Very good afternoon to everyone. Dear friends, first of all, very warm welcome to AIMS, and thank you for coming from all over India from various cities, which are, you have to travel quite a few distances, and so a very warm welcome and to this third postgraduate CME in bariatric surgery. A warm welcome to our faculty, again, who has traveled, and spared their valuable time from their busy schedule and to be a part of this important teaching activity. Now, why we hold this CME is that we realize that there is a scarcity of, knowledge or any well-established program in various medical colleges. And bariatric surgery is getting so popular and so, otherwise established as a standalone specialty that there's a large, gap in the curriculum of medical colleges where postgraduates don't have any orientation towards bariatric surgery. There are hardly any lectures, there are no operative procedures being done in these colleges. And so at AIMS, where our mandate is, part of our main mandate is teaching and training, and having a good, robust bariatric surgery program for more than a decade now, we thought we were in the right position to hold these CMEs to impart knowledge and fulfill this curriculum gap in the PG curriculum. The aim of this workshop is different from the international conferences we hold otherwise, we BARICON, which is our international conference, where we are looking at the latest developments in bariatric surgery and deliberations at a more complex level. Here we are trying to impart the basics of bariatric surgery so that all of you are aware what does it mean, which patients should we be operating. And there are so many myths about bariatric surgery. I mean, and even among doctors, you would have to believe me that so many patients come and they say, my doctor has said don't get it done, there are so many complications. So all these things, I think even if you don't plan to be a bariatric surgeon, this course will give you a very good insight into what bariatric surgery is, what procedures are, what are the type of patients who are eligible for bariatric surgery, how safe is bariatric surgery. So this is what the curriculum of the course is about, and this is a sort of a 2-day in a way, because we thought being winters we do not want to start early. So today we have the lectures on the basics, which cover the procedures, the evaluation of the patient and other parts, and tomorrow we have the live operative workshop where we will be demonstrating the basic procedures, the sleeve gastrectomy and the bypass, and hopefully the third one, the mini bypass, over the next day from OT. Again, I must thank my, introduce my team here. I think my team of who's organizing, Dr. Amardeep Kumar is a fellow, is finishing his fellowship in bariatric surgery at AIMS. Dr. Arun, he's just joined as a fellow. He's finished his senior residency. Again, all these are very senior people, but who are interested in bariatric surgery. Dr. Vitish Singla, who's the chief resident in our unit and a budding bariatric surgeon for sure. Has many publications with me, for over the last 6 years. Rachna Chaudhary, who's my coordinator and my secretary, who has been with us throughout our journey. Monita and Dr. Gurdeep from Dietetics, who are a very integral part of the team. Shelly and Sakshi, they are the psychologists, and again dietetics, they look after the overall workup of the patient. And our team of residents from Unit 2 who are really dedicated. Without them, we cannot run this program. So we have a very large team to help you, to guide you, and they're fairly knowledgeable in bariatric surgery. I'm sure you will find interaction with them very helpful. I have my fellows or who are now faculty at various medical colleges. It's a proud moment to have them here. So welcome, Amit, Aditya, Dr. Hemant Nautiyal from Dehradun and others. So I think we'll meet them in course of the day. So without wasting much time, I think we can start the first session, which will be, introduced by the comparer.
Thank you, sir. Now we invite our esteemed chairperson to take their seat, Professor Dr. Hemang Bhattacharya, Additional Professor, Department of Surgical Disciplines, AIIMS, New Delhi. We start our first session and I call upon Dr. Hemant Nautyal, Professor, Department of Surgery, Himalayan Institute of Medical Sciences, to present his topic on history and evolution of bariatric procedures.
I think we can ask Dr. Amit to join as a chairperson, Dr. Aditya to join as a chairperson. Meanwhile, I think our faculty from the department is traveling today, a lot of them. Dr. Hemang is here. Thank you, Hemang. And Dr. Amit and Dr. Aditya can join as a chairperson.
Good afternoon, everybody. First of all, I will like to thank Sandeep sir for inviting me to deliver this talk. And kudos to sir too and his team that this is the only program in India where it is meant for postgraduate students and senior residents. All other conferences have different purpose sometimes, but this is the only program, purely academic programs for the young budding surgeons. As sir said, there are some missing links in the curriculum. So, my topic is history and evolution of the bariatric surgery. Most of the time we never read the first chapter in the textbooks of this surgery. But last year once sir gave me this topic, I went through this topic and I found there is so much wisdom in the history and evolution of any procedure or any specialty that it becomes very easy to understand the topic. So objective of this talk today is to review the history and evolution, to understand how it has evolved and what we see today as the bariatric procedures as an established branch worldwide, and learn from our previous experiences, because there is a hidden treasure in these experiences. Otherwise you can end up doing the same mistakes which were done previously unknowingly. Just for our young colleagues, these are the standard bariatric procedures which we see accepted worldwide, that is gastric band-aid, not done very frequently in the selected cases only. Sleeve gastrectomy, the most commonly performed procedure worldwide, around 60% of the bariatric procedures are sleeve gastrectomy. Gastric bypass, which is a gold standard procedure. Every new procedure is compared with this procedure before it is accepted in the field of the bariatric surgery. And the last one is biliopancreatic diversion. It is just an atom bomb, the most strongest procedure with most of the complications, so done only in the revision surgery or for very select few cases. Other accepted procedures is the mini gastric bypass, also technically known as one anastomosis gastric bypass, very popular in Asian countries, still not accepted in United States of America due to some of the concerns. Sleeve gastrectomy with jejunal bypass, very common in China and Taiwan. Other procedures, biliopancreatic diversion, single anastomosis, duodenal bypass with sleeve. So we have lot of procedures. Why these were required when the disease is the same, and when you have to do this procedure, this will be discussed in the following lectures, but I will be going through the history of these procedures. So this is the IFSO data 2014, nearly 6 lakh bariatric surgeries are done worldwide every year. That is 2014 data, and out of this you will see 2.5 lakh surgeries are done in United States of America alone, with a population of around 33 crore people. So America has been the center of the evolution of the history of the bariatric surgery, and the most research is done in America, followed by Europe, and now it is done in Asian countries, especially Taiwan, and India is following it too. So you see here the sleeve is picking up since 2010 and it has become a most common procedure. RYGB is going down. This slide is not showing MGB. This is the ASMBS data of 2018. Sleeve picking up, RYGB coming down slightly. Mini gastric bypass is not accepted there, so they don't publish it. So why these procedures? Some procedure is going up and some is coming down is again a matter of interest, which will be dealt in the following lecture by other people. So this is a very famous saying by the Santayana, Spanish philosopher from Harvard University, who said, those who do not remember the past are condemned to repeat it. And these mistakes have been also repeated in the bariatric surgery also. So first mention of the obesity and the bariatric surgery you found in the 10th century literature, where a Spanish king, he has to lose his crown because he became so heavy. He could not pick his sword, he could not ride his horse. So he has to leave his throne, and his grandmother took him to a very famous Jewish doctor, Shatrup, who sutured his lips and put him on the herbal diet and only opium. He lost his weight and he regained his crown. So this is the first mention in the literature regarding the history of the bariatric surgery. So I think first bariatric surgery was the suturing of the lips so that you cannot take a solid food. Interestingly, how this surgery developed. At the end of the World War, in America when they won the war, Second World War, lot of the surgeons and physicians who were deputed at the front of the war, they came back to America, because lot of recruitment was done for the surgeons during the war due to the requirement at the trauma time. But when they came to the departments, respective departments, there was not enough work for them. So the main research started in the University of Minnesota, and these surgeons were shunted into the research laboratories that you do research on the GI topics or whatever you want, because you don't have a clinical work in the department. So John Liner was one of the famous experimental surgeons who came back from the Pacific Navy squad, and then he opened the department, and till 95 he worked on the bariatric surgery, and based on his principles we have many procedures still nowadays. So first literature mentions that V. Henriksson from Sweden, he did a small bowel resection in a patient, 32-year-old patient with obesity. And he found that after initial weight loss, the patient finally gained weight, but still the patient was happy. So this was the first mention that if you excise the bowel, you can reduce the weight, but the patient is going to regain the weight. So simple excision of the small bowel, that is by decreasing the absorption or introducing the malabsorption, is not sufficient to maintain a weight loss. This was the basis of the whole research for the bariatric surgery. Arnold Kremen, he did this research on 5 dogs in each group and did the different procedure, resecting the bowel, interposing the ileum and jejunum, and they found that all these dogs, they lost weight. But the interesting finding was that these dogs did not survive, they died of the malabsorption and the unknown reasons. But his conclusion was that 50 to 70% of the small bowel can be removed without apparent ill effects, and sacrifice of the distal 50% of the bowel produces most fat absorption associated weight loss. This was a conclusion from this study. So it was the first experimental study where obesity was researched. Then came the Pine, the very great surgeon who did the first documented surgery on the human being, that is jejunocolic bypass. He simply incised the jejunum and connected it to the colon, introducing a malabsorption in these patients. This is one of the few patients who became so slim after losing weight. And this procedure became gradually popular. The experimental surgeons started doing this jejunocolic bypass. This was the first established bariatric procedure. But this procedure had to be abandoned because there was intractable diarrhea, abdominal discomfort, electrolyte depletion, and very interesting finding which he found was the liver failure in these patients, which is still relevant in any bypass procedure if there is already a hepatosteatosis in these patients. So he was very meticulous in noting all down the complications, and the protocol was that you have to again, after the weight loss, you have to reverse the procedure. So when they reversed their procedures, they found all these patients, they regained their previous weight. So this was their results. And then Pine, he modified several of these surgeries, changing the length of the jejunocolic bypass, and then finally he ended up with a, in 1969, that is jejuno-ileal bypass. Instead of anastomosing jejunum to the colon, he anastomosed it to the distal ileum with a 14-inch of ileum and 4 inches of 14 inch of jejunum, 4 inches of ileum. And here is one of the patient who lost from 252 kgs to 86 kgs within 26 months. And this was his whole data of his career, where he could reduce the significant malnutrition complication in these bypass patients like vitamin B12 deficiencies, double cation deficiencies, hypoalbuminemia and all these things. But it is noted that his patients are having liver failure, migratory arthralgia and oxalate kidney stones. Picking up from the complications of his surgery, people modified the jejuno-ileal bypass because it was they postulated that the redundant closed bowel loop is responsible for overgrowth of the bacteria, which is leading to the liver failure and all these problems. So they anastomosed that redundant bowel sometimes to the colon, other surgeons anastomose it to the stomach, so that there is a continuity of the bowel loop to decrease the bacterial multiplication in this redundant bowel. Edward Masson was a very famous GI surgeon, and he was basically working on a duodenal and gastric ulcers at that time, as at that time PPIs were not available. So he was doing gastrectomies along with the gastrojejunostomy. He was separating the distal part of the stomach. But during his studies, he found that there was no benefit in the duodenal ulcer healing rate. But these of his patients, they lost significant amount of it. So from these findings, he became interested into the field of obesity and the bariatric surgery, and he started working on it. And this procedure became quite a popular procedure at that time, along with the jejunal-ileal bypass. But there was increased incidence of anastomotic ulcers and, of course, malnutrition in these patients. This is the first randomized trial conducted in the history of the bariatric surgery, where Griffin, he compared the Masson's gastric bypass with the jejunal-ileal bypass. But during his procedures, he found that Masson's bypass is difficult to take the jejunal loop here in the upper part of the stomach. So taking a cue from the Caesar Roux, who did it in 1887, all these surgeons didn't give thought to that procedure, and Griffin, he taking a cue from there, converted the Masson's gastrojejunostomy to Roux and Y jejunostomy, and he could reduce the incidence of anastomotic ulcer formation, as well as why surgery became easy, because it is easier to take the Roux limb above. Torres further modified this procedure, and he brought this gastric loop from the greater curvature to the gastric pouch from the greater curvature to the lesser curvature, and it named as a distal Roux and Y gastroileostomy, which was the basic foundation for the present day Roux and Y procedure. Another renegade surgeons, because when this branch started, the surgeons were not given OTs, they were not considered important because the patients had lot of complications. Mal Fovey, one of the famous United States surgeon who started his bariatric surgery in 1977, by 2000 he has done 7,000 procedures, and he also faced the criticism from the social media, society, physician and his surgeon colleagues, and he saw that in spite of these Roux and Y procedures, patient was gaining weight. So he applied a celastic ring around the anastomotic side so that this anastomosis does not dilate. And he gave a very hard-hitting statement that those who are educating that diet and exercise can reduce the weight are quacks. And soon he was followed by millions of dollars or lawsuits that what you are telling. But later on, it was proved that diet and exercise cannot control, these are not sufficient to control a morbid obesity. You need some surgical intervention. So this is the present Roux and Y gastric bypass, where we have a 30 ml pouch. These things will be discussed, so I am not going to detail. This is the standard procedure done now and how it has evolved. During the same time in the Europe, Scopinaro, another surgeon, was working on the bariatric surgery procedures. So he did distal gastrectomy. To reduce the anastomotic ulcers, he removed the distal stomach, and this biliopancreatic diversion surgery. But his patients had reduced ulcer, but still there was a problem of ulcer formation at the anastomotic side, and there was malnutrition. So Hess was another enthusiastic surgeon who and his son, they both followed the bariatric surgery, spent their whole life, and he modified his procedure. He said, why not remove this excess stomach from the greater curvature side and anastomose this ileum to the D1, so that there is no reflux of these biliary contents into the stomach to reduce the ulcer formation, because at that time only Rentec was present, PPIs came in 1988. So all these patients were suffering from peptic ulcer at the anastomotic side, leading to perforation, hemorrhage, and the patients were dying due to that. And this is one of his patients, 250 kg to 94 kg. But he has to quit his practice in 2005 due to around 3 crores rupees of lawsuits, and he quit his practice of bariatric surgery because there were still complications, lot of complications in these procedures, because these were all open surgeries. To reduce these complications, Gomes, Longus, they came up with the idea of only restriction. Let us only restrict the intake, and they came up with the idea of gastroplasty and lesser curvature gastroplasty. But these procedures were short-lived, and the patient used to gain weight after dilatation of this tube which they found by imbricating the stomach. Masson again, he invented vertical banded gastroplasty so that this does not dilate. He applied a mesh around this tube to restrict the dilatation of the opening. Going by the principle of restricted intake, Forsell and Kazumak, they introduced the adjustable gastric band, and then from these procedures finally led to the that is the sleeve gastrectomy. I will tell you the history here. The Rutledge, he came up with the mini gastric bypass, very upcoming and common procedure done nowadays. Anastomosis is single, easier to perform as compared to the Roux-en-Y with similar weight loss results and comorbidity resolution. Edward Mason was a never say die surgeon. He again came up with the idea in the low weight patients we can go for interposition of the ileum to reduce, control basically the diabetes and comorbidities. If the patient is low weight, instead of introducing a malnutrition, he came up with this idea, and ileal interposition is a specific procedure where you only want to control diabetes and other comorbidities without losing significant amount of weight. Talepur, he did laparoscopic gastroplication, just making the tube, restricting in principle. Major leap came in the laparoscopic surgery, and that was the reason why you see a bariatric surgery at this stage today. So laparoscopically gastric banding was done. Laparoscopically first vertical banded gastroplasty was done by D.S. Hess, and complication reduced significantly, mortality reduced from 1 to 2% to 0.2%, and this became acceptable to the patients, physicians and the media. Laparoscopic gastric Roux-en-Y bypass was done by Alan Whitgrove in 1994, and similarly in 1999 Michel Gagner did the first BPD laparoscopically, and that is the big benchmark, and it suddenly catapulted the bariatric surgery into the medical field. Sleeve gastrectomy was usually just done to reduce the mass of the parietal cell, and this became a standalone procedure after Michael McMahon. He was a young laparoscopic surgeon. Johnston, he was working with Professor Johnston, who was doing open vertical gastroplasties. So he said, let us do it laparoscopically. He took the help of Michael McMahon and he did the procedure laparoscopically, and finally he published his data as a sleeve gastrectomy with the comparable results to those bypass procedures. Then to reduce further the complications associated with the bypass, the concept of decreased intake, these balloons came. They were of polyurethane material, other plastic materials, but there were complications like hemorrhage, ulcer formation, so they were withdrawn within 5 years, and finally we have acceptable gastric balloons made of the silicone material. But they have to be removed after 1 year. You can maximally keep them for 1 year. You have to change these balloons, so it's still only for the selective patients you can do it. The new coming technologies are endoscopic bariatric procedures based on the principle of that is sleeve gastrectomy to imbricate the stomach so that there is reduced intake. But you see there no bypass mechanism is there, so they are not as good procedures as the bypass procedures in controlling the weight for a sustained period of time. Endoscopic bariatric procedure, sleeve gastroplasty is very famous, which we have to do in a selected patients, because finally these sleeves, they have a tendency to dilate, and only 14 to 19% excess weight loss is expected as compared to the bariatric procedures where you have a 70 to 80% excess weight loss after 5 years of the surgery. So in the conclusion, jejunal-ileal bypass by Pine was the first sustainable bariatric operation. RYGB is the result of efforts to reduce the risk and complication of the jejunal-ileal bypass. Lap surgery has become the standard of care. You cannot go for the bariatric surgery with the open technique, and current emphasis in bariatric surgery is towards reducing the adverse effects of surgery. Thank you.
But very comprehensively the entire evolution of bariatric surgery. As you have rightly said, initially we had few procedures which are commonly performed, starting from sleeve and Roux-en-Y gastric bypass, what is still the commonest procedure performed. But over a couple of last few years, we have seen too many new modifications in bariatric surgery. So whether it is one OAGB or SEDI or other procedures, there are several new emergent procedures in bariatric surgery. what do you think the impetus or driving force for new innovations on bariatric surgery? Is it the weight loss issues, or is it the nutritional issues, or it is the issue of metabolic benefits?
So why there are, it is said that there are around, if you go to the list of the bariatric procedures and its modified versions, there are around 28 to 30 procedures. Different universities, different surgeons are opting for different procedures with modifications. The basic principles are same, restriction and inducing a malabsorption. But the problem is that even with the procedure like Roux and Y, you have a regain of the weight in many of the patients. Even your diabetes comebacks, even your hypercholesteremia, it again rises after 5 to 7 years. So still the results are not 100% proof that you will get a lifelong benefit. Second thing, these are any bypass procedure is associated with some sort of complication. Complications in the sort of internal hernias, abdominal discomforts and malnutrition. Some patients, you have to go for reversal of these procedures. So still it is not accepted by the physicians and the society. Like you go for a gallbladder surgery, stone, okay, problem is solved forever. Cancer surgery, if done in early phases, very good results. But bariatric surgery is a readmission rate of around 15 to 20%. Once a patient undergoes a bariatric surgery, there is a readmission rate and revision surgeries are required. So that's why surgeons are innovating how to have less complications and good results. That is the reason for innovations. That's why we have different procedures. And procedure like SADIs, BPD, they are very, very strong procedures, and 98% of the patient, they get the benefit at 10 to 15 years, even after 10 to 15 years. But if the patient has, they may have suffered from complications of the surgery. So they are very, for the selected patient, that's why to know about the pros and cons of each procedure is very important. A particular procedure cannot be a solution for every patient. You have to choose your patient according to his eating habits, according to his psychology, according to his goals, what is the desire of the patient, what is the expertise of the surgeon, what is the backup for your team. So you have to very precisely choose a procedure. That's why there is a battery of procedures, and sometimes it becomes very confusing for the new surgeon which procedure to do for which patient. So that is the reason new procedures are evolving. Till we have a decreased complication, it becomes acceptable by the society.
Just put that thing in perspective. Yeah, can I put that thing in perspective?
Yes.
So just like, every day you have newer drugs for cancer, and not all of them become standard of care. So we have a lot of procedures which are coming up, but even now the standard of care is Roux and Y bypass, sleeve gastrectomy, and one anastomosis gastric bypass, and maybe lap band. So I think we should not go away with that. I think at this level, there are just 3 or 4 procedures for all of us actually, and for you, as a beginner, you should not get confused with the number of procedures which are there in the books or in the journals. I think one should right now focus on what is the standard of care, and the standard of care is a Roux and Y bypass, a sleeve gastrectomy, and one anastomosis gastric bypass. So just
Yes.
for that. They may not be, the newer procedures may not be better, I can tell you. So that's why the standard remains the old 50-year-old standard of Roux and Y bypass.
Yeah. Roux and Y is still the gold standard
Yeah,
for
yeah.
us. So if anybody of you have any questions to him?
Please let it be interactive. You are please free to ask questions, from the delegates, because that's what we want. That there's a good interaction with the faculty and the delegates.
I would like to raise a point. First of all, thank you, Professor Notial, for such a nice lecture covering comprehensively on the topic. And I would like to tell, for the benefit of the audience, that bariatric surgery has very short history. It's just 50, 60 years, but over the time it has come a long way. Initially, the surgical procedure very aggressive, so you could see malabsorption, patients dying of the surgery, and having bile reflux like in Mason's horizontal loop gastrojejunostomy. But these days, because the procedure converted into laparoscopy, the technology of the new staplers and new technology, safer anesthesia has come. And like sir said, sleeve gastrectomy, mini gastric, one anastomosis gastric bypass, and Roux and Y gastric bypass are the main procedures these days. And still the trend is going like sleeve gastrectomy is little coming down, and OAGB is coming up, Roux and Y gastric bypass is going down. There are some reasons for that which we will discuss further in the sessions. And there are specific criteria for each patient by the preoperative history, intraoperative, we do endoscopy, and then only we choose all these 3 procedures which is safest for the patient, and so that patient gets the best result after the surgery. So that's why bariatric surgery these days is as safe as any lap cholecystectomy or any laparoscopic procedures done these days. Thank you, Dr. Nutal.
Thank you.
So I would like to now invite Professor Sandeep Agarwal sir for his presentation on overview of bariatric and obesity and bariatric surgery.
Very good afternoon again, and thank you, Amit, for inviting me. I think what Dr. Hemant has told you, how it evolved over so many years. What some of us carry this opinion that bariatric surgery is something new. So it's not something new. It's there for a while. It's well established. The safety and the indication is well established, and whatever evolution that will have always happen in science, but that evolution is for good. So it's a field which is so well established now, and there are separate departments in various hospitals just focusing on bariatric and metabolic surgery. So again, I'm going to talk about, basically I'll give you a brief overview. This lecture was actually very long. I'm trying to put it in 15 minutes because that's what we have for us. So if you look at prevalence of obesity, this is again an old slide showing roughly about 50% prevalence in a city like Delhi, which was a while back, and obviously it has increased over time. And this is true for all metropolitan cities. This is true for all states with a very high per capita income like Kerala, Punjab, Goa, Delhi, and Gujarat. So there is a high prevalence of obesity in our country, and there's no doubt about it. Because sometimes when you go out, and when I went out in 2006 to US, that was a common question asked: do we have obesity in India? Everybody thinks India has a malnourished population, but we have a significant problem at our hand, and that's why we need to, all of us need to have an awareness about the magnitude of the problem. This was again an article, published last year, that although we are number one in underweight population, we're still among the top 5 in obesity. Because in terms of sheer volume, even if the percentage of obesity is about 5% compared to 30% in US, our population is so large that if we translate it into numbers, it's a huge number which needs bariatric surgery. So obesity is caused by long-term positive energy balance. This is just mathematics. It's not something genetic. There are few reasons, genetic reasons for obesity, but it's mainly related to what you eat and what you spend. And if you roughly have an increase by 2% every day in your energy intake versus expenditure, you gain about 2.3 kg in a year. So it's simple mathematics. A lot of patients would come to you and say, so I don't eat anything. How do I become obese? Is it genetic? Is it familial? But it's all plain mathematics, believe me. And obviously the change in lifestyle. All of us now have TVs which are run by remote. Your car windows are automatic now. The voice commands. You hardly have to move now. The lifestyle has become such that you can just do everything sitting in one office chair and with a computer in front of you. So that was about, so what are the therapeutic options? And everybody talks about this pyramid, and that diet, the people with overweight should be given diet and physical activity. It's cliche to say that. Why don't you start diet and physical activity, then pharmacotherapy, and then towards the end comes surgery. But I'm not a big believer in this pyramid if you are an eligible patient. If you have a BMI of 45, if you have 120 kg, I don't think there is any point in trying this pyramid very rigorously, and one can straight away jump to surgery after initial dietary modification. So look at it, when we say dieting, why don't you diet? Is it the answer? So if just to lose a half kg or 1 kg weight per week, you need to eat 500 to 1000 calories less every day of your life. And to go from a BMI of 40 to 25, you continue this for 1 to 2 years. You tell me how many of us can do that? Okay, and this is very difficult, and likelihood of success is very small. So chances of slimming to BMI less than 25 by diet alone is just roughly 3%. And then there's a yo-yo effect that those who lose weight regain. We have a number of patients who have come from various weight loss programs, have tried very expensive diets, keto diets. Some spiritual gurus have started some diets and all. but they all have spent a lot of money without achieving much. And this is the story of every patient. You come, they have tried everything. Again, impact of exercise. So if you run a mile, you spend about 100 calories. So just to lose, go from BMI 40 to 25, you would have to walk from London to New York and then run 5 marathons. So what I'm trying to emphasize is the improbability of these measures in an obese patient. I'm not talking about someone who has just got 5 kg extra, that he can lose it that way. But for a person who's like 120 kg, 140 kg, these are slightly impossible measures, okay? And maybe 1 in 1,000 may have a very strong willpower to follow this. So in nutshell, weight loss strategies are ineffective, like dieting and exercise, if BMI is more than 35. Drug therapy, there are more side effects than benefits. The amount of weight lost by drug therapy is about 5 to 10 kg, additional cost and a lot of complications. And going by the literature, in our own opinion, surgery is the most successful method of treating morbidly obese patient over a long period. And this is the target weight, which is required after a weight loss, this thing. So if you ask a 120 kg person to lose 10 kg, he's not going to achieve this target weight, which is going to affect his comorbidities. And this was the landmark consensus conference in '91 when the laparoscopy had just started. Even then, the consensus was that surgery is the only effective means of treating severe obesity on a long-term basis, and the dietary group regained all the weight over a period of 2 years. So again, when you say morbid obesity, there are various parameters, and BMI is one of them. And I hope you all know what BMI is, weight in kg divided by height in meter square. So roughly body mass index of more than 40 or 35 with associated diseases like type 2 diabetes, sleep apnea, NAFLD, PCOD, hypertension. So that's what morbid obesity group constitutes. Also, if you have roughly double your ideal weight or more than 50 kg of overweight. And so these are the general criteria for morbid obesity. However, for Asian Indians, because we have fat on our belly, which is more metabolically active, we like to use cutoffs which are slightly different, which are slightly lower than the Western cutoffs. So we might operate a patient of more than 30 to 32.5 BMI if they have diabetes. And indications are evolving because with the safety of surgery, laparoscopic surgery, we are more liberal in operating nowadays because problems of obesity are manifold. And these are the guidelines, were given by a group of medical people, and some of the surgeons, including me, were a part of this meeting, where it was decided to have an early intervention for prevention of type 2 diabetes and CVD. So and they defined obesity in a BMI more than 25. So a person with a 26 BMI had a class 1 obesity. So because physicians are worried because that any amount of obesity is harmful, they defined it in a different way and said the intervention should be done. So what we generally believe as obesity surgeons from India, that we should be operating at BMI more than 32.5 with diseases, and now with current literature it has gone down to 30, and BMI more than 37.5 without any comorbidity. And obviously, although there is no solid data for the above guidelines, and there are issues of risk or benefits, but I think if you ask most experienced surgeons, they would be happy to say this because we have seen the benefits. We've done, I think we discussed this, so although we say 18 to 25, 65, we also operate patients who are adolescents, who are less than 18 years, or who are more than 65 years if they are a good 65. We all know how with the evolution of healthcare, we are having people who are living longer, and patient may be quite metabolically okay at even 75 years of age, and they should not be refused surgery if they are not at very high risk of surgeries. And obviously these are the certain criteria, but as I said, if patient needs surgery, please recommend surgery, and don't ask him to run 6 kilometers every day to reduce weight. So that's very very difficult. And I think this part will be covered later on with in a lot of talks. I will skip this. So basically this discussion, again, I think my colleague will discuss in the next part. Some people say, why not plastic surgery? Why not abdominoplasty or a liposuction? And this is a photograph of a patient who had a abdominoplasty, and I have several more photographs showing a huge ugly scar running across the lower abdomen, and her weight never reduced. she was looking, she had a slightly lower flat tummy and that's it, and she was quite obese, diabetes, everything remained the same. And she spent a lot of money, a lot of morbidity, with the abdominoplasty, resting for 10 to 14 days, risk of pulmonary embolism. So this is not an option for weight loss. Please, okay, whenever patient asks you, tell them this is not a weight loss operation. This is just a cosmetic operation, maybe following weight loss or maybe, for a localized bulge somewhere, but not a weight loss operation. Again, and so I think Heman touched about safety, and that's one of the myths. I think even among physicians and surgeons and medical community, that's very unsafe as a surgery, so let's talk about safety. Sorry. So despite the well-documented beneficial outcomes, critics continue to question the safety of this treatment option. Okay, and it's often questioned from all of us, that patients have a lot of morbidity, and it's and the literature. If you go to Google, you may find just complications, and you may not be aware of the benefits. So when you say safety, we have to look at the problems of obesity. Obesity itself has a huge number of problems, including high mortality, the mortality and morbidity of surgery, the benefits of surgery, and the complications of surgery. So if you look at complications of obesity, we all are aware it affects from head to toe. Diabetes is probably the commonest comorbidity, or maybe not the commonest, in fact, NAFLD, which is slightly unknown. People are not even aware. Everybody says I have a little fatty liver, while they may have frank cirrhosis. So in our own series, we have 5% rate of undetected cirrhosis in bariatric surgery patients. Undetected, they were normal, liver functions are normal. Ultrasound says grade 1, 2, maybe 3 fatty liver. But that's one of the major comorbidities in patients with obesity. So it affects all the organs. The incidence of cancers, more than 10 to 12 types of cancers are higher in people with obesity. So when you have a talk to these patients, you must keep in mind the patients with obesity have a high rate of diseases, high rate of, these are the sort of livers we see, not very uncommon, I can tell you, so 5% is a big number, where, we're not even detecting thinking of cirrhosis. So, and obesity kills. That's the point. One should know that patients who have overweight and obesity have a life expectancy is reduced by 9 years compared to a similar, population. And if you look at the graph on the right, this risk reverts to normal after weight loss. And this has been proven in various studies that, if you are taking a weight loss treatment, and especially bariatric surgery, which causes good amount of weight loss, your risk of mortality returns to the normal population. I think this is a very important slide as far as when you consider the safety of bariatric surgery. And now what again was mentioned in passing, that the mortality of bariatric surgery is same as lap chole, and this is a data from JAMA, where the more than 15,000 patients, the mortality was 0.04% to 0.14%, and some of the centers of excellence less than that, even 0.0 something. So it is really low if the surgery is done in good centers, and compared to the cholecystectomy, which remains besides the biliary stricture and the bile duct injury, we are not even talking about it, which is permanent actually. Mortality of 0.3%, which is again comparable. So it's not a dangerous operation. You look at the operation, the blood loss is just 30 to 50 ml. Patient walks the same day. 4 hours you can make the patient run actually and goes home the second day. So the surgery recovery is similar. Obviously the caveat is you have to be doing in a good center. Look at CABG, death mortality of 1.7%, and other complications, a total significant complication rate of around 10%. So it is the safety is fairly well established. And look at the cost now of various procedures, and surgery turns out to be the most economical. And we haven't even accounted for the benefits in terms of cost reduction when you decrease the medications. If you ask any of my team members, they have seen patients who stop about 5 to 6 medicines within 3 months of surgery. Diabetes medications, other medications, and you look at the cost reduction in that term. So in terms of cost also is very cost effective. Benefits of surgery, as I said, the chance of mortality returns to normal, and this has been proven again in various studies, and this is a very good study when you look at the long-term results. 60% reduction in mortality from cancer, 92% reduction in mortality from diabetes, and again 56% reduction in mortality from coronary artery disease. So So look at the results now, look at the risk of obesity, safety of surgery, and then the results. This is the SOS trial, famous SOS trial, which has looked at longitudinally a large cohort of patients, more than 2,000 patients, where again the benefits in terms of weight loss are unmatchable. There's no comparison with other treatments. Showing again same in a graph, and I'll need 2 minutes more, please, that lifestyle modification has hardly any benefit. In fact, one of our dietitians, she did a PhD comparing supervised yoga program with surgery, again showing absolutely dismal results with lifestyle management in class 1 obese patients. So these has been our repeated experience with the literature again, that all these are things, and these are famous results published by Dr. Buchwald, showing how diabetes gets resolved in 70 to 80% patients. As resolved means within the same week, you discharge the patient without any medications. I don't know of any therapy which can do that. And impact seen after weight loss is due to hormonal changes, again, which have been well proven, and even in our studies we have shown that there are certain favorable hormonal changes which cause resolution of diabetes. Weight loss, which is 60 to 70% excess, and on an average weight loss in our own series about roughly 40 to 45 kg, more than 1,000 patients. So again, similar results in take any comorbidity, take this, take PCOD, take infertility, and we recently published on urinary incontinence, where a majority of patients were having incontinence and they were too ashamed to talk about it, and we studied them, showed very good results. This is the data analysis done by one of our postgraduates, Dr. Mehul is there. He showed again a very good impact on diabetes in our patient population, and been published in JMAS recently. So all these results are really very, very convincing. We have, as I said, we have shown the hormonal mechanism. The paper on the right looked at GLP-1, gastric emptying, and other mechanisms why diabetes gets resolved. And this is, I think, one of the most amazing things which we never thought of was, it's not our experience alone, it's the reversal of fibrosis and cirrhosis. So for initial, when we are started bariatric surgery, we were not thinking of cirrhosis reversal, but we have multiple studies. We have done biopsies of more than right now 300 patients, paired biopsies in roughly 60 to 70 patients. Paired means pre-surgery and post-surgery. And we have shown that in a significant number of patients, cirrhosis reverses. Grade 3 fibrosis reverses to fibrosis 1. And some of the patients, there's a total reversal. So the metabolic impact of surgery is so profound. And that's why, the need to create awareness about these positive effects of surgery. We have published on sleep apnea, again. So hypothyroidism, we are the first ones to actually publish on effect of bariatric surgery on hypothyroidism, showing a number of patients were off the drugs and a large number could reduce their medication. And the common myth that hypothyroidism leads to obesity is the other way around. Hypothyroidism may lead to a 1 or 2 or 4 kgs of weight gain, but not like 40 kg. So it's the other way around. When you gain 40 kg, you get hypothyroid. And that's how, this myth needs to be broken. Patient comes, I am hypothyroid, that's why I've gained weight. So this myth, we sort of broke. This is roughly our chart. Obviously, COVID brought a big halt to the number of surgeries. We're touching about 1,100 cases now. It's been a steady growth over the number of years, and we have been able to build a good team. We have a fellowship program in bariatric surgery, 2 years. Anybody who's completed 6 years of training are more than welcome to apply for our fellowship program. We have a fairly good hands-on, as our ex-fellows would testify, and they're all practicing bariatric surgery independently outside. We have a big team. We take care of patients over long term. We do not leave them and operate and leave them. That's a very essential part, is a long-term care of bariatric surgical patients. So these are the meetings we hold regularly and are attended very enthusiastically by the patients, because here they can discuss the minor problems with other patients. We reinforce the compliance of diet, exercise. We recruit yoga teachers and physical trainers who demonstrate yoga in these meetings. So all this creates positive vibes, and as a team that we are always available to take care of these patients. And so that's what we believe a good program should have. And you should go away with that impression that bariatric surgery is not just surgery, it's a whole program in itself. It needs a very dedicated team. And these are some of the photographs. I think all bariatric surgeons will show you. Patients are really happy. Majority of the patients would come and tell you that you have changed their lives, which is very gratifying. So, and then we bring about some public awareness newsletters. So I think it's a program where it's a very satisfying field of surgery, I must tell you. Having been through many fields of surgery as assistant professor and now over the last 12 years as a bariatric surgeon, it's a very, very gratifying field of surgery. And I encourage you to take it up if you are, looking at very challenging this thing. And also very stimulating as far you read about diabetes, you read about sleep apnea, NAFLD, which you as a surgeon sort of have forgotten. So it's a good combination of medicine, surgery, and as I said, teamwork, we need protocols, we need dedication, and that's what has good to good results. Thank you for your kind attention. Thank you. I'm sorry, I've overshot a little bit, but few questions, one or two questions I can take. Yeah, audible. Yeah. On kar lo usko.
Slightly off the top, maybe. Do you think it's time for sleeve gastrectomy to be called the standard of care now that more than 60% operations worldwide are being sleeve gastrectomy?
Yeah, I think so. I mean, obviously, it takes a lot of literature, and because sleeve is still new. Bypass is more than 50 years old, and it still gives very good results. Sleeve is something we have to prove now, and there are results being published, long-term especially. For everything to be efficacious, it has to be over long-term. So now only we are getting long-term results of sleeve, which are comparable to bypass. But then we have the problem Barrett's with the sleeve. So I think it will take another decade before we can have more long-term results with sleeve, or maybe maybe the next decade would be able to resolve that. But as of now, I would still say bypass remains the gold standard. Although 60% of the sleeve, and that's because of simplicity, not because of its efficacy, I would say that. I would welcome Professor Rajendra Prasad as a professor of surgery and a very senior surgical faculty in the Department of Surgical Disciplines, a very renowned GI, upper GI surgeon. And he also does bariatric surgery, and I'm really honored to have you, sir.
Thank you, sir, for the wonderful presentation on overview of obesity and bariatric surgery. As your fellow, I can tell that if you attend a follow-up OPD of a bariatric surgery, it is the most gratifying. Most of the patients are treated of diabetes, cured of diabetes, obstructive sleep apnea. They throw their CPAP out of their life, and they say they feel 10 years younger than before. After that, I would like to invite my colleague, Dr. Amardeep Kumar, for his presentation on patient counseling and perioperative workup.
Respected chairperson and good afternoon, my friend. So my topic for the discussion is patient counseling and pre-operative workup. So in 1948, World Health Organization recognized obesity as a disease. As Sandeep sir has told, obesity is associated with lots of comorbidities, starting from the diabetes, hypertension, vascular disease, gastroesophageal reflux disease, obstructive sleep apnea. There are many more. So we can say obesity is like a harbinger of disease. So obesity is measured through the many of the parameters like anthropometric and non-anthropometric parameters. Among the anthropometric parameters are the body mass index, skin fold thickness, and waist circumference, waist hip ratio. Among the non-anthropometric parameters are the densitometry, measurement of fat through CT and MRI. So, but the most commonly used parameters are the body mass index. which is most commonly used to define the obesity. According to the World Health Organization, the classification of obesity is defined as the class 1 obesity is the BMI is more than 30 up to 34.9. Class 2 obesity is the BMI 35 and up to 39.9, and class 3 obesity is BMI more than 40. It is also known as severe obesity or morbid obesity. The indication and the patients already has been discussed by the Sandeep sir, so I am just omitting this slide. This is the criteria for Asian selections. We are slightly keep the cutoff lower for the selection of Asian patient, because in Asian populations there are a lot of fat, which is mainly located on the abdomen. So we called as central obesity, and the central obesity are like more pathological. So the criteria is cut down lower for the Asian populations. So coming to the contraindication of bariatric surgery, there are some known contraindications, like if the patients are taking some, having the active substance abuse disorder, having the active psychiatric disorder, and the patient have limited intellectual capacity. This group of patients should be deferred for bariatric surgery, because this group of patients would not able to follow the post-operative advice, and this group of patients will landed into the complication and problem. And if there is a like contraindication to the general, it is obvious, and especially in the pregnancy and the female anticipating pregnancy within a year. So this group of patients should be deferred, because there are nutrition concern, because after bariatric surgery there are a lot of malabsorptions occurs, and generally the requirements of nutrition and minerals increases during the pregnancy. So there may be bad outcomes over the on the fetus, so it should be deferred. And if there is cirrhosis with the portal hypertension, especially child grade 2 and grade 3, this group of patients should be optimized before consideration for the surgery. So coming to the bariatric team is unlike the other departments. The bariatric team involves the multidisciplinary team approach. This team, the core member of this team was formed by the bariatric surgeon and his team, anesthesia and his team, bariatric nurse and bariatric physician, nutritionist. These are the core member. Other associated member that require the participation of the psychologist, endocrinologist, cardiologist, pulmonologist, and gastroenterologist, because there are a lot of comorbidities that need to be addressed before surgery, and patient taken only after the optimizations by the concerned department. So coming to the patient counseling part. So why counseling is the purpose of counseling is to set the realistic goals. So patient think that after bariatric they are going to be almost normal, but so their expectations are different. So we have to make them aware what they will achieve after bariatric surgery, and also the part of counseling to identify the risk factor, to assess the compliance level of the patient, to follow our advice after bariatric surgery, and their motivation level, how they are motivated for this surgery. And since the bariatric surgery causes a lot of behavioral changes in the diet, and that required a lifelong follow-up for the nutritional assessment and for other concern. So these things need to be discussed with the patient. So patient counseling is the key tool for the better patient outcome, and the purpose to make them understand the whole bariatric process. So apart from the patient, the family member and caretaker should be involved in the for the bariatric for the patient counseling, and as well as educating the patients about the all about the bariatric surgery and the procedures and regarding the complications. So the counseling should be done separately by the surgeon, dietitian, and psychologist. The role of surgeon is to discuss about the different surgical options available, their benefits, and related complications they might happen. So also need to be discussed about the perioperative process, need of preoperative optimization, about the dietary modification that is required prior to surgery and also after the surgery. And patient need to be like after losing weight, there is a real challenges arises to the patient to maintain that weight. So it is important to follow lifelong the dietary intervention, dietary advice, as well as the patient need to be like physically active. And since bariatric consists of malabsorptive procedure, so there is a need of bariatric supplement in the form of multivitamins, proteins need to be taken by the patient in the post-operative course, and they need to be followed lifelong. So the role, dietitian is the mainstay of bariatric program. So the role of dietitian is to make them understand about the food energy dynamics, and patient if they are patient before planning to the bariatric surgery, patient should be started on the pre-operative diet plan, like very low calorie diet plan. And the role of dietitian is also to discuss about the post-operative diet changes, various phases, like after surgery we start on the liquid diet, then we switch to the paste like that, then after that we allow the semi-solid diet, that we will discuss by our dietitian in detail. And also to discuss discussion about the what are the do's and don't about the diet. So counseling by the psychologist, the role of psychologist to assess the mental state of the patient, because the most of the obese patients having the component of some depression, anxiety disorder, and there is some behavioral issue, they need to be cited out and need to be addressed. And also to check for the compliance and motivation level of the patients, and to assess the support system, because it has been seen that if the patients having a good support system in the form of friend and family, they have get the better result, and they land up into the complications. So behavioral issues like eating disorder and sedentary lifestyle need to be addressed before planning of surgery. And after post surgery, the patient has to go through the lifestyle changes and behavioral changes that need to be discussed in detail by the psychologist. Coming to the history taking part, so the history taking start with the basic preliminary details. We record some anthropometric parameters like weight, height, BMI. Patient has to be asked for the progression of weight gain, because the weight gain could be of patient has regained weight in the short-term basis or maybe in the long-term basis. That need to be especially asked, and if the patient has already taken any weight loss attempt, either it could be the supervised or unsupervised, and also assess the activity level. So eating disorder is very common in the bariatric obese group of patients. Its incidence lies about around 30%, and binging, purging, grazing, night eating, this type of abnormal eating behavior has seen in this group of patients. So already I have told the comorbidity related to obesity there are a number of comorbidities. So each comorbidity need to be especially asked from the patients, and what treatment they are getting for that medical problem should be noted down. And according to that, because this comorbidity we help us in deciding which procedure we are going to offer that patient. And in the personal history, specifically, patient should ask for about are they a smoker or they are alcohol drinker or not, because if they are taking alcohol regularly, they should abstain the alcohol, because the taking alcohol is the relative contraindication. And continuing smoking, at least we want at least patient stop smoking at least 2 weeks prior to the surgery, because in this smoker it has been seen that the smoking causes a lot of complications, especially in the bypass cases. We got there is increased chances of marginal ulcer. So other point, the history about the family should be asked if there is a familial tendency of obesity or not. So this is the long list of the causes that causes that is the secondary cause of obesity. Few hours, the secondary cause could be due to hypothyroidism, Cushing syndrome, hypothalamic obesity, female taking oral contraceptive pills, pregnancy. Some patient is on some medications like for antidepressant, tricyclic antidepressant, that causes the weight gain. So this particular secondary causes of obesity should be searched for, but unfortunately this represent only minority of obese cases. So, and you will get the short history of weight gain, and this secondary cause is totally reversible when we address that, when we find out what is the reason behind that. Coming to the physical examinations, the measurement of neck circumference is important. It is indicative of if the neck circumference is more than 40 centimeters, indicative of the patient may have component of obstructive sleep apnea. And waist hip already talk, we can like determine about the which type of obesity patient is suffering from. Either it could be like central or peripheral. Limbs should be assessed for edema and varicosities, and on abdominal examination we have to search for the previous scar, ventral hernia, and sign of any venous hypertension. So this is the battery of long list of pre-operative work of investigation. Apart from the blood routine hemogram, we advise patient, we assess patient for advising for the bone profile, coagulation profile, diabetic profile, lipid and thyroid profile. And especially in this bariatric patient, generally they suffer from some nutritional issue. Also, the chances of nutritional issue raises after surgery. So the common nutritional problem encountered in such group of patients is between B12 deficiency, folate deficiency, between D3 and iron profile. So this would be checked before surgery, and under the radiological investigations, the ultrasound should be done to assess the conditions of liver, because there are high incidence of non-alcoholic fatty liver disease. It around more than 50% you will find in the morbidly obese group of patients, and also to rule out any component of portal hypertension. And there is a there is increased frequency of gallstone disease when compared with the normal general population. That should be checked for. Under the cardiac, we should have to advise for ECG and 2D echo. Respiratory evaluation should be done through PFT and sleep study. Sleep study generally routinely not done, but on the case-to-case basis, we can advise the patient. Sleep study is an important part because most of the patient have some degree of obstructive sleep apnea component. In the gastrointestinal examination, we evaluate through upper GI endoscopy and fibroscan. Fibroscan is the measure of liver stiffness. Is also measure the component of how much cirrhosis is present. So the evaluation of cardiovascular system, we know that diabetes, hypertension, dyslipidemia, and OSA increases is the significant risk factor for the cardiovascular disease. And in the obese population, there is increase in the sympathetic tone, feeling pressure, workload, that increases the risk of myocardial infarction, ischemic heart disease, and sudden cardiac death. So a detailed medical history and family history is important regarding the cardiovascular system. And if needed, stress tests and coronary angiography should be done on case-to-case basis. Evaluation of respiratory system, the physiological changes occurred in the obese individuals are there are decreased compliance of chest wall and the lung parenchyma, as well as increased bronchial vascular resistance that causes the reduction in the gas exchange and the mismatch of ventilation perfusion ratio. The two most important problems we need to discuss regarding this. One is the obstructive sleep apnea. Second is obesity-related malignant hypoventilation syndrome. The incidence of obstructive sleep apnea is around 74% in morbidly obese patient, and if untreated, that lead to hypoxemia and hypercarbia, further into pulmonary hypertension and pre-state cardiac arrhythmia. And even and also during the anesthesia, when the narcotic medicine has been given, they blunt the protective arousal of the hypoxic patient, and they may lead to the profound hypoxia and respiratory arrest. So for definition of obesity-related malignant hypoventilation syndrome is when PuCO2 is more than 45 and the oxygen saturation is less than 94 without oxygen supplementation. This condition increases the risk of prolonged intubation, tracheostomy, and death. So extent of pulmonary involvement should be assessed in detail. Evaluation of upper GI system, generally it has been seen that on upper GI endoscopy, the chances of abnormal finding is found to be around 10%. So it is important to, if in endoscopy there is a infection by the H. pylori, it need to be eradicated, because H. pylori infection is a risk factor for gastric malignancy. And in some group of patients, if there is a family history of gastrointestinal neoplasm, a routine endoscopy should be advised for such group of patient. And upper GI endoscopy also give the opportunity to detect hiatal hernia, there is high incidence of hiatal hernia in this obese group of patients, around 33%, that alter the choice of surgery in the decision making. In the bypass procedure, generally we resect the stomach, the remnant stomach become inaccessible. So it is a good idea to see inside of the stomach before planning bariatric surgery. Coming to the perioperative, that will be discussed by our dietitians. In roughly, generally we advise 2 week, at least 2 week of 1 to 2 week of preoperative very low calorie diet. The purpose of this BLCD diet, we want patient to lose around 5 to 6 kg of weight, because by losing such weight, that reduces shrink the liver, and that makes we will get the more area to operate in the upper part of abdomen, and also it increases the overall physiological compliance of the patient. And lastly, we want to discuss about the consent form. Generally, I advise you to take the umbrella consent mentioning all the 3 primary procedure, because many times if you are like planning for the malabsorption procedure and during intraoperative we found the liver to be cirrhotic, then you might require to change the type of procedure. You might require to like bypass, you convert the bypass, go for sleeve gastrectomy. And high risk consent should be taken, especially if after pre-operative optimization, if anesthesia people say there is a risk of ICU stay or prolonged, in such cases high risk consent should be taken, generally not required. So I would like to conclude my topic that bariatric surgery is a team approach, and patients will be taken for surgery after detailed clinical history, thorough clinical evaluation, adequate preoperative workup and optimization. Stabilizing such a team is the key to the success, and preoperative weight loss should be strongly encouraged. Thank you very much.
Thank you, Dr. Ahmadi, for nicely covered preoperative workup of bariatric patients. For the benefit of the audience, could you just elaborate on how the comorbidities will affect the choice of the procedure?
Yeah, thanks. Thanks, Dr. Aditya, for asking this question. So definitely, generally, it has been seen that there are 3 primary procedures: bypass, Roux-en-Y gastric bypass, sleeve gastrectomy, and the mini gastric bypass. So the sleeve is the restrictive, and other 2 are the more malabsorptive than obstructive. It has been seen that in initial reports that in the metabolic, if the patient with obesity having metabolic component like diabetes, hypertension, dyslipidemia, then in such group of patient, the like bypass procedure holds good for the resolutions of this comorbidity. Secondly, if patient has cirrhosis, then obviously the bypass procedure will may precede the liver failure. So in this situation, sleeve would be the good options. And in the extreme of ages, especially elderly patient, we are expecting the survival could be like around 10 years, 15 years. So it is better to go for simplest procedure, that is a sleeve one. And there are a lot of criteria to like choose, if the patient having the super obesity, like BMI more than 50, then we want to aid a more morbid procedure like mini gastric bypass. Our preference remains in such cases. So there are many criteria. Even in like if patient having like GI anomaly, we like some dextro torsion of intestine. If you don't know where the intestine is going, so it in this case it is advisable not to do any bypass procedure. Is to do the simpler sleeve procedure. Thank you.
Just like to add that GERD is a very important body selection.
Yes.
Patient has severe acidity or erosive esophagitis or endoscopy, we prefer to do a Roux-en-Y bypass. So that's what to add to what Dr. Ahmadi said.
Yeah. Thank you, sir.
A colleague recently asked me, how do you assess whether a patient is motivated for bariatric surgery? So do you like take that question?
We can check that's why there is we advise patient to follow the pre-operative BLCD diet. There is one way. If the patient, we advise for the weight reduction, if patient is strictly religiously following the BLCD diet therapy strictly for the 2 week, it means patient is like showing they are showing motivations. Obviously they are serious about bariatric surgery. And other things, obviously if the patient is compliance is good, if compliance is good, then we can consider patient is motivated.
Compliance, you can assess compliance only when the patient comes to you multiple times.
So I always ask the patient, have you come on your own, that you want the surgery, or your father or wife or is pushing you for surgery? Because then it's a totally different situation. So that's again a strongest indicator the patient is motivated. I think surgeon is the best assessor. Besides obviously a formal dietary and psychological evaluation, by experience you can make out after, and you need to spend time with the patient. It's not that you quickly note down and do like a checklist. You have to talk to the patient, show empathy, avoid body shaming. Even if the patient doesn't want surgery, respective views. And that's, you are the best person to assess how motivated the patient is, besides these things. So I would say with experience it comes, you can assess it.
Yeah, Dr. Amardeep? Yeah, Dr. Hemant.
Yes, doctor.
Yeah. The patients, as you said, the alcohol intake and smokers, ideally they should quit before they undergo bariatric surgery. Even after bariatric surgery, they should not smoke or start. But it is easier said than done, and more than 80 to 70% of the patients, they refuse. I am not going to quit. I am ready for the surgery, but I am not going to quit. I may reduce it. They will say, yes, I will try to reduce it. So what is your policy at
Look, I will differ from you. Patient will not, have to leave all the pleasures in life if you want to go bariatric surgery.
Yeah,
If that alcohol in moderate amounts is okay even after bariatric surgery, obviously it is everything in moderation. We have to warn them that it maybe really hit them very fast, because the gastric emptying goes very fast. So a small amount of alcohol may hit them, but they should be obviously in moderation. And obviously patient who has a bad liver will say, okay, stop it. But patient with a grade 1 liver who's lost 40 kg, I would say go ahead, use your discretion and common sense to drink them. But obviously smoking is the worst thing. Smoking should be stopped. But as far as alcohol is concerned, I would be a little more liberal about it.
Or you would like to go for specific like sleeve gastric? Those patients as compared to bypass.
For alcohol? Yeah. Depends on the state of the liver and trop.
Smokers also. Because at least
Smoker, yes.
you can view the
Smoker, yes, we'd prefer to do a sleeve who can't leave. For alcoholic people, not alcoholic, I don't want to use the word, people who take alcohol, and a lot of us do take in parties and all that, it will depend on the state of the liver. If the liver looks bad, there's evidence of grade 3 fibrosis on biopsy or overall, then I would say stop alcohol for good of it. But in general, if you tell people, then you don't want to take, want to have a patient have a good quality of life at the end of it. Dr. Arush, last question, because then we'll...
the basic question is that a lot of, like where I'm sitting, I'm in Delhi, Delhi 5, there are a lot of people coming for basically शराब भी पीनी है, नॉन-वेज भी खाना है, ठीक है, दिल्ली 6 के let us not name, but they all are coming कि जी हमें निहारी और ये सब नहीं छोड़ना. पंजाबी are coming कि जी हमें रात को बटर चिकन खाना है और साथ में 2 पैक दारू पीनी है.
You have to counsel them. Look, otherwise...
Counseled, everything counseled.
Yeah, let them
what is your surgical procedure of choice?
No, it will avoid surgery in such patients, but having said that, if they want surgery, and you know how taste changes, we are all aware how taste buds change. They may change. You never know. So I think let's start the next session.
Who knows better than me?
With this, we come to the end of session 1. I thank the chairpersons for looking over this session. Now we begin with session 2. I invite the chairpersons of session 2, Dr. Rajendra Prasad, Professor and Head Unit 3, Department of Surgical Disciplines, AIIMS, New Delhi; Dr. Aris Abarwal, Professor, Founder and Chairman, Surgical Center for Obesity and Diabetes, New Delhi; Dr. Wasim Firoz Khan, Assistant Professor, Department of General Surgery, AIIMS, Bhopal; and Dr. Devender Singh, Assistant Professor, Department of General Surgery, ESIC Medical College, Faridabad. Thank you, sir.
Conferences going on all over India, so faculty is traveling all over. So after the initial commitment, people are just sent out.
We have all the speakers. Excuse me? Do we have all the speakers? Okay, fine. So we start this very important session whereby we have 3 very eminent speakers. The first one is Dr. Vivek Bindal. Everybody knows him, and he's going to be speaking to you about robotics in bariatric surgery. Okay, so this session starts with the first talk by Dr. Vivek Bindal, who's going to be speaking to us about robotics in bariatric surgery. And Dr. Vivek Bindal is a well-known personality. Everybody knows him. So,
thank you so much, sir, for the kind words, and thank you, Dr. Sandeep Agarwal and the team at AIMS for inviting me in this August gathering in this hall after so many years because of this COVID gap. It is such a nice pleasure to come over and a privilege to be at this institution talking about the field of bariatric and robotic surgery, which is so close to our heart. So I bring greetings from Max Hospitals. This is our team. So basically, when we talk about robots, many people say, things like robots are too expensive, they are too big, they can cause complications, they can cause problems. And the same things were said about automobiles and aeroplanes 100 years back. But today, we drive and we fly to each and every destination every other day. And that is how technology takes over. So you must have seen the Da Vinci system. I'd just like you to, think about robotic as a concept, what robotic surgery is. So whenever you do open or laparoscopic surgery, the surgeon and patient are intimately related to each other. They are standing by the side. Now what robotic surgery does, it actually creates this digital interface in between the surgeon and the patient. So what that means is that whatever the surgeon is seeing is basically through this digital interface. So whatever input the surgeon is getting from the patient is through this digital interface, which amplifies it, which is able to give you a three-dimensional high-definition magnified view. You can integrate intraoperative Doppler, you can integrate preoperative CT, MR into that image on that console using TilePro imaging. So the input is augmented. You can use ICG fluorescence, which is again augmented. And the output from the surgeon's hand to the patient is again through this digital interface. And so my hand movement is refined. If I have a tremor, that is taken away. If my hand is moving by 5 centimeters, the tip of instrument is just moving by 1 centimeter. So that translation of motion is better at the end of the instrument tip. And this digital interface is in its infancy right now. This is where the progress is going on, and this is the power of robotics, where artificial intelligence and so many now newer things are coming up with new systems also. So this is the concept of robotic surgery. Let us not just discuss about a particular system which you may have seen. So that is why I was looking at this slide. Now this is a video we shot in University of Illinois at Chicago when I was a fellow. The newly joined residents of surgery were asked to peel a grape on the left side using laparoscopic scissors, on the right side using robotic system. They did not have any experience in either of them, and you can see how the tremors are amplified and how they are able to do a more ragged thing using laparoscopy as compared to robotic surgery, where the same surgeon without experience is able to do a better job. So people who are experienced laparoscopic surgeons, it may not make a difference to them when they switch to robotics in terms of clinical outcomes, but for people who are still learning, it makes a difference in the clinical outcomes. The current clinical use is just tip of iceberg. This is the Da Vinci XI system, which is the most commonly used robotic system across the world in this date. It has modular arms, and it has a boom mounted system with a mobile platform with 4-quadrant access. So earlier the SI system had shorter instruments and we had to redock, especially in RYGB, which was a multi-quadrant surgery mostly. Now with XI system we are able to do it in a single docking in a better, in a more refined way. And the laser targeting system is there for docking, which makes it easy. For a person to learn docking in SI was more difficult as compared to XI. There are newer tools. The new energy devices, the advanced bipolar is very nice with robot, which is the kind of vessel sealer. Also the endo-wristed stapler, which has now come up with robotic surgery, allows the surgeon from the console to fire the staplers and to control it, as compared to the earlier days, or I would say very recent till very recently when we had to fire the staplers, by the assistant had to fire the staplers while the surgeon was at the console. So the articulated staplers by Intuitive, they are also having the ability to judge the tissue thickness and to fire it according to the whether, and they can actually tell the surgeon that you are not using the right color cartridge for that particular tissue. This is the endocystoid vessel sealer, which again is a good device which when we use in robotic surgery. Simulator is there. So we have done robotic bariatric and robotic abdominal wall reconstructions for last 10 years now. But why do we need actually robotic surgery? You know, the lifestyle has become such that even for fitness centers we are taking escalators, and what is happening is we are getting super obese. Population is getting super and super obese. Our average BMI actually in bariatrics, what we have assessed over last 10 years is around 52, which is, you know, more and more super obese are coming in, and they have huge liver, limited working space. There is excessive torque on instruments. The abdominal walls are very thick. These are the kind of abdominal walls whom we deal with, and the torque is immense. The rich and poor people alike have these kind of abdominal walls. Young kids, 15-year kid, 60 BMI, his brother was again 120 kilograms, who was 12 years. This lady came with severe sleep apnea and actually obesity hypoventilation. She had CO2 narcosis, had to be put on ventilator, 85 BMI. Again another 82 BMI. So all these patients require, something which takes away the torque, something which allows you to do the same procedure as you do it in a 40-45 BMI patient, and that is where the robotic system comes in. So this is how the robotic ports have been placed for a gastric bypass. The camera port comes in from the left of midline, pretty much similar to what we do in a laparoscopic setting. 2 robotic arms come from left side of the patient, 1 robotic arm comes from the right side of the patient. And we do a totally hand-sewn gastrojejunostomy. In laparoscopy, most of the times we do stapled GJ, either with a circular or linear stapler, but here we do a 4-layered hand-sewn GJ. And these are absorbable sutures which go away within a month. So there is nothing remaining there. So there has been evidence to show that even if the staples are inert, at the GJ, in long run there is a higher chance of stricture ulcer rate with the staples being there as compared to a totally hand-sewn anastomosis, in which the sutures melt away. So this is how the patient looks like after port is placed and after the robot is docked. These are the procedures we have done. This is a video of robotic RYGB. This is so we basically make it a unique quadrant surgery. Now first part is laparoscopic to measure the bowel and to hitch the bowel. So basically here we have hitched the bowel at 100 centimeters from the DJ flexure to the stomach with 2 sutures. So this, once you dock the robo, you get a magnified view. You can actually measure lesser amount of bowel. So what may seem as 100 would be 50. So we have hitched the bowel, and again we have measured another 125 centimeters for the roux limb, and then we have marked 2 sutures. Once we have hitched the bowel, then we dock the robotic system, and here we are going by perigastric technique to create the gastric pouch first. We do a modified Lonroth way of RYGB, wherein we would create the gastric pouch first, followed by a loop gastrojejunostomy, and then we would divide the jejunum. So these are the laparoscopic staplers, the powered staplers which are being used to create the gastric pouch. The robotic instruments actually help you, dissect around the hiatus. So this is a barbed 3-0 suture, which is going to make the 4th layer of gastrojejunostomy. And here we are incorporating the staple line on the stomach side and the seromuscular stitch on the jejunum side. So this cardiac forceps on my left hand would also allow me to throw stitches as a needle holder. I don't need to use two needle holders. Then we do a gastrotomy and an enterotomy, and now we extend it using the harmonic scalpel. So this harmonic in robot is not articulated, while the vessel sealer is articulated. So one can use vessel sealer as well. We typically make an opening of 2 centimeters for this anastomosis, and then we take another 30 barbed suture, which is going to complete the third and the second layer of gastrojejunostomy. So this we start from across the corner so that the corner is secured well. Then we will come inside the opening and we will suture the posterior layer. So this is a super obese patient, but even then you are able to suture as if, it does not matter at this stage whether the patient is 40 BMI or 60 BMI, because the robot is taking away the torque. Now we have reached the right sided corner, and then we are making, so these throws are very difficult in laparoscopy, wherein you have to reverse throw the needle, and these are done with precision in robotic surgery. So after this anastomosis is done, then we divide the bowel here. So once the bowel is divided, that loop becomes a Roux-en-Y configuration, and then we do the jejunostomy, wherein we do a 60 millimeter stapled JJ, the jejunostomy, yes, and then suture close it using another barbed suture, and then the mesenteric defects are closed, both the JJ as well as the Peterson defect. We always do an endoscopy at the end to check. So this is another revision case wherein this lady had a vertical banded gastroplasty. She presented with dysphagia. She was one of the first bariatric cases of India. She had this open VBG done in Pune by an American surgeon, and in VBG there is a mesh kept around the outlet. There is a narrow outlet on the lesser curve, and that is what was the problem. She was operated twice after that. Surgeons tried to remove the mesh but could not. So here we did a conversion to normal anatomy. So even the Nathanson cannot be placed here because the stomach is densely adherent to the lesser curvature side of stomach because of the mesh. So here we are separating the liver, and this is the kind of adhesiolisis where robot is going to help you with better visualization and better angulation. We are able to separate the liver from the stomach in a much better way and able to identify the anatomy. Once the anatomy is identified, then it becomes a pretty simple case wherein we need to open the VBG pouch and then connect the remnant stomach with the VBG pouch. So this is the area of VBG pouch here. And this robotic scissor is a wonderful instrument, more so used in abdominal wall reconstructions than bariatric, but whenever you use it, you will find the angle and the precision to be much better than any other instrument. So what we have done is we have opened the VBG pouch, and from where you can see the gastric calibration tube. So, and there was a septum. So this is the septum here, and here is the remnant stomach. On the lesser curvature side, the narrow outlet is seen, and we are disconnecting the septum. So after disconnecting the septum, the remnant stomach gets connected to the VBG pouch, and then we suture close the gastrotomy. And this lady has been doing very well over last many years now. This is a patient who had a gastric band followed by a sleeve, 2 revisions done, still 50 BMI. 2011 a band was done, 2012 a sleeve was done, and still 48 BMI. So we did a SADI using a robotic system that involves a duodenal ileostomy. I'll just skip to the area of duodenal dissection. So this again is a difficult area to dissect. We take care not to injure the gastroduodenal artery, and the angulation of robotic instruments would help us make that retroduodenal tunnel. which has been created here. Now we would divide the first part of duodenum using the stapler, and then we do a duodenal-ileostomy. So this anastomosis is pretty much similar to what we did in a gastric bypass, and we use 3 Vlog sutures to create 4 layers of duodenal-ileostomy. So this is the posteriormost layer, and then after gastrotomy we create 4 more layers, and then we complete it. In the interest of time, I'll just not show many videos. These are our publications on robot gastric bypass in 200 cases in obesity surgery, robotic Roux-en-Y bypass as reoperative bariatric procedure again in obesity surgery. This is a review article which shows that robotic in bariatric surgery is safe and feasible, especially in super obese and revisions. Yeah, so I also have a chapter on robotic RYGB in Sage's Atlas of Robotic Surgery. Robotic stapling has made things much better. I think in the interest of time, I'll just, ICG fluorescence is now available in laparoscopy also. It's a wonderful tool to assess vascularity. Just a small video to show how the stomach is looking vascular. On normal, it was all pink. But here, once you inject ICG, you can see that this portion of stomach is all green, while this portion is not green. So this is the line of demarcation where the vascularity is gone. And once you again switch back to normal light, you cannot make out the difference between the upper portion and the lower portion. So this is where the utility can be to prevent a leak because of ischemia. A lot of future applications, augmented reality, warnings can come in real time. It is already happening. It can memorize the surgeon's moves as well. Telepresence can be there. So this is how the OR of future may look like. I think in summary, robotic bariatric surgery is safe, feasible and effective. It helps overcome difficulties encountered in super obese. Ergonomic comfort to surgeon with ease of suturing even in super obese is one of the high points of this. The ease and precision of gastrojejunostomy or stipple line imbrication is an advantage. And you should always start with a simpler procedure. When you are starting with robotic surgery, you will break sutures, you will have problems. So maybe start with robotic sleeves. And as AIMS also has it, robotic surgery training should be inculcated in residency and fellowship programs. With so many new robotic systems coming up, there is a lot of interest around it. We are doing a FALS course in robotic surgery from December 17 to 19 in the Leela at Delhi. So those of you who are interested in robotic surgery, you will be able to experience the intuitive Medtronic as well as the CMR system hands-on there for the first time in any conference. So you are invited. Thank you so much for your kind attention.
Stimulating talk. Now the house is open for any questions.
Thank you, sir. Sir, apart from super obese patients, are there any other situations where you would prefer to do a robotic bariatric surgery over laparoscopy?
Yeah, very good question. I think RYGBs is one of the places where I prefer robotic because you are able to do a better hand-skin anastomosis. Although expert laparoscopic surgeons are able to do it laparoscopic also, the hand-skin anastomosis, but I think in my hands robotic is better. Also in revisions, robotic is better. Apart from that, it becomes a patient's choice. So many patients would come to me if I have done a super obese patient by a robotic method. He sends another patient who is not super obese, who is 42 BMI. They would come and ask for robotic only. They would not settle for laparoscopy. So that is how our practice goes, and the only difference is cost. So the non-inferiority has been established. The only downside is added cost, which is not a matter to a lot of patients. In fact, majority of bariatric patients are not concerned about 1.25 lakhs extra which we charge for robot. So they say even if there is a slightest advantage, we are ready to pay for it.
Dr. Bindal, here I differ because although I'm also trained with robotics, but unfortunately we don't have a robo over there. And by and large, where I'm sitting, we have patients who are catering to every penny that they earn. maybe it's just because of where I'm sitting, where I'm doing, but I personally also feel that revisional surgery, yes, robo has a chance. Robo definitely takes it over. When it comes to regular sleeve, RYGP, MGP, I really doubt. I really have to be, convinced for me to spend an extra lakh or lakh and a half rupees for a robo just because for the surgeon's ease of mind. Now, this is where I personally feel it's a selling gimmick. Being in Max, Medanta and everywhere, or AIMS is free. Now, people who come to AIMS do not come to you. People who come to me do not come to AIMS.
No, yeah, I think you're right. See, Dr. Subramanian is pretty right. For an expert laparoscopic surgeon, it may not make sense to switch to robotics. If he is happy with his practice, his outcomes, it is fine. But we have to look at a bigger aspect, and there was a lot of debate about technology when laparoscopy came in. If you talk about laparoscopic inguinal hernia repairs, there is still no evidence to suggest that it is better than Liechtenstein repair. But all of us are doing laparoscopic repairs, and we opt for our own laparoscopic repair. We don't say that do a Liechtenstein repair. Although it is more expensive, it requires more instrumentation, and that expense has gone down with time significantly. Now with newer systems coming in, you can, with a CMR system, there is hardly any added cost to the patient. And there are both subsets of patients. So there are patients who would be very, very, conscious about money, and they would definitely opt for laparoscopy, which you are anyways doing. But there is another subset of patients. So as we see, people drive Maruti 800 and Mercedes. Arush will do a chartered plane. We will go in economy class. That does not, make us more distant.
I think this lecture was basically to stimulate the postgraduates and all into the possibilities, because that's what is the future. And there's a lot of debate. I would strongly disagree with Dr. Arush. Whatever. So it's not a selling gimmick. It's definitely a lot of advantages, and you talk to surgeons who have been doing both. So let's stop the debate here and let's proceed on with the.
I agree about the advantages. There's no doubt.
Sir, one question. Okay.
Thank you, sir. Thank you so much. Thank you, sir.
And we can't just wish it away. So be open to it. I mean, try it out. If it works for you, fine. If the circumstances don't allow, it's fine. And now we go on to the next topic, and I would request Dr. Sabharwal to please invite the next speaker.
So the next topic is how safe is bariatric surgery. It is by Dr. Manoj Handley. Hi, sir.
Hi, sir.
Yeah, I bring greetings from my department in Lady Hardinge Medical College, and I take this opportunity to thank Dr. Sandeep, who has helped us in initiating bariatric program at our place. And now it's almost 3.5 years, and we are past 150 cases. So the topic assigned to me today is how safe is bariatric surgery. I think Dr. Sandeep has included some slides in his talk showing some statistics. So I may be repeating some of these. So it usually, when any patient goes for any surgical procedure, there is a safety concern. Bariatric surgery provides us a valid treatment option. The surgical treatment of obesity developed from observing patients who have lost weight after gastric or small bowel resections, most prominently jejunal bypass. It was somehow where in 94 that Whitgrove et al. Performed the first laparoscopic gastric bypass. And since then, majority of these patients have a good weight loss, low complications compared to open procedures. Laparoscopic procedures have been replicated at various centers with low complication and good results. And recent advances in minimal invasive surgery and introduction of newer laparoscopic instruments have contributed a great in reducing operative time, length of hospital stay, and less complications. And there has been development in bariatric surgeries which have been exceptional in last decade. And there has been a dramatic increase in the number of procedures which have been performed world over in different centers. Now, bariatric procedures can be performed with operative morbidity mortality which is no greater than what we see in laparoscopic cholecystectomy. But we need to know certain procedure specific related complications which must be taken into account. All minimal invasive procedures in morbid obese patients are technically demanding. They require stapling, anastomosis, resection, handling of stomach, small bowel. There have been impressive effects on comorbid conditions as well, which I'll shortly talk about, which have prompted the adoption of this minimal invasive bariatric procedures into the field of metabolic surgeries as well. Now, benefits are unquestionable. However, as I have already told, we need to know some complications associated with individual procedures. As compared to about 10 years back, complications have decreased about tenfold. There has been technological advancements, surgeon experience have increased, center experience have increased, there have been establishment of pathways, care protocols, quality initiatives. All of these have reduced the complications. But most severe complications even today in bariatric procedures are seen in those patients who have some extreme degree of OSA, previous history of DVTs and extremes of age and smokers. So one has to be careful when we consider bariatric procedure in these patients. Complications like wound infections, dehydrations, they are much less common. Anastomotic leaks following bariatric procedures, incidence is hardly 1.5 to 6%, which is comparable to the bowel anastomotic leak in other laparoscopic procedures and in colorectal surgeries. Intermediate and long-term complications, which includes intestinal obstruction, marginal ulcers, ventral hernias and gallstones, may be seen with bariatric procedures, but they are either avoidable, preventable or easily managed. Metabolic complications, again like nephrolithiasis, hypoglycemias, can be managed with dietary protocols. Same applies to micronutrient and vitamin deficiencies. Now, these are, as you all know, the commonly done procedures, out of which sleeve and RYGB, and they are probably one of the most commonest procedures done. Sleeve is probably the most favorite bariatric procedures, and advantages are ease of technical ease and easy learning curve for surgeons, shorter duration surgery, and it can be performed in certain patients with high risk medical comorbidities. Pylorus is preserved, less risk of malabsorption. It may be performed as a first step for super obese patients, and it may be used as a bridge to RYGB or one anastomosis gastric bypass. It produces effective weight loss, and improvement of obesity is seen in related conditions. But disadvantages with LSG would be that non-reversible. Immediate complications which are seen with LSG are also seen with other bariatric procedures, but they can be, with experience, one can get over these complications like bleeding from resected margins of stomach, short gastric vessels bleeding, splenic, liver, diaphragmatic injuries. These are all listed because these have been reported by various surgeons in the history. Early complications, again like port site hernias, volvulus of stomach, abscesses, deep vein thrombosis, pulmonary embolism, all of us follow a certain protocol like prophylaxis for DVT and all those things, which has definitely contributed drastic reduction in the incidence of these complications. Now, late complications, again like weight regain may be seen following sleeve, lesser impact on metabolism compared to bypass procedures, strictures of remnant stomach, nutrient deficiencies and GERD. Again, one has to be careful while one faces these complications. Now, as far as RYGB is concerned, again it is one of the most commonly performed bariatric procedures, and its advantages are that it is more refined, standardized technique. It produces a reliable and long-lasting weight loss, especially in super obese patients. It more predictable weight loss outcomes than pure restrictive procedures. Metabolic changes resulting from this surgery means most patients have an almost immediate reduction in their need for diabetic medications, and some are able to completely stop diabetic medication altogether. This has, RYGB has probably the strongest effect controlling the hypertension and hyperlipidemias and other medical comorbidities. Now, the disadvantage with RYGB is again some of the complications which we do see with most of these procedures. Only thing, it is technically slightly more complex. Bleeding from margins, resected margins can occur, internal herniation and obstruction can occur, anastomotic leaks can occur, may cause dumping syndrome. As far as DVT and pulmonary embolism are concerned, most of us are already following DVT prophylaxis protocols in our centers. Late complications like weight regain, anastomotic strictures, gallstones, again, they are avoidable. As far as this laparoscopic adjustable gastric banding is concerned, this procedure only advantage is that it is less invasive and stomach is neither cut or crushed by staples. There are no anastomosis, but it has more of disadvantages to it. That may be associated with perforation, gastroesophageal perforation, improper band positioning, early post-operative slippage, band slippage requiring repositioning, and so on. It may be associated with significant failure to lose weight and rather maintain weight. So long-term ineffectiveness of this procedure and its high reoperation rates has resulted in a drastic decrease in these surgeries from approximately 42% to 18% of all bariatric procedures. Now, as far as laparoscopic biliopancreatic divergence with duodenal switch is concerned, again, this shows good weight loss compared with other contemporary procedures. However, this procedure is also associated with high rates of complications for both technical and malabsorptive reasons. And it has slightly higher mortality rates compared with other bariatric procedures. And long-term complaints like diarrhea, abdominal bloating, malodorous flatus, stools, risk of liver failure with prolonged malnutrition may be associated with these procedures. So here the patients may require intensive nutritional supplementation post-operatively and comprehensive monitoring of their nutritional status for probably the rest of their lives. As far as one anastomosis gastric bypass is concerned, again it is proposed as a simpler and more efficient weight reducing surgery. It has short operating time, low complication rates, excellent weight loss. These are all the advantages which we see with this procedure. Somehow retrospective studies suggest that weight loss is probably superior with OAGB than with sleeve gastrectomy. And however, the complications associated with this procedure again are quite similar to what we see in others. Late complications like stomal stenosis, marginal ulcers, malabsorption, iron deficiencies, again can be managed easily. Now, this is something which has come up recently, the endoscopic sleeve gastroplasty. This procedure is done via sutures placed through an endoscope. It is a restrictive procedure leading to weight loss. Long-term weight loss is comparable here to other laparoscopic procedures. It may be the option for patients who are not suitable or for rather unwilling to undergo laparoscopic procedures. It has no incisions, no scars, no stomach is removed, no anastomosis. Patient can return to normal activity soon. Minimal blood loss, there is hardly no requirement for blood transfusions. But disadvantages again would be that we need an experience and specialization of the executing endoscopist who is required. It is not recommended for super obese patients. It is contraindicated in those who have associated large hiatus hernias, who have active GI bleed and active peptic ulceration. Since it is a relatively newer procedure, we need long-term studies to address its safety and its efficacy. Now, as far as the data is concerned, it is said that RYGB is probably associated with complication rate of around 3.02%. LSG is slightly less, 2.12%. And mortality rates from various bariatric surgical procedures taken together is of the tune of 0.03 to 0.2%. But high-risk bariatric patients, what exactly do we mean by high-risk bariatric patients? Means those who are super obese, BMI more than 60 or 70, associated with these comorbidities like diabetes, hypertension, OSA, liver cirrhosis, they have probably a higher risk of these complications. Perioperative mortality has substantially improved in last 20 years. Now, if we talk of the effect of bariatric surgery on the comorbidities, we see that, I have tried to keep it very simple and basic, that better outcomes are seen than medical treatment for short-term remission and glycemic control of diabetes. It also leads to a decrease in risk of microvascular and macrovascular complications associated with diabetes. As far as dyslipidemias are concerned, the high levels of LDL, triglycerides, low levels of HDL, they show short-term improvements after bariatric surgery, that is within first 1 to 2 years of surgery. These changes are higher or better with RYGB than LSG. Hypertension, about 68% of patients who are morbidly obese who come for surgery, about 68% have hypertension, and 1 year remission rates of up to 80% are seen as far as controlling or decreasing the drug requirement for hypertension is concerned. Again, it is better seen with RYGB compared to LSG. 5-year changes, however, are similar in 2 procedures. Now, as far as sleep apnea is concerned, apnea hypopnea index, a score of 5 events per hour is normal, less than 5 events, and more than 30 events we consider as severe. And various studies have documented significant reductions in BMI and sleep apnea hypopnea index following bariatric surgeries. Osteoarthritis, again, we have seen improvements in knee pain and functional status in first 6 to 12 months after bariatric surgery. Urinary incontinence is again one association with some patients with morbid obesity, and it has been shown that 1 year after surgery the prevalence of urinary incontinence is much lower. Now, obesity associated with increase of certain malignancies like postmenopausal breast cancer, endometrial cancers, colonic, liver, pancreatic and ovarian cancers this is a known fact. And bariatric surgeries have shown to reduce the risk of all these types of cancers. Now, long-term weight, when we talk of long-term weight loss, results in greater long-term weight loss are much better than or as compared to non-surgical interventions regardless of the procedure which we are doing. Now, each procedure, bariatric procedure, has its own pros and cons, and various surgical techniques currently available for significant long-lasting weight in morbidly obese patients. The life expectancy improves in many of these patients, as does their general health, and enhancing the patient's quality of life. Despite its risk, bariatric surgery is nowadays widely recommended in obese patients. And with refinements in surgical skill and technological advancement, bariatric surgery is comparable or even less than routine laparoscopic surgeries. Intra and post-operative anesthetic complications better managed by the intensivists by treating their comorbidities, and most of us have this anti-thrombolytic prophylaxis started in these patients. Now, introduction of latest powered cartridge guns, stapling guns, ensure adequate safety of anastomotic site. I believe there is another talk on the newer instrumentation used for bariatric procedures. Now, post-operative malnutrition is nicely managed with supplements and regular follow-up of patients. Stomal stenosis could be converted, if it happens, it can be converted to other bariatric procedures, endoscopic or endoscopic balloon dilatations. Dumping syndrome, again seen in gastric bypass, can be managed with dietary modifications. Internal hernias, port site herniations can be prevented by proper closure of internal defects. Counseling of patients with lifestyle changes, dietary modifications, physical activity, it all ensures long-term weight loss. Now, the main goal of bariatric surgery is to manage weight loss and associated comorbidities. Despite risk, it is still a boon for morbidly obese patients. Risk-benefit ratio exceeds the advantages the patient achieves. Likelihood of complications in bariatric surgery compared to other routine lap surgeries is less. But long-term study and further skill development will further improve the safety profile in bariatric procedures. Now, numerous studies have shown mostly the short-term safety of bariatric procedures. There are very few studies which address the outcome of bariatric surgeries beyond 5 years follow-up. So, short-term assessment of safety primarily focuses on perioperative mortality, which we already know is less than 0.2%. And serious adverse events within 30 to 90 days like venous thromboembolism, hemorrhage, staple line leak or anastomotic leak, the incidence is less than 6%. Reoperations and readmissions are of the tune of 0.5 to 3%. Now, modern bariatric procedures thereby have strong evidence of efficacy and safety. Patients with severe obesity, especially those with comorbidities like diabetes, they should be involved in decision making, conversations about the risks and benefits of surgery compared with continuing medical and lifestyle treatments. So I think I have just tried to convey my thoughts and some literature which definitely no doubt proves that bariatric surgery is there to stay and it is a safe procedure. So a myth amongst laymen and even a lot of our medical colleagues that it is dangerous to go for a bariatric procedure, I think that those days are gone. So thank you very much. Thank you.
I think I totally agree with you, sir, and I mean, thank you for a wonderful presentation. But the only thing is that, you know, is basically taking me back is sleeve gastrectomy is not an irreversible procedure. It's a self-reversible procedure. You will gain weight back. So, proper patient counseling that you said is absolutely must. Because post sleeve gastrectomy, patients tend to gain weight back for sure. I mean, yeah, unless they are counseled well.
Definitely.
Any questions from the audience? Because we want your active participation. Otherwise, I think we also, as speakers, feel we are not talking to some. Yeah, please. You can come to the mic. You can just put on the mic with the. Yeah, just take the seat and talk.
If both sleeve gastrectomy and root are giving the same results at the end of 5 years, why we are not advocating on sleeve gastrectomy mostly?
See, as I have shown in some of these slides, as far as the comorbidities is concerned, most of the literature shows that probably RYGB is giving better results as far as control of diabetes, glycemic controls, hypertension, hyperlipidemias.
That is for short term, but at the end of 5 years.
Well, I believe what Dr. Sandeep said, that sleeve does produce the similar effect, short term effects. We don't know about long term, more than 5 years or 10 years, what will happen. But yes, the ease of doing sleeve, the time taken to do sleeve, that makes it more popular. But as far as the results are concerned, I believe everything goes more in favor of RYGB.
I mean, a question will be always debated in all bariatric conferences. This is the only question debated at all the coffee breaks. So there's no answer to that. It's the patient who dictates. Patient wants sleeve, we do sleeve because we tell them both are equivalent, as you said. And that's why it's so popular. 60% of global procedures are sleeve.
That is the handicap which we face.
It's the patient who dictates the procedure ultimately, you see. So what we can say is, yes, they are equivalent. RYGB is a bit superior for diabetes and for GERD. That's all we can say. And there we can say, tell the patient, no, get this done. But otherwise, we leave it to the patient that these are equivalent, and you can choose anyone. And that's why ultimately.
See, a major handicap which we face is collecting the data beyond 5 years. I think most of the patients, they stop coming to you after 5 years or 10 years. So we don't really know what is happening after that. So that is a big challenge.
And secondly, like, you know, according to our practice, I avoid giving restricted procedures to any non-vegetarian patient. But that's only me, that is none of the...
It's
because of various malabsorptive procedures that is coming up, and malabsorption cannot be per se, you know, I mean, if you're a vegetarian patient, you will not be having so much of proteins. So avoid RYGB or MGB at that per se. Prefer to do him a sleeve gastrectomy. And if the patient is non-vegetarian, I prefer to do a RYGB or MGB, you know, per se.
I think that would be a personal opinion.
That's a very
because
personal,
I think nothing suggests
personal.
that RYGB is actually a mainly restrictive procedure than malabsorptive. There were certain things like these were practices which are practiced by a lot of surgeons, what Dr. Aruj says. But now it's clear that, you know, if you're having a careful dietary follow-up and we can give adequate protein even in a vegetarian diet, RYGB is not contraindicated in vegetarian patients, and actually our program does not take that into consideration. Although yes, it's a point which is not absolutely wrong. Right. I think we can go on to the now. Next talk.
Thank you very much.
May I now invite my colleague Dr. Arun Sharma, who will speak on stapler instrumentation and equipment in bariatric surgery.
Thank you, respected chairpersons, and very welcome to all the delegates and the faculty. So my talk is on staplers, instrumentation and equipment in bariatric surgery. And in this talk, I'd like to talk to start with equipments and some special instruments. Before coming on to staplers, as I know that staplers are indispensable in GI, even in thoracic surgery in today's world. And in staplers, I'd like to talk about the types and how to choose one, their biomechanics, and then few contentious issues of pre-compression time and the staple line reinforcement. Before coming on to the newer technology in the form of tri-staple technology, and briefly talking on powered and robotic staplers, as Vivek sir has previously covered it in this session only. So as far as equipments are concerned, as we know, majority of our patients who come to us in OPD, they are not only big on weight, but they are big on size as well. So, and they come with the complaints that they have, they have the metabolic derangements and like diabetes and OSA. So they readily admit that. But when it comes to hypertension or blood pressure, so probably because of inaccurate cuff size and the measurement outside, so they have this, that doctor, sometimes we have like high blood pressure, but we do hardly take medications or on and off. So I think it's somewhere related to the like inappropriate cuff size. So we do have these extra large BP cuff size for our patients, so we start monitoring them with these when they are admitted, and even we recommend to get their BP measurement with adequate cuff size. So as I said, that they are not only big on weight but big on size and burly. So we have they are burly as well. So we have these specialized trolleys which are sturdy enough to carry weight even up to 350 pounds, and with side railings, so that to prevent them from any inadvertent harm. So same goes with the OT table as well. We have a specialized OT table which can carry weight up to 350 pounds, and with extensions like foot plates, side reinforcements, and cushioned belts and straps, so as to secure our patient to OT table at their arms, lower abdomen, thighs and legs, as you can see in this video. So in this video, so how a properly secured patient can be put in a steep reverse tenderloin position, which helps the small ball and the momentum to fall below, so as the surgeon can focus on the area of interest if in case of sleeve gastrectomy, and the position obviously can be reversed if you want to do an anastomosis, a small ball can come up. Another equipment I'd like to mention about is the DVT pump. Because of the deranged metabolic component, majority of these patients are at high risk of deviant thrombosis and embolism. So we have our patients make like customized compression stockings and DVT pumps with their customized cuffs, so as to, and they secure these cuffs, and once the patient is secured to OT table, so we put the DVT cuffs on and start the DVT pre-operatively as well, like once they are induced, and it will continue as long as the patients are ambulatory in immediate post-op before discharge. As far as instruments are concerned, they are all routine lab instruments, but here I'd say the length matters. And as we know that routine lab instruments are of the size of around 37 centimeter, but here even 6 centimeter of extra length will help us, especially in patients who are burly, super obese, to reach to hiatus or to the other extent. And beside these, we need extra long pores, 15 centimeter, to go across the thickened abdominal wall. Then the rest of the instruments are routine same instrument, but again the length is somewhat which matters. Talking about some special instruments, I'd like to talk about a golden finger retractor, which can be introduced through a 5mm port, and again it has a single hand operation, very handy to use, comes with different tips. The one we have a L type of hook, and it helps us especially while doing the dissection near the fundus, especially in those patients who have a redundant fundus. So to have a smooth staple line, it helps in identifying that, and also where the spleen is large and densely adhered to the fundus or the cardia. So pretty handy instrument there. Other forms are like half ring and full ring shapes are also available. This helps in retraction of lever as well. One instrument I would like to talk about, I will say not special but indispensable in bariatric surgery, is Nathanson lever retractor. So it has a As you can see in the video, I'll talk about this again, but it has a horizontal limb which can be secured to the table, and then a vertical limb and then a horizontal limb, and then the Nathanson hook. So what we do, we at the epigastric port site, we first introduce a 5 mm trocar to create a tunnel, so that we place the hook through that and lift the liver. So as a form of some studies and even a routine pre-operative, we do liver biopsy, and even once the liver is retracted, the left lobe is retracted up, it takes care of that minor ooze from liver as well. Another handy instrument, or usually I say, is endostitch. It is an automatic needle passer, and it's pretty handy and useful, especially in RYGB for the closure of mesenteric and the Peterson defects, as well as in hiatal hernia repair. The suture we use is available with is a polyester non-absorbable suture with a 9 mm taper cut needle. Coming to the hemostatic or ligature clips, we all use these during our routine lab coolies as fasteners or ligatures. But in bariatric surgery, we found it pretty useful while checking the ooze for the staple line and to secure that ooze. So they come with different materials. What we use is a titanium or nitinol based clips here. Biodegradable magnesium alloy clips are also available in different sizes, and they have that groove inside to help them secure at the oozing site, and we find it pretty helpful in our set of patients to control that bleed or ooze for any ooze from the staple line. As far as coming to staplers, so as far as history is concerned, they are there from last more than a century or no, but since the advent of laparoscopic surgery around 30-35 years back, they have seen drastic improvement. But as I said about bariatric staplers in bariatric surgery, I would say bariatric surgery is kind of a prototype for endostapling, because although it's important, staple line integrity is important any kind of surgery, but it's leaking or leaking staple line or staple line with hemorrhage in obese patients with a big abdominal wall, you might not get signs of acute abdomen immediately. Sometimes patients show very subtle signs of tachycardia, and if you have inappropriate cuff size of BP, your BP apparatus, so you might not be able to pick hypotension immediately. So those patients, for those patients, you must be very well aware of your stapler devices, and you must be aware of some able to fix some kind of troubleshooting as well. So this is briefly about the history, and as we know broadly, they have their advantages, whether you argue or not, but they help us in reducing total operating times. They have their less tissue manipulation, so less tissue trauma, and they help us in reaching out to difficult areas, whether it's a narrow pelvis or close to hiatus. And then studies have proven that they are as reliable and heal as rapidly as sutured anastomosis. So definitely there are numerous types of staplers, but for the sake of time and constraint, and especially for bariatric surgery, I'd like to restrict myself to endolinear cutting stapler, which do come with some kind of articulation ranging from 30 to 45 degrees. And before that, you must be aware of what is an ideal staple formation. So we all knew that they have a crown and then open limb length, and when this open limb length hit the anvil, they bend inwards and form a closed B-shaped configuration. So this is the ideal configuration which one should aim for, although not in control all the time, but then you have to pick and choose your tissues and the patients, and where to choose which staple height and these 8 illustrations can very well depict that these are can be considered close to the well-formed staples, whereas anything like these 8 can be considered as malformed staples, and then it can be because of either tissue characteristic or stapler characteristic, like such as tissue thickness or viscosity, then the staple height or other staple properties like thickness and bending characteristics, and the type of metal as well. So different brands comes with different color-coded staple heights, and they came with the preset of open and close height, so you can choose carefully, and you should be aware of these. So the brand you are using should be aware what is open and close height of that particular stapler, and only then you'll be able to use that on your particular tissue which you are going to cut. And it's important because appropriate hemostasis and tissue apposition without significant ischemia or tissue destruction can cause this tissue destruction. So too high staple line may inadequately oppose the tissue, can cause leakage, bleeding, dehiscence, and if it's too low or tight, it can cause ischemia or necrosis, serosal shearing or cheese wiring we can say, and leakage as well. So coming to a very important topic or part of my talk is biomechanics. So this holds true in all kind of surgeries, GI surgery, GI surgery especially, because you have to be aware of your biomechanics of the your device as well as the tissue you are going to cut or divide. As different tissues in the body vary in thickness and they vary because of age, gender, the organ, the system involved, the anatomical structure, or if there is any pathology or subtle pathology. So again, that can change the dynamics. As we know, tissue has a biphasic nature and they are both variable, whether it's a liquid or solid component, and their intrinsic biochemical properties as well, whether it's a protein content or the metabolic profile, they again vary. And of course, extrinsic blood supply is again variable. And then these bands come with stapler reloads which are indicated for specific closed staple height, and then tissue we know has to be compressed to the same height. As also know that the choice of staple height also determines the amount of compression imported upon your tissue. So when the staple is closed and fired, so that is important. So you are importing that amount of energy to the tissue. So you should be very well aware of that height. As far as the pre-compression time is concerned, again it is a duration between the closure of the jaws of the stapler and the firing of the stapler. And optimal stapling is important to achieve an adequate tissue compression so as to as it decreases the fluid in the tissue, allows its elongation, which allows a smooth firing of instrument, and to achieve a consistent staple line formation. As it's evident from this study on experimental stomach tissue, they found that optimal formation rates were 52.7% for 5 minutes compared to around 28% for 1 minute. So regardless of thickness, increased optimal formation is achieved in 5-minute pre-compression time. So I said the contentious issues because 5-minute compression before each fire is somewhat we hardly see in real practice. So usually advocate a pre-compression time of 30 to 40 seconds is at least required. And another contentious issue of staple line reinforcement, you can see from this meta-analysis published in Obesity Surgery in 2015, as around 44% of patients hasn't been underwent any reinforcement of staple line, and then others went on fibrin glue or other sealants, followed by suture overseeing and buttressing with bovine pericardium. So it's a large study with 253 articles included and patient sample size of around 98,000 patients, and they concluded that staple line reinforcement provides superior results for patients compared to no reinforcement for reducing the staple line complications, and that buttressing with bovine pericardium resulted in the most favorable outcomes. Although there are many other trials and even studies which have proven that they have advantage as far as bleeding is concerned, but leak rates are not that it's not that beneficial. But this meta-analysis proves that it has beneficial in especially bovine pericardium in the leak rate as well. Coming to another important nanotechnology, although it's there for almost a decade now, the tri-staple technology, what they did is that they provided a stepped cartridge phase so as to deliver the graduated compression and so as to optimize the interaction between tissue and stapler. So you can see on this insert that within the close to cut line, the staple height is small. So here is something we want more hemostasis. As you go away from the cut line, the staple height increases, so as to generate less stress during compression and clamping on the tissue, and which may allow greater perfusion into the staple line and provides better performance even with variable thickness. So in this study on experimental animals, they found that when compared the tri-staple technology with the universal green conventional staple, and also they practiced the slow firing group in one of the arms, 2 minutes of waiting followed by 6 minutes of firing. So they found that more secure staple formation was with tri-staple reloads than with the universal green load. Although there's another finding on slow firing, they found that there is enhanced secure staple formation, or it's more with universal green loads than the tri-staple reloads. And in thick tissues, tri-staple forms exceptionally well compared to the universal loads. Just briefly on power staplers, they have their clear advantage over manual staplers in providing greater stability and less tissue trauma because of less manipulation is required. Although personally I have used ones and found it slightly heavier side because of probably the battery, and that is another disadvantage because they are slightly expensive and single use because of the battery. But then some staplers do come in the market with the replaceable batteries. Lastly, briefly on as Vivek sir has already covered, but on robotic stapler, this is a new technology in the form of show form introduced with the Da Vinci, which has a smart fire technology with and it measures take 1,000 plus measurements per second, so as to monitor tissue compression before and during firing, to make automatic adjustments to optimize the staple line. And also it has a 120-degree articulation, so gives the surgeon to freedom to approach the tissue where it naturally lies, thereby reducing the need to pull it towards the stapler, thereby having the least distal tip deviation, causing least sharing of the tissue compared to the other endo-GI staplers. So talking about some of the pitfalls, although a sarcasm kind of thing, that they can't compensate for your deficiencies in surgical technique, they can't overcome deficiencies in factors such as rough handling of tissues, anastomosis under tension, or ischemic anastomosis. But a true pitfall of stapling is the migratory cross staples. So once you fire a stapler, just do look at the end of that staple line for any migratory cross sample, because they can cause the misfiring of your next stapler. So you have to remove that before firing the next one. Last, coming to practice, take to practice message, choosing an appropriate size staple cartridge of utmost important, and you must know when which size to choose for which kind of tissue you are going to staple and cut. And important thing, as I said earlier, understanding your role of your stapling devices, their biomechanics, and some sort of troubleshooting as well, that will be handy, and the tissue interaction with those stapling devices. And also allow for adequate duration of compression time, if not 5 minutes or 6 minutes, but at least 30 to 40 seconds before firing each fire. And always check for integrity and vascularity of the staple line, and if there is any ooze, you can use various forms of reinforcement, and removing the migratory cross samples, if any, before next firing. Thank you.
I think it's a fabulous talk, sir.
Thank you, sir. Thank you, sir.
Really.
So we have an inauguration starting at 4.
Any
Okay, then we can.
any question anybody is to ask, please.
Thank you, Arun, for a wonderful presentation.
Thank you, sir.
I would like to ask one question. What is the recommendation for the size of the staplers for sleeve gastrectomy?
Yeah, so for if you are doing a sleeve, and first stapler file is close to antrum or close to pylorus. So obviously, if we go from esophagus to stomach to the pylorus, the thickness increases. So for thicker tissue near the pylorus, obviously I will recommend a firing stapler of either a black with a close staple height of around 2.5 mm, and then subsequently as you go proximal, you can go with the staple height of lesser, like golden or a blue, or as you go proximally. So as proximal to cardia or fundus, even a blue cartridge will do. So if I require 6 or 7 staplers to complete my sleeve for my patient, so I'll first fire probably if the tissue is, I'll obviously assess the tissue at the pylorus and the antrum. So first fire is view of black, then followed by 1 or 2 golden, and then blue. I hope I answered. Yeah.
So
No.
Fire green anywhere in the picture. First black, then golden, then.
So it's color coding. Some doesn't, instead of green, some.
So I think what you are talking about is the Covidian staplers, right? Because Ethicon staplers have a green, blue, and.
No, sir, they do have a black as well.
No, black also, but.
Covidian. With Covidian.
Yes, sir.
No, but that's a tri-stapler, sir. That's a tri-stapler. That's different technology altogether.
Actually, now staplers are made by more than 2 companies. So
it's like
colored, tri-stapler purple is made by Covidian as well as I think Merrill.
Merrill and even these guys, Panther guys are coming up.
Yeah. So it's a multiple companies. Let's not talk about brands right now.
Yes, sir.
But one thing before you go to that, what do you do, Dr. Sandeep? You are using black for a first cartridge? Always?
Black, actually, if you look at Vishal Gagne's paper, even that is inadequate. If you look at his paper, experimental study, where he says whatever stapler you're using, the length of the is inadequate if you look at the experimental studies. But we find black adequate. But having said that, I've seen people firing different sorts. People firing purple right from the first cartridge, people firing white at the top. So again, as I said, I think it all depends on this thing. There's not much difference. Yes, we have to keep in mind at least vary from antrum to the top.
I agree.
You may
I
start from
agree with
green,
Dr. Singh.
end up in blue, or you may start with a purple, end up in tan. So I think it all depends on where you get trained and you use what.
No. But I agree with Dr. Sandeep that black is acceptable for the first firing, and I would use it on an African patient if I have any. But when the first firing, usually what I do is a green, but many times I do a black, undoubtedly. Mostly I do a GJ with a white stapler, like he was just commenting on the stapler. But many times if it's a thick tissue, then I might do it with a blue stapler. So everything really differs intraoperative.
And I think we'll have a lot of discussions tomorrow in the operative workshop. I think he has a question.
I wanted to ask that other than ease of use and speed, is there any consensus regarding hand-sewn versus stapler in anastomosis in bariatric surgery, or regarding post-op complications?
You see, like in bariatric surgery, using hand-sewn versus stapler. So they are like
anastomosis.
In the anastomosis. So the thing is that there are studies which have compared the two, and they found that there's nothing like superiority of one over the other, but they are like non-inferior. So again, it's the surgeon skill and expertise as far as anastomosis and technique of hand-sewn anastomosis. Some you do a single layer, some do a double layer. So again, it varies. So there's a lot of heterogeneity of data about this.
Okay. I think we'll need to wind up this session because we have an inauguration, and you can ask all your questions on a cup of tea or with a cup of tea.
There's a question from Manoj sir regarding golden finger.
Golden
So,
finger.
Because Manoj, if you're coming tomorrow, we can show you tomorrow.
Yeah.
Mainly to define the angle of his.
Okay.
It sort of articulates what.
One suggestion is that can we pre-operatively assess the thickness of tissue by some means so that we can plan the. Yeah, sure.
Thank you. Sir, can you standardize the height, because the color coding differs with each company? So if the height can be standardized for what height of the stapler to be used, like 3.5, because your transparency shows at 3.5 and 1.5 mm.
So that is for brands to come on a platform to decide that they have a uniform.
So you can't compare heights.
Variable.
So you cannot compare heights, because heights depending on the type of staplers that you use. So you just cannot compare heights. You can compare J&J green to a Covidin green, but you cannot compare a tri-stapler to a GST or a J&J.
No, so but if the height...
You're right. What I'm trying to say is each color means the color of one company, green color of one company, green of other company, and third one are all the same, the closing height. So it's color coding and the closing heights are same for all companies. So that answers the question. Okay.
Thank you.
We conclude our first two sessions for the day. Inauguration ceremony is at 4:25 p.m.
Please have a quick cup of tea, and I'll really request you to come back because it won't look nice if the chief guest comes and we are all outside. So have a quick cup of tea, and I think 10 minutes good. Okay? We'll have enough time at the dinner to interact.
Good evening to one and all present here. Today we are gathered here for the third postgraduate CME and certificate course on the basics of metabolic and bariatric surgery. I am extremely honored to be given this opportunity to address everyone on this special occasion.
Now, I would like to I'd like to begin the inaugural ceremony by inviting our guests. I request Dr. Anita Saxena, Dean Academics, Chief of Cardiothoracic Center and Head of Department of Cardiology, to come onto the dais. I request our team to please present a bouquet to Dr. Anita Saxena. Now, I invite Dr. Rajendra Prasad, Professor and Head of Unit 3, Department of Surgical Disciplines, to please come onto the dais. Dr. Arun will now present a bouquet to Dr. Rajendra Prasad, sir. Now, I invite Dr. Lokesh Kashyap, Professor, Department of Anesthesia, AIMS, to please come onto the dais. Dr. Vitish will now present a bouquet to Dr. Lokesh. Now I invite up onto the dais Dr. Sandeep Agarwal, Professor and Head of Unit 2, Department of Surgical Disciplines, and also founding member of FORMS, to please come onto the dais. I request Dr. Amardeep to present a bouquet to Professor Sandeep Agarwal. I invite Dr. Himanga, Additional Professor and Founding Member of FORMS, to please come onto the dais. I request Dr. Arun to please present a bouquet to Dr. Himanga, sir.
Thank you. Thank you, sir. Light is a symbol of brightness and prosperity. To make this evening a blessed one and invoke Goddess Saraswati by kindling the lamp of knowledge and wisdom, we invite all dignitaries on the dais for lamp lighting ceremony and thereafter followed by Saraswati Vandana. Dignitaries to please remain standing. We are happy to announce the launch of the 4th volume of our newsletter. I request Professor Anita Saxena ma'am to unveil the newsletter.
Thank you, ma'am. We are also pleased to announce the launch of the booklet for patients. I request Professor Rajendra Prasad to please unveil the booklet. Thank you, ma'am. This app will go a long way in educating the patients about the diet in the post-operative period. This booklet, sorry. Now, we are also proud to launch an app for our bariatric patients. I request Dr. Lokesh Kashyap to please come here and launch the app.
This is indeed a proud moment for us to announce the launch of this patient-centric mobile application. Ma'am, you can please take your seat, so I'll start. So as sir, I would have suggested its name as BariCare, as we do care for our patients even for when they come for long-term follow-ups. And probably this is the time that our patient need us most, when they come for long-term follow-up. So especially once they are discharged from the hospital. And this app will go a long way in connecting us with our patients, and it helps the patients in seeking follow-up care, including appointments, sharing their health issues, including weight parameters and investigations. Besides helping us in maintaining our follow-up database for a better research analysis. We are launching a beta version of this app today. However, it will soon be available on Android Play Store, followed by iOS Apple Store, and it will be a password protected app. The unique feature is, as said, the patients can record their weight loss periodically. They can select dates for periodic follow visits. By push notifications, we can send the patient reminders for follow visits, and we can also check on the number of patients visiting us on particular follow-up day, so as to cater to them. Also, the submitted data is synchronized with our secured bariatric record using their unique ID. Currently, as I said earlier, it's available for select patients by invitation and then scanning of the QR code, but soon it will be available on Play Store as well as Apple iOS. Thank you.
Thank you, sir. This app is a must step for the patient-doctor interaction and will be a boon for the patient to monitor the post-op progress and adhere to regular follow-up visits. I now invite Dr. Agarwal, sir, to come and say a few words.
Very good afternoon to everyone. Our chief guest, Professor Anita Saxena, Dean AIMS and Chief of Cardiothoracic Center, Professor Rajendra Prasad, Senior Professor in the Department of Surgery and Head of Unit 3, Professor Lokesh Kashyap, who is a Professor of Anesthesia and one of our key support members of our team for our bariatric surgery program, and Dr. Hemanga Bhattacharya, Secretary of our foundation, which we formed for the awareness for this field of surgery, senior faculty colleagues in the audience, and dear delegates and friends. It gives me a great pleasure to welcome you all to this third postgraduate CME in bariatric and metabolic surgery being held in AIMS, New Delhi. So as I already said, this program we hold to fulfill the gaps in the curriculum which we perceive are there in the PG curriculum of various medical colleges. And we're aware that there are not many public hospitals and medical colleges have a bariatric program, and the postgraduates don't even get to see any of these procedures, as well as even the theoretical part is not covered during the lectures and deliberations. So we have been doing this CME over last 4-5 years, and this is the third in series. Because of the break-in due to the COVID lockdown, we could not hold it in time. But I think this is a welcome CME, and it's so we're so pleased to see you all in this post-COVID time to be with us and attending all these lectures and all. The CME is running over a day where today we are having lectures on the basics of bariatric surgery, the patient workup, the counseling, the dietary and the psychological workup, and also some other lectures about the newer technologies. And tomorrow we plan to show live procedures from our OT, which will be directly related to this auditorium. And this CME holds a lot of value in our overall program, because the mandate of AIMS is to teach and impart training. A few lines of our program: we are roughly about 12 years old now. We started in 2008, so roughly 12, 13 years old, and we have come a long way. When I was probably a lone member, along with Professor Mishra, the then HOD, we built up a program along with the other faculty of the department. And we did not have any fellows or any trainees that time. And over the years, we have built up a very strong team consisting of a bariatric coordinator, a psychologist, a bariatric dietitian. We have a fellowship program of 2 years in bariatric surgery, so we have fellows who are there. We have our resident team who takes a lot of interest in bariatric surgery. So we have a strong team now, and so we have been able to grow quite a bit over the last 12 years in the terms of not only patient care, but also research and further training. I'm glad to say that we have published more than 50 research papers during this period in mostly reputed international journals, and we are now internationally recognized. Our faculty gets international invites from major international events to give lectures, both nationally and internationally. Our fellows and residents have been winning prizes in almost all the conferences where they have presented their research papers. So I think it's a program which has come up well with the support of the administration, the department, as well as the senior colleagues. And we hope to take it further in terms of training opportunities, in terms of patient care over the next few years. Also, we hope that when the robotic surgery, we go in a big way when our own robot we are able to acquire, and with the new surgical blocks and the new facilities coming up, we plan to grow dramatically. So just that was a brief this thing about that, and I will now again say thank you and welcome everyone to this CME, and hope you have a nice CME and you learn a lot to carry very pleasant memories from this CME. Thank you so much.
I now invite Professor R.P. Sir to come and say a few words.
Thank you. Professor Anita Saxena, the Honorable Dean of All India Institute of Medical Sciences, Professor Sandeep Agarwal, Dr. Hemanga, Professor Lokesh, dear friends and students. It is indeed a pleasure to be a part of this event. The bariatric surgery program, as Dr. Sandeep Agarwal has elaborated, has come a long way, and I would first like to congratulate him on his efforts that has brought this program from an infancy to a stage where now we have fellowship programs, and I also hope that it will further grow once we move on to surgical block, where we'll have more facilities for more operative time and possibly a robotic setup also. This is an important event, and I think this is one of the first that we have had after a long hiatus due to COVID, one of the first physical events that we are having, and it is very heartening to see the room full of enthusiastic students and other delegates who have come from all over the country, and I wish everybody a very, very pleasant learning experience and a very, very pleasant stay at Institute. Once again, wishing everybody a great learning experience and a great success to this program. Thank you very much.
Thank you so much, sir. Now I finally invite Dr. Anita Saxena ma'am to come on the dais and say a few words.
Good afternoon, everyone. I must begin by welcoming you, all of you, on behalf of the All India Institute of Medical Sciences and my own behalf, to this program, which Dr. Sandeep has very nicely put up for the next 2 days that you're going to be here. So, I think obesity is something that we always associate with Western world, and we never thought that it is a problem in our own country. But we have seen over the years, especially in 20th century, it is almost reaching epidemic proportion, and I believe 5% of the population of India has morbid obesity. We also know that obesity is associated with so many complications, and I, being a cardiologist, I look at it as a major cardiovascular risk factor, and I think it also came up as a risk factor during COVID times, risk factor for mortality. So we know that obesity is bad, and as we keep saying, prevention is better than cure, so we always try and tell everybody to have a lifestyle modification, keep obesity away, try to have a very active lifestyle and all that. But still I think there are plenty of patients that we see who have so much obesity that despite trying all means, the only hope they have is bariatric surgery. And actually, I have been at a personal level asked this question many times from several people who ask me whether bariatric surgery is available in All India Institute of Medical Sciences or not. And I think this is the first public hospital which has started bariatric surgery, and Dr. Sandeep Agarwal and his team has really brought it up to this level that now we are having CMEs and we are trying to train students and young surgeons towards bariatric surgery. I think that's a very big success, and I must congratulate Dr. Agarwal and his team for that. I think there is also data to say that bariatric surgery helps in reducing mortality. There is data to say that it adds years to the life of a morbidly obese person. So I think there is no sort of doubt about the effect of bariatric surgery anymore. Like earlier we used to think it's more of a cosmetic surgery. Now we know that it helps in prolonging life of an individual, and therefore it is actually getting more and more popular over the years, as you would have seen. I believe more than 1,100 surgeries have been done at the All India Institute of Medical Sciences under the supervision and leadership of Dr. Sandeep Agarwal, and that's a very big number. I'm also told that I think establishing such programs in other government hospitals is also the task that has been taken up by the Department of Surgical Discipline here at AIIMS, and such programs have been established at Chandigarh, at Maulana Azad Medical College, and so on. I think these CMEs are very, very important because they not only teach you, I think they sensitize you. I mean, the very fact that there is a CME being held in the by the department is a good stimulus or the sensitization for many of us to understand what is bariatric surgery. And as Dr. Agarwal said, that the current PG curriculum doesn't have much of bariatric surgery in the curriculum, and I think this is what we need. I'm sure in years to come, it will be incorporated in the PG curriculum also as things expand. I'm really happy to have so many participants, and I wish you that you have a good time in the next 2 days. When I looked at the program, there were of course didactic lectures, as we always have, starting from the counseling to perioperative management to intraoperative procedures and all that. But you also have a live workshop from OR, which I think gives ample opportunity for learning, for interaction, for question and answer session. And I think that is something that you all must utilize while you are here, because you can ask as many questions as you want, and I'm sure the experts will be able to satisfy your scientific hunger. I was also pleasantly surprised that there is a psychological evaluation of a patient, which I think is very, very important, because when I was going through some literature about bariatric surgery and from some friends, I realized that weight regain is another problem that happens sometimes after bariatric surgery. So one has to really look at a lot of aspects besides the surgical aspects as to the patient's benefit would be most if there is no weight regain, and that is an important. I think it happens in almost 20-25% of individuals. So I once again wish you all the best, and I hope that you have a very stimulating time over the next 2 days and enjoy and learn to the maximum and take it back with you and try and train more people, emulate what is being done over here. And this is a process that will not finish with 2 days, it will go on, and please keep in touch with the team here so that you also establish such programs wherever you come from. Thank you very much.
Thank you for the nice words and gracing this occasion, ma'am. Now we invite Dr. Amardeep, Fellow in Bariatric and Metabolic Surgery and organizing member of BARIME, to propose the vote of thanks.
Thank you, Dr. Ritvik. On behalf of our organizing team, it's my privilege to propose a vote of thanks. First and foremost, I thank our chief patron and dean, Professor Anita Saxena ma'am. She took time away from her extremely busy schedule and pressing responsibility to come as a chief guest for this program. Many thanks to you, ma'am. We are thankful to our patron and HOD, Professor Sunil Chumbar sir, for encouraging our program and gracing this occasion. We are thankful to the faculty members on the dais, Professor Lokesh Kashyap sir, Professor Rajendra Prasad sir, Professor Sandeep Agrawal sir, Professor Hemangas Kumar Bhattacharya sir. I am grateful for being and guiding us. Thank you all. I am grateful to our organizing chairperson, Professor Sandeep Agrawal sir, the guiding light for this academic event. We are thankful to him for entrusting us with the task and encouraging us for this event. I extend sincere thanks to co-organizing chairperson Dr. Hemanga Kumar Bhattacharya sir, Dr. Manjunath Maruti Paul sir, Dr. Piyush Ranjan sir. Without their guidance and support, this could not be possible. I now thank my teachers and senior faculty members from our department, Professor Sunil Chambar sir, Professor Rajendra Prasad sir, Professor Shinu sir, Professor Sandeep Agrawal sir, Professor Anita Dhar ma'am, Professor B.K. Bansal sir for their immense help and encouragement. We are thankful to the Professor M.C. Misra sir for guiding us with his novel idea. I now thank my friend and colleagues Dr. Arun Sharma and Dr. Bitish Shingla, who are also the part of organizing secretary, whose support and contribution is beyond my words. My sincere thanks to my team member for their selfless support. A special thanks to our dietitian, Ms. Monita, Ms. Shakshi, and our psychologist, Ms. Sally, for active participation in conducting this program. I am extremely thankful to the staff of Department of Surgical Discipline, especially Mrs. Rachna ji, who is also our bariatric program coordinator, for working very hard to make this meeting a grand success. My sincere thanks to the delegates and all the faculty members who have been participated in this program with such an enthusiasm. I extend my thanks to Audiovisual Department, Security Department, Computer Facility, Transport Department for extending for this program. I am very thankful to industry partner Merrill Indo Surgery Private Limited, Panther Healthcare, Johnson & Johnson, and Hexagon Nutrition for sponsoring this event, and media person for covering bariatric health related news. I also extend my thanks to many others whose names have not been mentioned. Please accept our sincere gratitude and please forgive us for any mistakes of ours. Thank you all once again for being here and making this program a grand success. Thank you one and all.
Thank you, sir. With this, we conclude the inaugural ceremony. We request you all to kindly stand for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
before we begin session 3, I'd like to remind you all that all interested delegates, please register for the bariatric quiz. We have attractive prizes for the top 3 winners. We will have a screening round during the course of the CME and will end with the final quiz tomorrow as the last event. Thank you.
Now we enter our third session for the evening, and I invite the following chairpersons: Professor Dilip Shinde, Department of Anesthesia and Intensive Care, AIIMS, New Delhi; Dr. Renu Sinha, Professor, Department of Anesthesia and Intensive Care, AIIMS, New Delhi; Dr. Piyush Ranjan, Additional Professor, Department of Surgical Disciplines, AIIMS, New Delhi; Dr. Parmeet Kaur, Chief Dietitian, Department of Dietetics, AIIMS, New Delhi.
Good afternoon, everybody. I welcome you all for this afternoon session. And we start with the topic, dietary evaluation by Ms. Monica Gehlot. I invite Ms. Monica Gehlot to present her talk.
Good afternoon, everyone. I'm dietitian Monica Gehlot, working in the Department of Dietetics. First of all, I would like to thank the organizing team and Dr. Sandeep Agarwal for giving me an opportunity to present in this reputed BARIME. The topic of my presentation is nutritional management of bariatric surgery patient. So we all know that nutrition is a very important, vital component of management of bariatric surgery patient, and our goal for nutritional management of bariatric surgery patient is to optimize the nutritional status of bariatric surgery patient before and after surgery. So the nutritional management is basically done by stepwise manner. First of all, we do the nutritional assessment, and nutritional assessment is also done stepwise. Like, first of all, we take the anthropometric assessment, by which we ask the height, weight loss history, BMI, hip circumference and body composition. Secondly, biochemical assessment and clinical assessment, by which we can identify any micronutrient deficiencies if they are in patient. And then most important, the dietary assessment part, where like several methods can be utilized, like 24-hour dietary recall, by which like we ask the patient the last day's recall, and we can come to know how much calorie and protein they are consuming by taking detailed history, like diet history. When we ask the patient the diet in detail, we can come to know about the like dietary patterns of the patient, like what faulty habits they followed, what kind of eating behavior which lead to their weight gain. Then food frequency, this is also a method which we utilize in nutritional assessment, by which which we can ask the food frequency of eating healthy food items, like how frequently they are consuming fruits, how frequently they are consuming vegetables, or we can even ask the frequency of eating unhealthy food items, like how frequently they are consuming fried foods, how frequently they are consuming carbonated beverages. So these, like for doctor, the diagnostic tool are the lab investigation. For us, the diagnostic tool is dietary assessment. So we do it in detail so as to make a diagnosis, dietary diagnosis, and so that we can plan a diet which is individualized, which is as per the patient's dietary specific, and so that we can achieve a more compliance toward diet. And this nutritional management and bariatric surgery patient divided in two parts, pre-surgery and the second is post-surgery. The pre-surgery nutrition is aimed at, first of all, like 5 to 10% weight loss is advised in pre-surgery patient, because it reduces the size of liver, it reduces intra-abdominal fat, it eases the laparoscopic surgical procedure. So this much weight reduction is advised. So in pre-surgery diet, the two kind of diet basically advised. One is VLCD diet, that is very low calorie diet, and other one is low calorie diet. So what is the difference? VLCD diet approximately provides 600 to 800 kilocalories, and it is basically liquid in nature. And the other diet is, and it is followed just 15 days immediate prior to the surgery. Other diet is LCD, which provide around little more, 800 to 1200 calories, and it is like regular food included along with the portion control. So if we have more gap in surgery, like 2 months or 1.5 months or 3 months, we can put the patient on first on LCD diet, and then we can, like 15 days prior to the surgery, we can put the patient on liquid VLCD diet, so that maximum weight loss can be achieved pre-surgery also. So in VLCD diet, the 15 days prior to surgery, the major concern is we have to provide enough of protein and fluid. So the primary planning is done using, first number you can see the protein containing meal replacement, protein powders mixed in either water or skim milk, given at major meal timings, breakfast, lunch, dinner, and like evening also. And in between, second point you can see a patient should be given low calorie sugar free beverages like soups, coconut water, buttermilk, lemon water, green tea, etc. So this is the primary component of VLCD diet, and calorie and protein, as I like mentioned it. And this like operative nutritional management, one important thing which we need to know, that assessment of micronutrient deficiencies, because it has been seen in studies that severely obese patient, when compared to the healthy control, they are deficient in several micronutrients like vitamin B12, iron, folic acid, and vitamin D. So assessment of micronutrient deficiencies is very important, and pre-surgery micronutrient supplementation can be advised if deficiencies are there, otherwise more complication occur post-surgically, right? And now comes the post-surgery nutritional management. So once the patient undergone surgery, now there are anatomical changes in the digestive tract. The stomach pouch is small, and in some cases, like there are like malabsorptive procedures has been used. So the goal of post-surgical nutritional management, first to heal the newly made stomach, preservation of lean body mass with weight loss, preventing the micronutrient deficiencies, and preventing complications, and preventing weight gain. These are the goals which we target when we are advising diet to the post-surgery bariatric patients. Now, what should be done? So, first of all, we'll talk about the macronutrient. Protein, carbohydrate, and fats are called as macronutrient. What should be the macronutrient composition of the diet? So, among the macronutrients, protein is the most important macronutrient. Why? It is first required for the healing of the new stomach. Second, with the initial 1 year, the weight loss rate is very high, and with that weight loss, along with fat mass, lean body mass also like losses. So, to prevent that lean body mass loss, that protein intake is very important. So pre-bariatric, the protein requirement was 1 gram per kg of body weight. Now post-surgery, the requirement is 1 to 1.5 gram per kg of ideal body weight, and it can be even more in malabsorptive procedures, like in BPD it can be up to 2 gram per kg of body weight. Now comes the carbohydrate. There are no recommendations as such exist for carbohydrate, but the percentage should be on lower side, like 50%. Normally it is 60 or 65%, but the type of carbohydrate is very important. So patient should be advised to take complex carbohydrate, preferable over the refined sugars or simpler carbohydrate. calorie goals are like no recommendations of calorie goals exist, but the studies have proven that on the first year patient are able to eat 800 to 1000 calories. The aim is to produce the negative energy balance so that they can reduce weight. So usually the patient calorie is right around 1000 kilocalories for first year, and fat should be less than 30%. Now comes the micronutrients. Now post-surgically micronutrient deficiencies are very much prevalent due to the surgical procedure, also some other like poor nutritional intake, pre-existing micronutrient deficiencies, poor food intake and food intolerances which occur with the surgery. So correcting the micronutrient deficiencies is very important. As per ASMBS guidelines, any micronutrient supplementation is must for all surgical procedures, and it should contain the mentioned amount in their micro vitamin mineral supplement. Like it should have, we should study the label, and we should see that it should have at least 12 milligram of thiamine. B12 should be around 350 to 500 microgram. Folic acid should be 400 to 800 microgram. Vitamin D 3000 international 3000 international units. Similarly, minerals also, iron has to be 45 to 60 milligram, calcium 1200 to 1500 milligrams. So these this amount must be there, supplemental amount must be there in any vitamin mineral supplement, and along these are the supplemental amount I have to mention here that if the deficiency is there, the repletion and correction amount is different from this. And the micronutrient vitamin supplement should be like advised, patient should be advised to take daily. Calcium should not be advised along with iron, and iron supplement should be advised to taken with vitamin C sources. Now I have like told you about the macronutrient composition, about the importance of protein, calorie, fat and carbohydrate. Now when we have calculated the energy, like it has to be 1000 calories, we have calculated the protein requirement, it has to be like something like 80 gram of protein. Now we will convert those energy and protein into diet. Now the diet of patients progress in 4 stages, because the newly made stomach we cannot give the solid food. So there are diet is like progressed in 4 stages. The first stage is liquid diet, which is followed for 15 days, and for this can also further divided into 2 stages. First is clear liquid diet, which is followed for 1 to 3 days, and then full liquid diet 3 to 15 days. What is the difference between 2 diets? The clear liquid diet include the foods which we can see through, transparent like water, clear soups, coconut water, etc. They are given initially at the 30 ml rate and increased to 150 ml by 3 days. After like once patients started tolerating the clear fluid, we will now introduce the full liquids to the patient. So in addition to the clear liquids we prescribed earlier, we will add milk, yogurt and protein powders in their diet. So this liquid diet will be followed for 15 days, and the composition of this diet also is same, like protein containing meal replacement mixed in either water or skim milk, given at major meal timings, lunch, breakfast, lunch and dinner, and in between low calorie sugar-free beverages. So this is about a liquid diet, and protein replacement is the major part of this diet. Now once patients start tolerating the liquid diet, the second diet is the pureed diet, and pureed diet is like the texture of diet is smooth and without lump. So how it is made? It is made using soft cooked food mixed, blended in either like mixie or hand blender or food processor. So it looks like a baby food. So anything like soft cooked like cereal, like khichdi can be mashed, dal can be pureed. So it can be given in pureed diet, and it should be gradually progress. And once the patients start tolerating the pureed diet for 15 days, now we can progress to soft diet. What do you call a soft diet? Which the soft diet is a diet which is soft enough to fall apart when pressed with a spoon. So now the soft cooked food like cereal item like khichdi or dalia or upma can be given to the patient. Soft cooked dal can be given to the patient. Soft fruits can be given, and hard skin fruits and vegetable raw salad should be avoided at this stage. Now, fourth diet, after 45 days of surgery, now the stomach is like almost healed, so regular diet can be introduced. The most important point in regular diet is we will be introducing one food item at a time, and patient will be advised to take one food item at a time, and if tolerated, we can like progress toward the second item. Only thing we have to consider in regular diet is that they should need to avoid all like sweet food items or all calorie loaded food items or all fried food items which can like cause weight regain. Now the protein supplement is very important part of all 4 stages of diet. Why? Because the stomach capacity is very small. There is malabsorption also in various procedures, and it is with this much 800 to 1000 calories, it is not possible to take that much amount of protein from diet alone. So protein supplement is very important in all these 4 stages. So patient should always be advised to take their protein supplement in advised doses. Now all these 4 stages of diet, the eating techniques are now new as per the newly made stomach. So eating techniques need to be changed. So whenever the patient come to you, the eating techniques need to be explained so that various complications can be prevented. Like they have to be told that they have to eat slowly, they have to chew thoroughly, they have to chew each bite 20 to 25 times, and they should take at least 30 to 45 minutes to finish a meal, and they have to sip water throughout day to meet their fluid requirement. They should not be gulping their fluid. It can cause nausea and vomiting or other complications. And also one most important thing, they should keep their fluid and solid intake separate. At least a 30-minute gap should be maintained with solid and liquid foods. One more important thing which we need to counsel to the patient is mindful eating. That is, patient should be advised to eat consciously, like they should be thinking before eating. They should know that if they are eating because of hunger or because of non-hunger clues, like when they are eating when bored or in front of TV or when stressed. So they need to be educated regarding mindful eating also, because these only eating habits will help them to stop their weight regain. Now one most important thing is they need to be taught about portion control also. So post bariatric surgery, we should tell the patient that they should be purchasing some kind of measuring cups with them and food scale so that they can measure their food and eat, so that portion control is there and overeating can be stopped. Now, there are few complications which occur after bariatric surgery. Like one of the most important is dumping syndrome. You all must be knowing, like it's a rapid gastric emptying of stomach content into the small intestine, which causes a osmotic effect and postprandial hyperglycemia. So the dietary management of dumping syndrome involves avoiding all kind of sweet food like dessert, ice cream, yogurts, juices, sugar-loaded all food items need to be avoided. Along with that, correction of eating technique is very much there. So they need to avoid drinking fluids while eating. They need to eat slowly and chew thoroughly. So these are the guidelines they need to follow to prevent dumping syndrome. Other like complications like nausea, vomiting, and regurgitation also can be prevented by using correct eating techniques, like same eating slowly, sipping slowly, chewing thoroughly, and along with that, lying down right after eating. One most important issue I want to discuss here is sarcopenia. So in the initial 1 or 2 years, when the weight loss is very much there in the bariatric surgery patient, so they lose fat mass, but along with fat mass there is a loss of lean body mass, so which can produce a condition called sarcopenia. And if muscle mass reduces, our body's metabolic rate, which is energy expenditure at rest, reduces. So what is the implication? If this muscle mass reduces, your RMR reduces, and if RMR reduces, your tendency towards weight gain is more. So our main objective is to prevent sarcopenia, or our main objective is to prevent lean body mass. So there are 2 ways. That is why protein is so important. So protein intake has to be ensured in patients' diet, that they are consuming the sufficient amount of protein. First thing. Second thing, in physical activity, new recommendations say that along with aerobic exercises, there has to be 3 days, 60 to 75 minutes of resistance training, because it targets core muscle muscle groups and help to prevent the loss of lean body mass. So strength training is very much important for bariatric surgery patient. Now, once like we have discussed about all kind of diets, now on discharge we need to give patient all the kind of 4 diet charts along with the new eating techniques like education, and their regular follow-up is very important to maintain the compliance. It has been seen in a meta-analysis of 5 studies that patients who are regularly follow up with the bariatric team maintain their weight regain can be maintained and complications can be reduced. So at least initially at 1 month, then 3 months, 6 months, and then 6 monthly follow-ups very must for the patients. And lastly, they should be educated to self-monitor, which is very important. If they self-monitor, only then they can prevent their weight regain. So they should be taught to maintain a food record diary, physical activity diary, and along with monthly weight record, so that they can track their weight, that if it has increased 2 kg, they can be aware. Otherwise, patients are unaware of their increase in weight. So it is very important self-monitoring. So by these guidelines which I have mentioned, these are all either evidence-based or practice-based guidelines, and by using these guidelines we can ensure we can optimize the nutritional status of bariatric surgery patient, help them in their healthy weight loss journey. Thank you so much.
Talk. I just want to know one thing. How much time after surgery you ask them to do the surgery, do the workouts? I don't think they are. It's very easy to get the workouts done from them. Is it so?
So walking can be advised after a week or so, I think. Walking can be advised, strength training takes time.
Okay. Any questions, please?
Presentation you mentioned that nowadays we are focusing more on adults, and then these nutritional guidelines, these are adult based, and in time to come we have to also bring nutritional approaches or strategies for adolescent population also, because that is also coming up below 18 years, because they have their different physiological needs as per their physical growth and mental growth, and their food environment is also school or college based. So monitor, we need to work on this aspect also. And Dr. Sandeep also mentioned about nutritional strategies for senior citizens 65 plus. And these patients, they present with lot of comorbidities. And in bariatric surgery, like Monita mentioned, that protein is the mainstay, it is very important. But when we talk about renal patients, we need to reduce their protein intake. Right. So, Monita, you can throw some light on this aspect that for adults, we target 1 to 1.5 grams per kg body weight. And mostly the people, renal patients also, they are the patients. So, what should be their protein intake?
Thanks for the question, ma'am. Yes, in being in tertiary care center, we do get bariatric surgery patients which have several other comorbidities. One of the main important is CKD, because the management of CKD, dietary management is very difficult. Usually the normal CKD requirement, protein requirement is somewhere about 0.6 gram per kg body weight to 0.8 gram, and the bariatric surgery patient requirement is 1 to 1.5. But for bariatric patient with CKD, the requirement is 0.8 to 1 gram per kg of ideal body weight, with the solute restrictions like phosphorus should be less than 1000 milligram, sodium should be less than 2500 milligram, potassium should be less than 2000 milligram. So the protein has to be in moderate amount. We cannot restrict much of protein, because that protein is required for healing in that post-surgery period.
Another one major thing, because I was going through our presentation and you mentioned about pre-operative and post-operative nutrition programs, but I think we should be focusing more on pre-operative programs, because pre-operative we have large our gastrointestinal tract, it is the normal size, and so absorption of nutrients will be more. So when we are preparing patient for bariatric surgery, we should be bringing the patient to optimum a good nutritional status first, and then going for surgery, because later on it is difficult to correct the nutritional inadequacies, because my vitamins and mineral deficiencies, calcium, anemia, there are so many complications. So it is very important that pre-operative nutritional status is built up for these patients. Thank you.
One question I have, when I was doing fellowship here, that time I was not following patient from diet point of view so closely. But patients who are going gastric bypass, MGB or RYGB, they are having more symptoms after you give protein supplements. This is not seen with sleeve gastrectomy patients, and they feel nauseated, bhari feel hota hai, and they are unable to take that. You decrease the dose to half teaspoon also, and still they're not able to take that.
So at the initial period, there is a protein indigestion is there in some malabsorptive procedures, because protein is converted by stomach acid into peptides. So this is affected in many of the cases. That this could be the reason. This is why we tell the patient to start with a half scoop or 1 scoop in water initially. Once tolerated, then only we gradually progress. So the eating technique is very important to check for the tolerance. We have to always check, and food tolerances can be different. One person with the same surgery can tolerate that protein powder, other person might not tolerate. So these are the various factors. We have to check for the individual tolerance, then progress.
So if patient is unable to tolerate even half teaspoon, so what options do we have?
Try some other things. We will try some other things, like if patient is not tolerating milk, we'll switch over to curd. If patient is not tolerating one kind of protein powder, we can switch over to other. It can be, if they are not tolerating mixed in milk, then it can be given with curd, it can be given with vo. But we have to see the tolerance. And in severe cases, then the diet plan has to be specifically designed for that particular patient. That is why dietitian is very important in bariatric team.
Thank you.
Thank you so much.
Good evening. This is a very interesting session. In fact, I got a lot of insights into the dietary management before and after bariatric surgery, and it would require a lot of patience and psychological strength. I'm not sure how Dr. Sandeep Agarwal is able to regulate all these regimes in his patients. At least if I had to go for it, it would have been a very difficult proposition. So in that background, the psychological evaluation becomes a very important part of any metabolic or bariatric surgery. Ms. Shelley would be giving presentation about psychological evaluation. Ms. Shelley, please.
Hi, good evening everyone. I hope you all are having a good and informative time. My name is Shelley and I'm working as a psychologist in the Department of Surgery. Today we'll be talking about how psychological evaluations are helpful in bariatric patients going forward. Psychology is simply the scientific study of our mind and behavior. So naturally a psychological evaluation is aimed at understanding the cognitive functioning and behavior of the person. Psychological evaluations usually involve a thorough assessment and screening process, which is aimed at understanding what behavior patterns, what personality types, what other psychological contradictions are there in patients going forward for bariatric. 4 usually used assessment types are assessment of intellectual functioning. IQ tests measure a person's cognitive abilities and provides a score that helps us determine an individual's intellectual abilities and potential. 2 primary types are used: intelligence tests that help us categorize whether a person is developmentally delayed, a genius, or above average or average person. Another one is neuropsychological assessment that tries to determine the impairment to a particular skill. Behavioral assessment are used to determine a maladaptive behavior or emotions, which once identified in collaboration with the patient and using different therapy techniques are converted into constructive adaptive behaviors and emotions. Another one is clinical interviews, which is an evaluative tool to make accurate diagnosis of a variety of mental illnesses. Personality assessments are used to check the genetic, environmental, and social components of one's personality. These psychological assessments are used to determine the severity of symptoms, the presence of learning disability, strengths and weaknesses of a person, root causes of emotional problems, positive and negative coping styles, insight into aggressive behaviors, information about how one views the world, issues or conflicts one may be struggling with, insight into their personality type, impact of psychological maladaptiveness on other domains of life. So we discussed what a psychological evaluation is, what it comprises of, and what it is used to determine. Now we'll be coming to why these psychological evaluations are required for bariatric patients. A lot of my colleagues had already discussed the criteria which an ideal bariatric patient can have, so I'll be skipping these. So WHO reveals that since 1975, the world obesity rate has increased thrice, and in 2008 they reported 200 million men and 300 million women are obese worldwide. If I specifically talk about India, a current study was established in 2021 by Venkat Rao that says that the India prevalence is 40.3% and the highest in South Indians with 46.88% rate and lowest in East Indian population. It is seen to be higher among women than men, more in urban than rural population, and more over 40 years than under 40. In addition, 65% of global population was living in countries where being overweight and obese was causing more number of deaths than being undernourished or underweight. Obesity management requires a multidisciplinary team and integrated treatment that comprises of a nutritional, physical, psychological, and medical evaluation. Despite bariatric surgery being the most recommended treatment for obese individuals, a considerable portion, about 20%, of patients do not achieve relevant outcomes in terms of limited weight loss or weight regain. If a psychological problem is pre-existing, it can worsen the patient's health. Psychological problems that are present at a mild or moderate rate can increase in intensity, or new psychological challenges can arise in patients after the surgery. The prevalence of psychological disorders in bariatric patients. Little is known about why psychological evaluations are necessary and what psychological effects are there on life of bariatric surgery patients, despite the prevalence of psychological disturbances being high in these candidates. A review that was conducted by David in 2020 suggested that about 1/3 of the population of bariatric population have psychological disturbances. Mood disorders was ranked as the most prevalent one, with ranging between 22.4 to 45%. Axis 1 disorders were also seen to be negatively associated with reduction in BMI post-surgery. In all the Axis 1 disorders, mood disorders were followed by anxiety, which was followed by binge eating. So a clinical significant level of anxiety is found in about 44% patients. Preoperative anxiety is predictive of post-operative anxiety too. And most of the studies also suggest that the depression and anxiety that is seen in individuals pre-operatively lead to less weight loss after the surgery. Binge eating disorder is also considerably studied in the Asian population, and it is also correlated to many other psychopathologies. Persistence of binging after the surgery leads to a rise in the BMI and is linked to a low health-related quality of life. High stress, low social support, and low self-esteem is also predictive of lower weight loss. Though the available literature of psychosocial factors that are impacting patients with bariatric surgery is not sufficient or conclusive in the Indian population, but majority of the studies have shown a negative impact. The psychological resources that we usually use to assess bariatric patients are clinical interviews and psychological tests, which comprises of the behavioral and personality tests. Very, very rarely there is a need to do an IQ assessments. Currently, there is no established protocol for psychological assessments of bariatric patients, which hinders the identification of which domain deserves attention and which evaluative procedure should be employed by the psychologist. Furthermore, without a standardization of practices, the value and purpose of psychological assessment is subject to variation, as each professional or bariatric team uses their own collection of tests according to their objective to assess these patients. The preoperative evaluation of psychological conditions and pre-post-surgical psychological support is helpful to achieve the desired post-operative outcomes for a long time. So, the pre-bariatric psychological care actually comprises of obtaining an objective measure of the patient's psychological adjustment through the psychological evaluation, so the psychological disturbances and cognitive distortions can be identified. To prepare the patient for the post-operative period, aiming to optimize surgical results. To better understand the patient's motivation, preparation, emotional factors that can impact the adjustment to life after surgery. To identify any psychosocial contradictions to surgery and obstacles to post-operative success, or any psychosocial factor predicting various weight gain prior to surgery. To screen candidates that may benefit from psychological treatment prior to surgery in order to maximize long-term bariatric outcomes and improve the quality of life of the patient. To assess the presence of recommended criteria for surgery and identify or modify any risk factors associated with undesired treatment outcomes. Alternative treatments are proposed when patients do not meet the criteria for bariatric surgery. I want to take a moment to answer a question that was proposed earlier. How do we assess the motivation of a patient for bariatric surgery, pre-bariatric surgery? So it's through a combination of clinical interviews and the psychological assessment. Let's say I take a psychological assessment of a locus of control. So we have two components of locus of control, internal and external. After the scores, I will analyze whether the person has an internal locus of control or an external. If the person has an internal locus of control, that is indicative of the person having confidence in himself, the person believing that he'll be able to adhere to any post-operative restrictions or anything that the surgeons or the doctors suggest. And while we are asking these questions, there is one simple variation that I do with my psychological assessments. I do not just give the patient the psychological assessment and ask them to self-report everything. Because while we're asking the questions from them, it gives us insight into a lot of things, other things that are related or that lead to that particular behavior. So depending upon the expertise that the person has in the practical or theoretical aspect of eating disorders or bariatric surgery, it is easy to assess the motivation or the confidence that the person has in himself. I recently evaluated this patient who had substance abuse from the past 10 years. But the main aspect that makes him different from other substance abuse individuals is he had insight, he had self-awareness, and he knew that these factors have led to several problems in his life, financial, social, and otherwise. So he was very confident and very sure that he'll be able to not use alcohol or do substance abuse. Moving forward, the post-bariatric psychological care comprises of offering psychological support and preparing the candidate for behavioral modifications, psychoeducating the patient about the changes resulting from the surgery and under what circumstances should they opt for counseling, assessing psychological outcomes for surgery in patients, and effectively evaluating whether the surgical treatment approach has facilitated any resolution of pre-existing psychosocial factors. Efforts are made through psychological interventions to make patients more self-aware so they can recognize their problematic eating behaviors, learn strategies to cope with life stressors, and engage themselves in healthy eating behaviors. So there are certain conditions under which, from a psychological point of view, we delay or deny bariatric surgery to patients. One of them is uncontrolled symptoms of schizophrenia, as this is a disorder. In this disorder, the person experiences hallucinations, disorientation from reality, and delusions. Mental retardation, factors like social support, IQ score, etc. are considered to determine whether or not surgery can take place with such a patient. Lack of knowledge about the risks, benefits, and results of surgical procedures. Bipolar disorder is a very severe mood disorder. History of depression or suicide attempts or ideation. Presence of eating disorders, as these individuals are unable to control their eating urges and commit to dietary restrictions. And substance abuse, use, or dependence. For any disorder present at a severe level, counseling is required for surgery, so the impact of surgery does not deteriorate the health of the patient. For instance, if I have a bariatric patient who has severe depression, then I would first suggest taking counseling sessions or therapy sessions with him, because the liquid diet that we have for patients post-bariatric, you do not get food items that are rich in serotonin or that secrete serotonin in your body, and depression is associated with the low serotonin levels. So if a patient has severe depression, it can further deteriorate the health, or suicidal ideations might result, or the hopelessness and helplessness can lead to further deteriorating of their quality of life. So to wrap up my session, I would like to say that all candidates for bariatric surgery that are undergoing bariatric surgery should have a clinical evaluation as well as a comprehensive psychological assessment to decrease the impact of any complications that may emerge after the surgery and diminish the risk assumed by patients and professionals involved in this process. The psychologist performing the assessment for bariatric surgery has an obligation to investigate different aspects of the patient's life, and not only to determine their readiness for the surgery, but also to educate them with regards of what changes will follow after the surgery. However, the need of the hour, due to not having a standard protocol for assessment in the psychology field, we need to develop a protocol or collection of tests to measure all aspects of bariatric patients, so better patient care can be taken. Thank you. Any questions?
Thank you, Shelley. I think some of the basics of psychological assessment is absence of any major mental disorder. That could be depression, bipolar disorder, severe anxiety disorder, eating disorders. So active mental illness, that should not be there. Other is ability to cope with the stress, stress coping, motivation, and social support. These are some basic things which should be present before a bariatric surgery is undertaken. So the session is open for any questions or clarifications. Shelley would be happy to answer.
Thank you for your presentation. Is history of depression per se, just history, no active depression right now, is that a contraindication for bariatric surgery?
Not a contraindication, but it definitely helps in understanding how the patient's family environment or social environment is, and whether the data that is being given by the patient right now is valid enough. Because if a patient is telling me that a year ago I had severe depression and I was on antidepressants, but now I am perfectly fine, so I would definitely need the history to understand history and the psychological assessment to understand whether there is any active depression or how the patient is dealing with the everyday life.
So two things about that. One is obviously a lot of patients have depression. So that cannot be a contraindication, otherwise, 1/3 of patients won't be eligible for surgery. So one is the medication alteration that may be required post-surgery. The second thing is the counseling. What we have seen is the results are a bit inferior in patients with depression and major psychological disorders. So we have to, be cautious, and we have to define the expectations to that extent. And also, there has been some reports of increased suicide after bariatric surgery. So again, on those subset of patients, we have to keep a close watch in the post-op period, especially those on medications, because a lot of changes occur in their life. I mean, some of them may not be. Some patient goes, let's say for example, somebody goes undergo cosmetic surgery. You may not be accepting that new look, and you may go into further problems. Similarly, with bariatric surgery, it causes a lot of social changes. For example, I attended a lecture in one of the international meetings where they said because of a person losing weight and becoming good, there's a lot of increased divorce rate because the spouse was shaming this person earlier. Now he's become good. He wants to take a revenge. And so there are so many changes. I mean, it's really happening in physical surroundings of the patient that we have to keep them under follow-up. That's the importance of these things.
So another thing is, if a patient has a history of depression or any psychiatric illness, will that affect the choice of procedure? Like, will there be in bypass procedures? Is there any drug interaction?
No, not to my knowledge. No.
Thank you.
See, obesity. Sorry.
Yes, sir. Continue.
Obesity as such is associated with, because obesity which is requiring surgery definitely is a massive obesity, it's not a mild obesity. So it's as such would be associated with some secondary psychological symptoms in the form of anxiety, depression, or other adjustment issues, but not all such psychiatric comorbidity would be requiring medication management. Generally, the psychological, non-pharmacological measures would be helpful. But if it's severe, because definitely then the choice of antidepressants, post-bariatric surgery, that would also need to be taken care of, because you can't have the long-acting preparation. That's true for the usual medications, post-bariatric surgery. So, number of other things would need to be taken into consideration.
I just wanted to let you know that the suicide risks are majorly associated with pediatric patients who regain their weight after a year or 2 years because they have this intense feeling of failure and disappointment. So that just heightens the suicide risk. And if there's an active depression, then that's again a risk factor for suicide. Any more questions? Thank you. Thank you. Have a good day.
Very good presentation, Shelly. Now I will invite Dr. Lokesh to talk about anesthesia management for bariatric surgery. As we all know, anesthesia is required for any surgery, and good pain relief is also needed after the surgery. And in our hospital, we see that the whole family is coming for bariatric surgery. So definitely we have a very good anesthesia management, and Dr. Lokesh is one of the anesthetists who is giving anesthesia for this surgery.
Thank you, Professor Renu, and thank you, Professor Sandeep Agarwal, to give me this opportunity, and thank you, other chairpersons. Anesthetic management in obesity is important. About 10 years back, when I was first posted to this theatre on seeing the patients, it was really scary. A lot of these patients had respiratory problems, and some of them could not even go to the toilet and have problems in breathing. And it is very brave of Dr. Sandeep Agarwal to operate such patients in a setup. Most of them will not have a proper HDU or ICU care available also. So it requires a lot of courage to do such kind of patients, though we have all the facilities available, but routinely it may not be available to all the patients. So in anesthetic management, there are a few patients have a lot of comorbidities. Commonest is the psychological problems, depression, social incompetence. And once a patient said that in the hospital he was not getting the proper size clothes, which was quite embarrassing for the patient as such. Apart from them, other medical problems like diabetes mellitus, nowadays it is in fact being used for treatment of bariatric surgery is being used for treatment of diabetes mellitus or decreasing the dose of anti-diabetics. Hypertension and cardiovascular diseases, obstructive sleep apneas, liver diseases, hypothyroidism is common along with joint problems in these patients. So they may have an increased risk of dying prematurely just because of overweight or obesity as such. However, in the last few years, in a decade or so, bariatric surgery has become quite safe, and the overall mortality is similar to that seen following lab cholecystectomy, and there is a significant decrease in mortality following bariatric surgery. The various challenges faced from anesthesia point of view is, apart from the comorbid conditions, they often have episodes of desaturation. There may be airway difficulty, hemodynamic monitoring, especially during intraoperative period, may have hypotension, administration of doses may be difficult, anesthetic doses and other doses. Also, in the end, you have to have an awake patient, because these patients, if they go on a ventilator, it will be very difficult to wean them off from ventilator. Post-op pain management, avoiding of opioids, and early ambulation and DVT prophylaxis is important, and team of Dr. Sandeep Agarwal does a really good job in the post-operative period. The same day by evening, the patient is asked to move around, and they really do well because of early ambulation in these patients. Other issues are positioning of the patient, may have problems for the staff as well, and you really need special equipment like a big bed, air mattress, big BP cuff, and extra airway equipments to manage these patients. They have varying degrees of obstructive sleep apneas, so increased incidence of desaturation, respiratory problems, or post-cardiac events may be seen, and few of these patients may be on CPAP, which may help in decreasing the risk of complications. So in respiratory problems, as you can see, this is the normal lung volume relations, while in obese patients there is a decrease in FRC compliance, increase in metabolic rate, work of breathing, and there may be episodes of cessation of breathing, a rapid fall in PaO2 in some patients, and some of these may have wheezing, which may not necessarily be because of bronchial asthma, but it may be because of the collapse of the airways. Monitoring pulse oximetry and a fall in saturation during sleep or following exercise may give a good idea of the oxygen status of these patients, and patients who have a fall in saturation may be at a higher risk compared to other patients. In high-risk patients, a pre-op ABG may be important, while patients who have a saturation of less than 95, wheezing, fall in lung functions, and a serum bicarbonate concentration higher than 27 with a higher stop bank score may be at a higher risk of complications. So a pre-operative assessment is essential in these patients, and patients with good exercise tolerance and who can lie flat without getting symptoms of obstructive sleep apnea may have a better outcome. Along with that, we have some cardiovascular problems like hypertension, various arrhythmias, venous thromboembolism, there is increase in cardiac output, there may be a impairment of cardiac function and various changes in the ECG, which may affect the recovery in these patients. As these patients are overweight, so it may be difficult to calculate the doses, and it may be important to titrate the various doses which are needed. They have a large volume of distribution and increased clearance of drugs and decrease in lean body mass. So the pharmacology may be changed in these patients. These are the investigations which may be needed, and in patients who are having cardiac problems, and echocardiography may help in assessment of the cardiac function. They may have a difficult airway, so this ramp is one of the most important things which may make a very difficult intubation simple by bringing the vocal cords just in line with during our laryngoscopy. However, they may have a poor mass fit or intubation difficulty in some patients, and it is important to assess the airway. A Mallampati score may help in assessing the airway, and a circumference, neck circumference of more than 40 centimeter may be problematic in these patients. They may have a difficult mask ventilation and intubation, so a difficult airway cart along with this CMAC, special laryngoscope for intubation, and a fiber optic scope may be essential in few of these patients. Deep vein thrombosis, so requirement of stockings, pumps, and heparin is essential along with early mobilization. As said earlier, you may need to pre-oxygenate during induction, intubation in this RAM position, and may need PEEP during early intubation, and use of shorter acting agents may help during intubation. Because of obesity, sometimes IV cannulation may be really difficult in these patients, and occasionally you are only able to insert blue cannula, which is the finest cannula. So, and titration of anesthetic drugs is important. So normally after induction with propofol, we use oxygen air along with shorter acting relaxant like atracurium and desflurane, and fentanyl infusion are used. Predominantly NSAIDs are being used along with paracetamol, and local pole site infiltration may help in decreasing the need for analgesics. Complete muscle relaxation during surgery is crucial to help the surgeon do a nice job during surgery. These are the various forms of monitoring. Usually an IBP monitoring needs a large cuff. Occasionally invasive blood pressure monitoring may be needed, along with neuromuscular junction monitoring, which may help in assessing the repeat dose of muscle relaxant as well as reversal at the end of surgery. BIS monitoring, this is one of the pi spectral index monitoring, which may help in assessing the anesthetic depth, may help in decreasing the recovery time and dose of inhalational agents. Opioid-free analgesia. In these patients, opioids like morphine are to be avoided. So opioid-free analgesia with dexmedetomidine, ketamine, and or Xylocard may help in having an awake patient at the end of surgery. Also, extubation is important. We have to have a awake patient with pre-op tidal volume respiratory rate. They should have preferably a head lift, effective cuff, and a good vital capacity and inspiratory force, and ideally should not need ventilation as far as possible. This is one of the Normogam apps in which these 5 factors, diabetes, open surgery, OSA, chronic respiratory disease, as well as a revision surgery, is associated with a higher complication rate and ICU admissions after bariatric surgery. This is post-op management. Need to avoid opioids, supplemental oxygen along with CPAP, and a multimodal post-op pain management may help in providing analgesia. Post-op multimodal analgesia decreases the adverse events by almost 30%, and there is significant reduction in the need for opioids. High flow nasal cannula, which is commonly used during COVID times, has been used during induction and also in the post-operative period to decrease the respiratory problems in these patients. So, to decrease complications, we need to pre-oxygenate the patient well. Induction needs to be done in a rammed position. CPAP may be needed. Multimodal analgesia. Avoid opioids. Extubation in awake patient. And CPAP therapy in the post-op period if the patient is already on CPAP. Desaturation monitoring and treatment is important to avoid a catastrophe in these patients. Also, these patients are heavy, so staff may be at risk during movement, and special equipment may be needed in these patients. PONV also needs to be treated early with ondansetron or metoclopramide. Early mobilization and monitoring of saturation is important. This is Society of Bariatric Anesthesia UK. They have these guidelines. They have made this one A4 size thing in which they have suggested the management of these patients from anesthesia point of view, and some of these red flags or important things are abnormal ECG, poor functional capacity, congestive heart failure, decreased SpO2, higher bicarbonate, stop bank of more than 5, which may lead to increased complications, and they need to be assessed properly in the preoperative period. Thank you.
So nowadays, many patients are coming for repeat bariatric surgery after first surgery. So what are the problems in those patients, and whether there is any difference in anesthesia management?
Repeat bariatric surgery depends. Some of them may have some vitamin or nutrition deficiencies, but it depends, because luckily in our part of the world we don't see really super obese patients. So that way we are not in so much of a problem. But of course, psychologically they are not happy because they have had a repeat surgery because of maybe regurgitation or again increase in weight. So you need to work them up psychologically at least. From anesthesia point of view, most of the times workup is done vitamin and nutrient deficiency, and if it is there, then it needs to be treated properly in the pre-op period.
Regarding nausea, post-operative nausea, vomiting, I think it is more in the gastric bypass surgery, isn't it? Rather than the sleeve gastrectomies. Our perinom is more effective in those situations. And one thing you said that we avoid opioids. So is it a rule that we avoid? We are talking about opiate-free anesthesia, but usually we don't avoid opioid in these patients.
Surgeons are very scared of giving opioids, especially long-acting opioids. Morphine. Fentanyl can be given, but it has to be given with proper monitoring, because some of these patients who have a respiratory problem, you give them opioid and they may just have OSAs and they may go off to sleep, and periods of apnea may happen. So if monitoring is there, then it can be given.
No. Metabolic, actually, avoidance of nausea and vomiting is very crucial, and our protocol includes metoclopramide perinom regularly, TDS. And in fact, then patient is discharged, they are put on domperidone for another week. And MSET also initially. So, because we don't want them to vomit or retch. So that's extremely important, and for the same reason we do not use tramadol. We use short-acting this thing, but mainly paracetamol and ketorolac.
Ketorolac.
So those are our main, backbones of analgesia here. But avoid opioids, as said, because it can cause respiratory depression, or avoid retching.
Nausea, vomiting, and respiratory depression. Of course, if you have a good monitoring and setup, you can use it.
But at this point, I must, appreciate the contribution of Department of Anesthesia, Dr. Lokesh, Professor Shinde, Dr. Renu. They have really never refused a case. They have handled most complex of cases. And once we post, we are absolutely sure of very good, safe anesthesia. And actually, we just focus on operating. And I really take this point and thank you, then the Department of Anesthesia, for an excellent support.
Sir, actually for type of cases who are difficult, there should be a very good coordination between anesthetist and the surgeon. One should tell the problems to the other, especially during the surgery also. One or two times there was accidental extubation because of the tube. The tube was being pulled, and at that time accidentally endotracheal tube was also pulled. So there should be very good coordination. Each and every step one should tell the other that last time this has happened, so the person is more wise and careful. And yes, having a team which is working for 100 cases will definitely do a better job than having a new surgeon or new anesthetist. So every place there should be one team to work for those type of difficult cases.
Advancements in the anesthesia, anesthesia equipments, basically use of CMAC and all those things have made airway management much simpler than earlier. And so that has definitely decreased the complication rate.
Yeah, sometimes when I watch the CMAC, I am tempted to put the tube myself.
Yeah, that makes it very
It looks
easy.
so simple.
Is there a cutoff of HbA1c level above which you would deny anesthesia in a bariatric surgery patient?
Actually, I think it is the same as in any other patients. Usually maybe about 7.5 may be okay, but the control has to be good. It should not happen intraoperatively. Usually we may not have a problem, we can start insulin infusions, but in the post-op period it might cause more problems.
Most important outcome is that their blood sugar levels come down to normal within short time. So higher blood sugar should not deter you from taking a.
And also the dietitians, they usually manage an endo people, they regulate. So mostly we are not having much high HbA1c once they are posted for surgery.
Yeah. So we give you prepared patients, that's what you mean. But what he is asking.
No,
Sorry, you want to say something?
I was just saying that pre-op preparation
Ma'am,
by
the
the
immediate,
surgeon.
I'm talking about patient who's immediate, I mean, for the last 2-3 days the sugar is controlled. But yes, sir.
Answer to that question is that like so many things in bariatric surgery, like people say patient doesn't take 2 weeks of diet refuse surgery, patient does that, refuse surgery. So it's like that, it's relative. I mean, if scientifically speaking, yes, HbA1c more than 8.5, there are problems. AHI more than this thing, there are problems. But we do operate these patients because we are unable to get them down. We send them away, they will come back with a worse AHI, unless we are sure. So yes, there are relative contraindications, but in practice, as we all do them with proper precautions. That's my answer.
And when
the sugars come down very rapidly.
Post-op monitoring is essential and treatment of
so there are relative contraindications, certain level cutoffs. Yes, they are there on the paper. I think all my colleagues.
We also do a so high AHI. If you do the polysomnography, their AHI is 80, sometimes 70, and we do, and they do well in the post-op period. So experience and cutoff you can manage.
Once I had done a patient with almost 100, more than 100 patients are there, and they usually do well.
So you grow with each patient experience, and then from 60 to 70 to 80 to 100 AHI. So
for postgraduates, yes, I think it's for the delegates, it's crucial to optimize the patient. But in the presence of an experienced team with a lot of experience, one can be a bit more relaxed than taking a high risk patient. Is that all right?
Is the key
Yeah.
to any surgery,
Absolutely.
specifically for bariatrics.
Yeah.
अगर आपने नहीं किया, you yourself are at
Come up and ask them.
Sir, is there any protocol for is there any protocol for early extubation or keeping patient electively in venti after post bariatric surgery to
extubation, because if you don't extubate them, it will be difficult to wean them off a ventilator. So we need to, at the end of surgery, we need to see that they are awake, muscle laxants and other anesthetics are washed off before we extubate. Otherwise, the extubation criteria is similar as in any other patient.
We tend to
The
extubate them.
question is, when do you would keep the tube? That's what the question.
There is very rare situation when we will keep a tube. We will tend to extubate almost each and every patient, and if some patient require oxygenation is if issue, you can have CPAP pressure support for them. So keeping a tube is not answer to any problem.
Really drowsy or the muscle laxant has not recovered, then you might need to ventilate them in the post-operative period. But that is what has to be seen, that they really don't need it. Some of these patients who are really having a respiratory problem in the pre-op period may need it, but touch wood, we have rarely had such a situation.
Mostly a presence of nasopharyngeal airway is good enough for the things.
Something like a patient having a obesity hyperventilation syndrome.
Yeah.
That they
And
might consider keeping it for a day.
Very rare, it's extremely rare.
and some major surgical complication. These two are the mainly things.
Which is also very rare.
Yeah.
It's very rare to keep it for some anesthetic purpose, like excessive sedation and all that, because whatever medications we use are extremely short acting, and we have got medications to reverse them if they are in excess dose. So that is most of the time not an indication or reason. And we have got one mode called as non-invasive mode of ventilation these days, which necessitates you to extubate a patient because you can manage them without a tube also.
It has been seen once you start bariatric program in your hospital, initially you will have 5-6 patients who will be remain intubated for few days, but gradually you will see that they don't need post-op. Yeah. Short-acting drugs are the key and monitoring. And tell your anesthetist to talk to us.
So thank you, sir. Thank you for an excellent presentation. So it's all
Perioperative care and pre-op optimization. So to enlighten more on that, I would like to call Dr. Karun, a dear friend, consultant laparoscopic and bariatric surgeon at Sir Gangaram Hospital, and the dynamo of our ASI Delhi chapter.
Thank you, Dr. Piyush, and thank you, Dr. Sandeep, sir, for inviting me on this talk. And they are all interrelated topics. All these 4 topics are interrelated. Some things might be overlapped and it's more of a theoretical topic. But I feel this perioperative care in bariatric surgery is very important. Whenever you have a patient in OPD and you feel you can operate this patient and maybe next day or maybe 2 days later, so that I can operate, but better to optimize these patients to have good results. So it's most important, as we have been discussing, like psychologist, dietitian, surgeon, physician, anesthetist, all it's a part of a team in which we have to operate these bariatric patients or any complex surgery. So if your team is well versed, you are tuned to each other, the results would be much better vis-a-vis if we are not tuned to each other or we are fighting in between, like sometime happen, the anesthetist say this cannot be done, surgeon say this has to be done. So it should be a cohesive team which should be there, and definitely results would be much better. So it's to define it, the perioperative care, it's the care that is given during, just before the surgery, during the surgery and after the surgery. This period is used to prepare the patient both physically and also psychologically for a surgical procedure. And specifically bariatric surgery is many of these patients are psychologically dependent on drugs, or they have some psychological issues which require perioperative management. And whatever you inform them and preoperatively, assessment is also required for better care of the patient. So as divided preoperative care, most important thing about preoperative, it starts with the first OPD consultation, where you should inform these patients, and if it's possible, make them go visit the ward. It reduces their anxiety. It's improved compliance with the post-operative instructions. They should know what they are undergoing, what type of surgery is there, what are the expectations of the surgery, what the problems might occur during my post-operative period. If they are well informed, their anxiety is less. So ultimately reduced length of stay is there, long-term outcomes are better. A preoperative psychological intervention is required in many of these patients. So a psychological assessment is done by a psychologist, and in which they see what are the problems which can happen to this patient, they have to identify what are the cognitive problems patient has. Sometimes there might be marital issues, environmental issues, psychiatric contraindications, any eating disorders. These all have to be identified. There are not any contraindications to these surgeries, but they have to be identified, treated, optimized, and then they have to be they undergo surgery, and they should not undergo surgery just after the OPD consult. Sometimes we also miss the psychiatric evaluation. We don't it's not like 100% psychiatric evaluation is not done in private setup sometime, because sometimes the bariatric patient say, I don't have any psychiatric problem. Why are you showing me to psychiatrist? But it is better to show to a good counselor or a psychiatrist before surgery. The other issue which is there is that before surgery, if you optimize these patients, and sometime initially we in any big surgery we used to give the incentive spirometry to these patients, but now with the use of laparoscopy, the use of incentive spirometry for big surgery, at least in laparoscopy, has reduced. But these patients should not be very lethargy and not doing exercises or not taking walks. If they do exercises and do prehabilitation and do some walking, so the results are much better, their recovery is better, their surgical stress is less. So if we can optimize these patients and make them ambulatory, would be much better. And always its criteria is there that tobacco smoking is associated with increased post-operative morbidity and mortality. There is reduced tissue oxygenation, higher chances of pulmonary complications, and they increases the chances of DVT and thromboembolism. So the minimum requirement of smoking cessation for bariatric surgery, they say it is 4 weeks according to literature. But yeah, definitely I agree. I have also operated patients who have come to me, and we tell them to quit smoking. Sometimes they do, sometimes they don't do, but at least the anesthetist should be informed about these things. The patient should tell the anesthetist so that it can be optimized. The ideal is 4 weeks prior to surgery, they should be reduced or stopped. The other issue is of the alcohol issues. Alcohol cessation should be there. Here also they say if it is patient is a habitual over volume eater, which is said to be 3 alcohol equivalents of 12 gram ethanol more per day, the risk are higher of post-operative complications, and in them it is minimum 1 to 2 years of alcohol absence is required for them to undergo bariatric surgery. If person is not a very volume alcohol eater and not taking regularly, then they say it's better, according to literature, 4 weeks is the time that they should stop it. Also, alcohol issue arises in some of these patients post-surgery, go into depression, and if they are taking alcohol, the alcohol dependence increases after the surgery. So they have to be counseled, and sometimes a psychiatrist has to be seen before the surgery. The other thing which has to be optimized in these patients is sometimes they have a lot of fatty liver, grade 2, grade 3 liver, heavy liver, which are reaching sometime up to the umbilicals also they can be reached. So if we give them a very low calorie diet, that is 800 calorie diet for 2 to 4 weeks is the period which is there, they are given. So they lose some amount of weight, sometimes 4 kg, 5 kg, 6 kg, depending upon how much obese they are. But it reduces the liver size by 60 to 20% in 2 to 4 weeks. And it has also been seen those patients who lose weight by very low calorie diet, post-operatively also they do well, and it is an indicator that they are not cheating during the that time when they are undergoing a very low calorie diet. And if they don't lose weight, we counsel them that you are doing cheating, post-operatively also you can do cheating. So it becomes an indicator, and you can write this in your discharge summary also. So it becomes like a indicator, like if patient did not lose weight and subsequently patient does not lose his weight post-surgery, maybe he loses 10 kgs weight, and he says that, doctor, I will see you because I didn't lose weight, you guaranteed. But then we can say, if we have that documentation that the patient did not lose weight that time also, that means he is doing some cheating and he's not following our diet plan. The other issue which we have to always follow, optimize these patients nutritionally also. They are obese, but they have malnutrition. Sometimes they have we also have a lot of calcium, vitamin D deficiency, B12 deficiencies. If we detect them preoperatively, it's better to correct those preoperatively, because when the patient is on low calorie diet and when he is on liquid diet, there it will be very difficult to get them corrected easily. So whatever, if you are having deficiency you identify before surgery, they should be tried to be corrected as much as possible before the surgery. That optimizes the results. And if the physical activity, as I told before also, 30 minutes physical regular activity before surgery, if they do, it increases the outcome of the surgery. The other issue these patients can have are eating disorders. And these are not generally contraindication, but they should be identified and corrected before the surgery so that the post-operative weight loss is much better. If they are not corrected, the chances of weight regain over a period of time are higher. Binge eating disorder, sub-diagnostic binge eating disorder, night eating disorder, this I have seen so commonly in my bariatric patients. I would like to confess, many of these young patients are sleeping at 1 o'clock, 2 o'clock in the morning, and they have an extra meal in the night at 12 and 1. And this is, most of these patients are, which are young, I am seeing them. And when we do, if we correct that thing also, ultimately bariatric surgery is just a tool. Ultimately, person has to correct his lifestyle. If he does not correct his lifestyle, whatever surgery we do, ultimately over a period of 3 to 4 years, they will gain weight. So most important is the person has to change his lifestyle. Whatever he is doing wrong has to be corrected before surgery, and has to be informed to him before surgery that these are the things you are doing wrong and these have to be corrected. Because after, if we say them after surgery, now you are doing this, doctor you did not told me before, now after surgery how will I do it, whatever I will do it. So there can be lot of differences between the doctor and a patient and a surgeon. So all has to be informed. And bulimia nervosa is absolute contraindication. Until unless that is corrected, then only it should be performed. The other issue in these patients is most of these patients are obese. They have restrictive lung disease because abdomen is huge. The lung gets compressed. Many of these patients have asthma. Some of these patients would be smoker. So these patients have to be optimized. If they have asthma, they have to be given adequate inhalers, and pulmonary function test would be required. And as discussed now also, like many of these patients have obstructive sleep apnea or obesity hypoventilation syndrome, and it's better to err on the side of getting a diagnostic sleep study test done and see what is the sleep study is, vis-a-vis not getting the sleep study done, because in private setup we have a cost restraint also. This costs 10, 15, 20,000 depending upon the setup, but it is better to undergo sleep study. If you are in doubt, better to get it done, so that if post-operatively any issues are there, you know what pressure it has to be applied, what are the, and if sometimes these patients are very hypercarbic, they have fluid overload or right heart failure also, and these patients have to be optimized with diuretics, reduce the swelling, so then undergo surgery vis-a-vis going early surgery. The other issue is the DVT, venous thromboembolic event. It is the most common cause of mortality. 50% of the mortality in bariatric patients is because of DVT. So it has to be, it is a preventable cause, and as we know, it's a hypercoagulable state. So it has to be a multimodal prophylaxis which should be followed. Would be what we do in our hospital is like intraoperative pneumatic compression with the stockings, with chemical prophylaxis, that is the low molecular weight heparin. All the three are generally done in most of the patients until and unless patient is a very high risk for bleeding disorder, like we are doing a chronic liver disease, or patient was on chronic artery disease, CAD, in which we cannot stop the blood thinners for long duration. In them we do mechanical prophylaxis and early ambulation. Otherwise we try to do all the three. And there are a lot of studies which are now there, in which initially unfractionated heparin used to be given, but now the drug of choice generally is low molecular weight heparin, because they can be titrated. It is single dose is there, subcutaneous is there, the reduced incidence of thrombocytopenia is there. Generally 5,000 units 1 day, 12 hours before surgery. After surgery, 12 hours after surgery, we start the low molecular weight heparin again, and then based on the there are no fixed guidelines what to do, but generally based on criteria we do give it for 5 days for less than 40 BMI, then 10 days for 40 to 50, then 2 weeks, and then 3 weeks for more than 60 BMI. But they are all variable guidelines are there. There are no fixed guideline, but whatever suits you. But longer duration of prophylaxis for high risk patients prevents these thromboembolic events and decreases the mortality. So this is the same. Now they are saying that it should be weight adjusted. Sometimes if it is more than 50, you might have to give 10,000 units also. But I must confess that I have not been, I am little skeptical and I have not been using, but literature says that you can give up to 10,000 also for these patients. There was initially lot of interest of use of IVC filter in these patients who are more than 55 BMI, in which anticoagulants cannot be given, history of pulmonary hypertension, obesity syndrome. But generally, nowadays IVC filters are generally not required in most of the patients. The IVC filter has its own set of complications like thrombosis, occlusion, filter migration, filter removal is a lot of issue, contrast-induced nephropathy. So generally, present indication, IVC filters are very frequently used nowadays for prevention of pulmonary embolism for bariatric patients. The other issue, as we go, always have an upper GI endoscopy before surgery. If you find H. pylori, it's better to eradicate before surgery rather than after surgery. Generally, initially it was when we were getting trained with Dr. Chaube, we were giving bowel preparation for all our patients, but generally it is not required in these because we are doing a upper small bowel surgery or a stomach surgery. Where, colon is nowhere involved, so generally it's not required. It has its own side effects of dehydration, electrolyte imbalance. Sometimes they can go into ileus also. If it is required, then one day before you should give liquid diet, maybe 1 liter of Paglec, and adequate fluid should be replaced if you are doing a bowel preparation. There is lot of discussion about ERAs, which I will be discussing, in which one of the component is you give 90 minutes before the surgery a glucocorticoid 2.5 to 5 mg, and it reduces the inflammatory response, reduces the post-operative nausea, vomiting. But if there are diabetic patients are there, you have to monitor them the sugar very aggressively. Initially, the preoperative fasting used to be overnight, but now they say you can take clear fluid up to 2 hours and solid 6 hours before. So the catabolism is not happening early, so that helps in overall recovery of the patients. The other thing which is happening is carbohydrate loading is being done. In lot of theses also in our surgery is going, like you take a high ASO osmolar 2 to 3 hours before the induction of anesthesia, take a liquid diet. So that attenuated development of post-operative insulin resistance, reduce both operative nitrogen protein loss, and maintain lean body mass is there. But this is plus minus, some literature is there, but the compliance with this is less than 15%. The main now comes the intraoperative intervention. What I would like to emphasize, anesthesia point, ma'am has they have specifically told that you should not compromise on the OT table. Don't take a OT table which is not good. You should take a good OT table in which you can do a steep head rise. You never know what complication you have. When you might start with the low BMI patients, but ultimately you would be doing high BMI also. And sometime you require a steep head up position. You require a good split leg. You should have the pressure points be monitored, pressure point be padded, because if these obese patients sometimes can go into rhabdomyolysis post-operatively and can have renal failure. So they should not compromise on these things when you are starting with your bariatric program. Better to have all these things beforehand also. Perioperative fluid management, anesthetists have told us that it's not very required to be very aggressive on fluid management. Neutral fluid management with 15 ml per kg IV fluid is most of the time required, and that also prevents the rhabdomyolysis. And it's a little complex perioperative fluid management because these obese patients have we feel that they have more blood volume, intraoperative blood volume, but per kg it's less than the normal, that is it's 50 rather than 75. They have a lot of sometimes comorbidities like heart failure or COPD. So sometimes they require monitoring of the arterial monitoring is required. The best monitoring is, they say, is that you measure the stroke volume, and guided by that you can give fluids if it's a very complex patient. Anesthesia, what now they say is that propofol for induction and maintenance of anesthesia, IV anesthesia is best rather than initial anesthesia or volatile anesthetist. Minimum use of opioids and avoidance of fluid overload. And in these patients, to prevent post-operative nausea and vomiting, it's best to have a multimodal treatment, use steroids, use anti-aldosterone, use perinorm, and if you use those three and avoids opioids, you can prevent most of the post-operative nausea and vomiting. Now there is a lot of evidence that drains does not prevent a re-exploration. So if you feel it's required for hemostasis, then also it's, well, drain use is not, there is no advantage of using a drain in a bariatric patient, and it will not prevent re-exploration in most of the time. Now, some post-operative intervention, this is a multimodal analgesia treatment is given for post-operative pain. You can use NSAIDs, you can use blocks. We have published a paper of a TAB block, bilateral TAB block to prevent early mobilization. You can give a local infiltration of local anesthetic can be given. Sometimes thoracic epidural has analgesia has also to be given, but not much advantages there. So multimodal treatment of pain is best. You use all the things except the opioids if possible. Avoid opioids. There is a little bit controversy of whether to get a gastrographin done post-operatively, but I feel maybe not for patient point of view, but at least medico-legally, because most of our patients are now discharged the next day. So if you have done a gastrographin and if its leak is not there, so at least medico-legally, if on 5th day patient comes with a leak, we can at least say that we got a test done on day 1 and it was not leaking, patient was fine, then we discharge it. That's the only advantage I feel now, because if patient clinically is able to eat liquids well, so not much we will have, we'll gain with the with the gastrographin. The other thing which we gain by gastrographin sometime is we can see how much fundus has been left, how much antrum can be seen, but that is all no advantage to the patient. So now the post-operative nutrition has to be well managed, because they can go into catabolic state. They have to take iron, calcium, multivitamin. Early liquid diet we start within 2 hours of our surgery, and most of these patients, because we are all vegetarian most of the time, non-vegetarian also occasional, they require high protein diet and supplements during the early post-operative period. And 1.5 to 2 liters of fluid they should take, and we monitor their iron, calcium, multivitamin. This is an issue which we were discussing, that there are 3 categories of patients: obese patient without obstructive sleep apnea, obese patient with diagnosed obstructive sleep apnea, and obese patient without diagnosed obstructive sleep apnea. So these patients have most of I'm finished. So these require good oxygen monitoring, good oxygen saturation monitoring, and if you feel that patient is desaturating or has a hypercarbia, there is no harm in giving CPAP or BiPAP. It does not increase the chance of leak most of the time. This ERAS protocol, most of the things I have discussed, it is coming in bariatric surgery also. In COVID times, in most of our patients post-COVID, 95% of our post-COVID patients we are doing in daycare bariatric. We are calling them in morning and discharging them in next morning because of this ERAS protocol, and patient did not want it to stay. Then we gained confidence as we were able to manage these patients daycare. We were able to reduce the cost of the patient. Ultimately it benefits the patient and the surgeon both. So thank you.
So what I feel that for a lot of these patients, surgery is the only way to optimize. And for some, we need proper pre-op optimization. So the question remains, how much optimization is optimization? So we need to draw a line in between. For that, we need other subspecialties.
Everything will not suit everyone. Every patient is an individual patient. We have to take that individual patient into consideration and optimize that patient. If we feel that we can optimize this patient, like if patient is a more than 50 BMI patient with heavy liver, grade 2, grade 3 fatty liver, patient will definitely get benefited by doing a very low calorie diet for 2 weeks, and it will surgeon will also get benefited, and overall the results will be much better.
Exactly. So we can have quick 1 or 2 questions before we wrap up for this session. Okay, thank you, Dr. Tarun.
Thank you.
With this, we come to the end of session 3. Thank you, chairpersons. Now, I'd like to invite the chairpersons of session 4. Dr. Shalimar, Professor, Department of Gastroenterology at AIIMS. Dr. Ashish Vasishtha, Senior Consultant, Bariatric and Minimal Access Surgery, Max Super Specialty Hospital. Dr. Suhani, Additional Professor, Department of Surgical Disciplines, AIIMS, New Delhi. Meanwhile, I'd also like to remind the delegates, live surgery session will be starting tomorrow at 9 a.m. However, all of you are requested to come here at 8 a.m. sharp. Breakfast will be served. And please don't be late as the surgery will start sharp at 9 a.m. Thank you.
Yeah, so as you said, come at 8, don't waste your time in breakfast at a hotel. Breakfast will be here. And hopefully we start before 9. The idea is to get the 3 procedures done and leave, so that you are free early. So don't be like sleeping after the party and, That's the, you'll be able to watch the procedures live.
Yeah, so we can start this session. As already running about 15-20 minutes late, but that's not much. So on this first talk by Dr. Amit Bhamri, I'd like to invite him for outcome impact of bariatric surgery on weight loss and comorbidities. And let's, he's from Ludhiana, so welcome. Looking forward to this talk, please.
Very good evening, everyone. At the onset, I would like to thank Professor Sandeep Agarwal, sir, my mentor, for giving me this opportunity to talk on impact of bariatric surgery on weight loss and comorbidities. I may extend by a little more time because there's a lot of impact on many spheres on systems after bariatric surgery. Myself, Dr. Amit Bhamri, I'm from Ludhiana. I'm leading a bariatric and metabolic surgery department at SPS hospitals. Factors affecting outcomes of bariatric surgery seems to be patient dependent, type of procedure we choose, and surgical techniques. It is true to a great extent. Bariatric surgery results in greater weight loss and initial remission of comorbidities than non-surgical treatments. Long-term observational studies and randomized controlled trial, initial remission of comorbidities after trial have been directly compared with bariatric procedures with medical lifestyle intervention for type 2 diabetes patients, and they are more effective. So one of the most important studies, Swedish obese subject study, also known as SOS study, which was a long-term prospective controlled trial to provide information on effects of bariatric surgery on weight loss, diabetes, cardiovascular events, cancer, and overall mortality. In this study, around 2,000 patients underwent bariatric surgery, mainly gastric bypass, gastric banding, and vertical banded gastroplasty, and with around 2,000 control subjects. Period was as high as 12 to 25 years. Mean change in body weight was from 2 to 20 years was around 18 to 23%, and whereas in the control group was just 1 and 2% only. There was long-term overall reduction in mortality, which was the primary endpoint of the study, and decreased incidence of diabetes, myocardial infarction, stroke, cancer in surgical groups as compared to the control group. Here we can see all the surgical groups had much lower outcomes, much higher weight loss as compared to the control group. And the patients underwent surgery. At 2 years, there was high amount of diabetes remission, but around 50% of the patients had remission at the end of 10 years. Also, the patients who didn't have diabetes, there was more chance of patients not developing diabetes by 75% by 2 and 10 years than patients who didn't undergo surgery. Similarly, on the cardiovascular deaths, they were lower in the surgical group. Both fatal and non-fatal incidences were less, and even MI and stroke were less in the surgical group. The incidence of cancer in the surgical group was much less as compared to the control group. However, the incidence of cancer in women cohort was less than, and it was equal in men cohort between surgical and control groups. There was around 29% reduction in mortality, and the limitations of this study were it was done in old era between 1987 and 2001, when most of the common procedures performed then were VBG, and these days it's OAGB, sleeve, and RYGB, and it was a non-randomized trial. Another trial which was very important in the common procedure performed today is RYGB. It was Utah obesity study. And in this, around 7,900 patients of RYGB controlled matched with control group. And baseline BMI was obtained from the medical records for the surgical patients, and it was and a baseline height and weight of the control group from the driver's license data. And at 7-year follow-up, RYG patients had 40% reduction all mortality, 49 and 92% respectively cardiovascular and diabetes-related mortality as compared to the control group. Also, this UTHA group has been prospectively doing study on 1,000 subjects, including RYGB, with 2 non-randomized control groups with severely obese patients, and examine the endpoints of weight loss, diabetes, hypertension, dyslipidemia. And at 6 years, they show superior in RYGB group as compared to the control group. It is 27% in the control surgical group and 0.2% in the control group. So now coming to the weight loss, I would like to highlight this study, which is long-term study of most commonly performed procedures, sleeve, RYGB, and 1 anastomosis. It was published by a group of Carbajo et al. And it's a prospective randomized control study of morbidly obese patients between 2010 and 12. And 3 groups were done, around 200 patients each, total of 600 patients. And at the end of 5 years, it had follow-up of around 90+%. The excess BMI loss after OAGB was much higher than RYGB and sleeve gastrectomy at 1, 2, and 5 years. And at 5 years, OAGB achieved significantly greater remission of type 2 diabetes, hypertension, dyslipidemia than Roux-en-Y and sleeve. However, RYGB did not show any significant superiority over sleeve gastrectomy in short and long term in diabetes and hypertension, but had greater remission of dyslipidemia. So sleeve and RYGB was performed in a routine manner in which we perform, but in this group, the OAGB performed was different by Carbajo group, which do OAGB, which is a variant of MGB. They did around 200 to 350 centimeter length of bypass and left common limb of around 180 to 250 centimeter. And the ratio between BP limb and the common channel limb was 60 to 40. So at the end of, between sleeve, RYGB, OAGB, the sleeve had again gain of the weight, gain of the BMI, but OAGB had the best results at the end of the 5 years. Similarly, it was seen that OAGB, it was 92% at the end of 1 year, but 95%, almost maintaining or even going up. But sleeve and RYGB had certain dips. Similar trends were seen in hypertension, but in dyslipidemia there was 100% remission in MGB even at 5 years. So I would like to highlight another 10-year long study by VJ Lee group on the mini gastric bypass versus Roux-en-Y gastric bypass. It was done around 1600 patients between 2001 and 2010, around 1100 MGB patients and 500 RYGB patients. Patient could choose procedure by themselves. RYGB was standard and MGB was also the more type which we perform in our centers. Like it was anticolic Bilrod 2 type gastroenterostomy and 200 centimeters from DJ. So 5-year comparison between RYGB and MGB, MGB performed better in more BMI loss and more weight loss. But at end of 5 years, HB hemoglobin was lower in the MGB group and mean corpuscular volume was lower in the MGB group, more iron deficient. So outcomes in diabetes mellitus, this was a stampede trial, surgical treatment and medications potentially eradicate diabetes efficiently. It was performed by Philip Shore in 1 and 3 year after randomization in both gastric bypass and sleeve gastrectomy groups was superior to intensive medical therapy alone, and they achieved better glycemic control. HbA1c was less than 6 and even better cardiovascular risk, improved quality of life. In this, around 89% of follow-up of 150 patients included 5-year assessment, and one patient in the sleeve gastrectomy had HbA1c of more than 9, so underwent gastric bypass. One patient in the sleeve gastrectomy underwent gastric bypass because of gastric fistula. So in this, the effect on HbA1c was better in sleeve and bypass groups as compared to the control groups. At end of 60 months of 5 years, the patients who were having no medications or insulin was much higher than the control groups. Outcomes on the BMI were better in the surgical groups as compared to the medical group. And there was no difference between the surgical group or less than 35 BMI, more than 35 BMI, as compared to the outcomes. Now, Stampede trial takeaway points are gastric bypass and sleeve gastrectomy patients are significantly more likely to achieve HbA1c less than 6 as compared to the control groups. So next, coming to effects outcomes on OSA. This was a study done on 13,900 patients. Mainly procedures were done by BPD, which is not done these days routinely, sleeve gastrectomy, RYGB and LAGB. So improvement in bariatric surgery for OSA is weight dependent, like decreased mechanical force on neck, upper airway and diaphragm movement, and also on weight independent mechanisms by a mnemonic BRAVE, bile flow alteration, reduction in gastric size, anatomical rearrangements, vagal manipulation and enteric gut hormone modulation. So after sleep apnea and obesity, because tumor pro-inflammatory factors like TNF alpha and IL-6 are decreased, and they are the specific markers for sleep apnea, and if they decrease, sleep apnea also gets decreased in these patients. I would just highlight on the sleeve group, it was excess BMI loss of 46%, and there was overall improvement of 86% resolution or improvement in 86% of the patients. Similarly, in RYGB group, around 79% patients had improvement. So very important on impact of bariatric surgery on liver diseases. This was a study done at this institute itself. It was to see NAFLD by assessment using paired liver biopsy and fibroscan. It was a prospective study evaluated by the effect of bariatric surgery at 1 year and changes in liver biopsy, clinical and biochemical parameters. So liver quality was assessed by a transient elastography to see hepatic steatosis, fibrosis non-invasively. And the primary outcome of this study was to see the grade of steatosis, stage of fibrosis at 1 year after surgery using liver biopsy and fibroscan both, and secondary outcome on weight loss and metabolic syndromes. Around 167 patients underwent transient TE measurement and histopathologic grading preoperatively. Of this, 141 were completed follow-up at 1 year. Around this, 58 patients consented for liver biopsy, and it is the evidence shows that a weight loss of 10% leads to 90% resolution of NASH. In this study, patients had weight loss of 31.36%, and this explains the significant change in histology in hepatic steatosis, lobular inflammation, ballooning, NASH, and fibrosis. Even NAS score, NAFLD activity score, decreased from 2 to 1.31. So impact, there was impaired regenerative capacity of liver with increased age seen in the study. 17.2% of the patients showed worsening of fibrosis with advanced age. So it can be postulated that bariatric surgery, if considered at a younger age, may lead to improved outcomes in NAFLD. Interesting finding in this study was 3 patients who had cirrhosis on intraoperative liver biopsy underwent 1 year follow-up, and 1 patient reversed to stage 1 fibrosis and another to stage 3 fibrosis, and the third remained in stage 1 and didn't deteriorate. So conventionally, the notion that once a cirrhosis, always a cirrhosis, that is irreversible, is a changeable phenomena. And this study was further studied for this cohort for advanced liver fibrosis, and it was a retrospective review of prospectively controlled data between 2014 and 18. All patients with cirrhosis and advanced liver fibrosis were on an intraoperative liver biopsy, that is stage 3 and stage 4 were included. If incidentally grossly nodular liver was seen, they were also included. So 2 categories were formed: cirrhosis and stage 3 fibrosis. Cirrhosis was nodular nodularity on laparoscopy, stage 4 fibrosis, and features which were seen on histopathology biopsy, other causes of cirrhosis, and rest patients were categorized in stage 3 fibrosis. So in this study, total 38 patients with advanced liver fibrosis who underwent bariatric surgery, 22 had cirrhosis and 16 had stage 3 fibrosis. Mean age was 41 years, mean BMI 47, and liver stiffness measurement to see steatosis, to see fibrosis was 15, and CAP was 352. So 81% patients came for follow-up, and mean follow-up was for 34 months. BMI dropped to 33.1 kilogram per meter square. 7 patients showed worsening of TE 3 in cirrhotic cohort, and 3 in fibrosis, and 4 in fibrosis cohort. 12 patients consented for liver biopsy at the end of 1 year, and 9 patients had improvement in fibrosis, while 3 had no change in fibrosis. So this is a very interesting finding. Stage 4 patient fibrosis converted to stage 0, stage 4 converted to stage 3, stage 4 converted to stage 3, stage 4 remained at same level, and stage 3 nodular liver was improved to stage 0. So effect of bariatric surgery on GERD is prevalent in approximately 45% of morbidly obese. This study, bariatric outcomes in longitudinal database, almost 1,16,000 patients were included. Of this, 36,000 patients had GERD, but the patients who underwent either hiatal hernia repair, fundoplication were excluded. So around 22,000 patients were there with 6 months follow-up. Predominantly, most common procedure performed in this study was RYGB, followed by gastric band and sleeve gastrectomy. Weight loss was significantly greater in RYGB group compared with sleeve gastrectomy. GERD was best improved in RYGB cohort. GERD worsening was seen mostly in sleeve, followed by Roux-en-Y and gastric banding. So in this study, period-wise comparison was showed between RYGB is better than both gastric band and sleeve gastrectomy. RYGB is better in improving GERD. AGB is better than improving sleeve gastrectomy for the GERD. And all patients showed significant improvement in GERD composite score. The more the weight loss, the better is the GERD score. The group of people who had low weight loss, excess weight loss, or regained the weight had lower GERD improvement. If excess weight loss category was kept constant, RYGB performed the best in this category for GERD. So the takeaway points are that sleeve has very controversial data. Some say it improves after bariatric surgery, some say it deteriorates after bariatric surgery. However, major studies shows that if hiatal hernia repair is done with sleeve gastrectomy, usually it shows improvement in GERD. OAGB improves reflux in majority. Hiatal hernia repair is usually not recommended as a simultaneous procedure, and if patient is having large hiatal hernia, it is preferable to do RYGB. Procedure of choice in GERD is RYGB. So in hypertension, this was another trial, randomized single center non-blind trial in patients having hypertension using more than 2 medications at maximum dose or more than 2 at moderate dose with BMI of 30 to 39. Patients were randomized into RYGB plus medical therapy or medical therapy alone. Included 100 patients, mean BMI was 36, and 96% completed follow-up. So RYGB group had 83% reduction in more than 30% of the drug dosage, and had 1 year remission in 51% patients, but control group had negligible results. We can see bypass performing much better than medical therapy. On hypothyroid, in morbidly obese hypothyroid patients, the thyroxine replacement requirement is increased because of enlargement of their fat mass. Moreover, impaired pharmacokinetics in severely obese is because of the high volume of distribution. This was a study done at this center. Around 93 patients were included for the final analysis. Mean BMI was 47, mean follow-up was 29 months. Excess weight loss was 59%. 55% of the patients, 52 in number, decreased their thyroxine dosage, and 37 patients, 39% had no change, and 4 patients increased their requirement. In PCOD, PCOD is most common endocrine disorder affecting women of reproductive age with prevalence of around 8%. PCOD can happen in both obese and non-obese women, and this meta-analysis was performed on women having PCOD, hirsutism, menstrual irregularity. Around 2,100 females were identified with mean follow-up of 23 months. Preoperative BMI was 46 and improved to 34. And all patients with PCOS from 45% decreased to 7.1 in 1 year, and with menstrual irregularity from 56% to 7.7%. And in other parameters also there was a marked improvement. So PCOS is usually simultaneously associated with insulin resistance, elevated glucose, sleep apnea. This leads to a term derived as syndrome XS in females with hyperandrogenemia and anovulation. So impact on cardiovascular diseases, it was another trial, a retrospective matched controlled trial between 1990 and 2018 in UK, and BMI 30, patients BMI 30 above was included. Total 5,100 were in a exposed group and around 10,000 in control group. Gastric bypass has significant impact on coronary vascular disease, statistically significant decrease in incidence of heart failure in Roux-en-Y gastric bypass group, and significant reduction in overall mortality in gastric band. But there was no significant reduction in ischemic heart disease in RYGB group or transient ischemic attack or atrial fibrillation. And on psychological aspect, this study, there were 107 extremely obese patients included with face-to-face interviews at 6 to 12 months and 24 to 36 months. It showed significant decrease in depression, need for antidepressants in the surgical group, but there was no significant decrease in the anxiety disorders. And it is worth highlighting that patients with depressive disorders, the results are suboptimal after bariatric surgery. And on the quality of life aspect, it was done based in Netherlands between 2015 and 2017. There are multiple parameters to see the quality of life: BAROS, bariatric analysis and reporting outcome, short form 36 and RAND 36. In this study, RAND 36 questionnaire was done checking physical functioning, social functioning, physical limitation, emotional limitation, mental health, vitality, pain, etc. This is the RAND 36 performer. They did questionnaires, and around 4,800 patients were included. Most of the patients had better physical functioning, better physical role limitation and health change, but the health perception of the patient after surgery in sleeve gastrectomy was poor. So this can be hypothesized that those patients who had RYGP patients had better resolution of comorbidity, so they felt better. And usually sleeve, the higher BMI patients who had more problems were suited, high-risk patients were suited for sleeve gastrectomy group. So they had worse health perception as compared to Roux-en-Y gastric bypass. So last but not the least, effect on life expectancy. American Society of Metabolic and Bariatric Surgery statement says that all factors causing mortality after bariatric surgery are reduced and long-term survival is increased. Bariatric surgery leads to treatment and remission of diabetes and reduced death rates because of diabetes, and reduced coronary vascular diseases and deaths related to that, and reduced certain cancers and improve quality of life. So what is take-home message? Obesity is the mother of all diseases. By treating obesity, one treats many of its associated comorbidities for good. Bariatric surgery is a highly effective tool for weight loss and comorbidity resolution. Without proper usage of this tool, improper surgical technique, etc., the tool can lose its effectiveness, leading to inadequate weight loss, comorbidity resolution, and even weight regain and relapse of comorbidities. This tool should only be used for patients fulfilling guidelines recommended by various national and international obesity surgery societies, and close follow-up is mandatory for long-term excess weight loss and comorbidity resolution. Thank you.
Thank you, Dr. Amit, for such a nice presentation and quite comparison about sleeve and MGB. The end is a conclusion. These three procedures has to be done in a different way in different scenario patients. So how's the quality of life in an MGB which is coming up in a big way? You have not mentioned that. What do you feel the quality of life, study has been done, quality of life in MGB patients?
Sir, I could not find out for MGB, the quality of life, but usually patients after gastric bypass have more abdominal symptoms as compared to the sleeve. And because the resolution of comorbidities after MGB is superior as compared to, and the weight regain chances are lower as compared to the restrictive sleeve gastrectomy. So it's in long run it should be better.
Yeah, so I also feel that what segment we are taking, like if we are crossing 250, 300, there's a last segment in an MGB. But if we keep it rational within 200, the quality of life is also very positive, the weight loss, the comorbidities. So studies will come which will compare this with that.
Yes.
But very nice presentation, quite lucid.
Thank you.
Anyone else, please?
Welcome to the mic. Yeah. Just put on red light.
So how to approach a patient with like bariatric patient, NASH-associated cirrhotic child A without portal hypertension. Will you go for surgery because AIMS study is showing that it is reversing cirrhosis? Or like no clinical portal hypertension, will you go for surgery in such cases? Or
I would like to highlight a case who had macronodal cirrhosis, grade 3 esophageal varices, severe portal hypertension, splenomegaly, and he had BMI of around 60, absolute weight of 180. We went ahead with the surgery, obviously after explaining all the risk factors and taking consent even for liver transplant in future he might need that, and he did really well, though we have faced difficulties intraoperatively.
so it was still sleeve? Sorry to interrupt.
We did sleeve, yeah.
Okay, sleeve only.
Only
no, that-
sleeve is recommended in
Yeah,
such patients.
Okay.
So-
Please.
So it's not only our experience, there's enough data. There are series with more than 100 paired biopsies which have shown excellent impact on cirrhosis. And then we have a systematic review, I can send you the link, which we have published in Surgical Endoscopy, where we have compared all the data of the cirrhotic patient undergoing bariatric surgery. And you can see the change in improvement, dramatic improvement in these patients. And what Amit said, portal hypertension, yes, you have to be careful, but in child's A, with portal hypertension, it can be done. Obviously, you have to be careful about intraop hemostasis, maybe use some reinforcement, but cirrhosis is not a contraindication. Yes, we should do only sleeve in these cases.
In data,
Only the patient needs to be counseled beforehand. And now, how do you know beforehand? There are investigations, there are studies going on. So you can ask them if your liver is cirrhotic intraop by surprise findings. Do you want us to go ahead or not? Yes, yeah, it's not only our experience. Yeah, biopsy proven. Yeah. Exactly. And Dr. Shalimar is here. He's a very renowned hepatologist who supports our program.
So just add on to what Sir has said and what you'd asked is child A. I think that the emphasis should be on. You're only including patients with child A. You're not including child B and C. So over there is a combination of bariatric and transplantation being done where you got a decompensated liver. There you're not contemplating a bariatric surgery. So you need to choose selectively. And varices is still not a contraindication. So that's it. You need to choose specific patient. So the role of TIPS comes in when your hepatic venous pressure gradients are high.
Yes.
So over there, people have used, like in general surgery, you want to do it, you want to reduce the ascites, dry the patient up, then take the patient for surgery. We do not have data on bariatric surgery and combination of TIPS as of now. And use of any invasive procedure, unless it's really indicated, I think we need to really think about it before you got more data to recommend its routine use. So TIPS for now, absolute not required.
And even the initial fear of a decompensation in the early postop period is actually unfounded, because we have not, except one or two occasional case where we had a transaminase rise and we could manage with the liver diet and all. Actually, there is no immediate mortality. In fact, whatever has happened, some of the patients have worsened. I'm not saying all the cirrhotic patients improve. One or two patients have worsened and gone to liver failure and died over a longer period, but not because of surgery.
Yeah, I think that's very important, is like you need to carefully choose your patient and manage them very aptly when you're doing it for this. So my just one question, Amit, you had a very good presentation. So is it the amount of weight loss which matters or the type of surgery which matters? So if, say for example, if either type of surgery gives you a similar amount of weight loss, are you having similar improvement in your comorbidities, though you showed some data on specific individual complications or say comorbidities?
So related to liver disorders or?
In general.
In general, like if I talk about diabetes and bypass procedures are better than sleeve gastrectomy. And if patient is having higher BMI, bypass procedures are better than sleeve gastrectomy. And even other comorbidities, the data also says that bypass procedures are better. And from the bypass also, the recent data shows that MGB has even better results than Roux-en-Y over long term.
No, fair enough. With the type of surgery. But what I'm just I'm more curious is weight loss is the crux. That's
Weight
what
loss,
you're
yes.
targeting. So for a same amount of
So
weight
there
loss
are
with
some
different
mechanisms
surgeries.
which next presentation will highlight, which lead to better outcomes in comorbidities after bariatric surgery, other than weight loss. Weight loss independent mechanisms also. There is one question.
Good evening, sir. So we have seen that there are miraculous result of bariatric surgery over the control of hypertension and diabetes. If does the same results could be replicated if the surgery had been performed over non-obese, uncontrolled diabetic or hypertensive patients?
So this can be the future. Like if BMI less than 30, only purely metabolic surgery can be there. So the length of bypass done is around 100, 110. So you achieve a metabolic effect, but not the weight loss effect.
I think there's a talk by Dr. Kallan on this. You can again. Thank you.
For the next talk, we have Dr. Vitish Singla. He'll be talking on mechanisms of weight loss following bariatric surgery. Vitish has been our resident par excellence, and he's a final termer with minimal excess MCH program, and he aspires to be a bariatric surgeon in the days to come. Over to you, Vitish.
Good evening. First, I would like to thank Professor Sandeep Agarwal sir for giving me the chance to present in BARIME 2021. So, coming to the topic, mechanisms of weight loss following bariatric surgery. So, it has already been covered in the first talk. The discovery of bariatric surgery. I just put it in this slide so that like how we got to know that bariatric surgery is like the weight loss occurred following bariatric surgery. Actually, it was a like incidental discovery. First, when patients underwent ileal resection, they were found to have weight loss, and then further, when patients with peptic ulcer disease underwent surgery, they were found to have weight loss. And then Mason did the first gastric bypass in 1967, which reduced the stomach capacity and digestion. However, since then, there have been more than 50 years, and there have been recent advancements in recent discovery of mechanisms in addition to restriction and or malabsorption. So first and foremost is the calorie restriction. Calorie restricted diet produces up to 40% improvement in the insulin resistance, even when we measure by the HOMA index as early as 2 days after the bariatric surgery, and improvement in the peripheral insulin resistance occurs at around 11 weeks post surgery. In perioperative period, the caloric intake is reduced to around 200 to 300 kilocalories per day, which is an important factor in the immediate weight loss as well as resolution of diabetes. 90 to 95% of the patients fail to lose weight by dietary restriction alone. So this specifies the need for bariatric surgery because the weight loss only by diet is rarely successful. I'll come to that mechanism in the next slide. And to conclude about the calorie restriction, it has an early role. Other factors are thought to be involved in the long-term weight loss and glycemic control improvement. So as we can see here, the morbidly obese patient can undergo dietary therapy or bariatric surgery. If he undergoes dietary therapy, then there is increased hunger and decreased satiety, which are homeostatic mechanisms to defend against the higher body weight. And when we compare to bariatric surgery, the same patient has decreased hunger and increased satiety, so there are no counteracting mechanisms for weight loss. And we, in studies, it has been seen that around 80% of weight regain after dietary measurements and weight loss after bariatric surgery, we all know. Now, coming to the changes in the eating behavior, it has been shown that there is predilection of lower fat foods after RYGB in human studies and after sleeve gastrectomy in rat studies. This cannot be explained only by mechanical restriction because Compensatory choice of calorie-dense foods would have been occurred if it was only the mechanical restriction which was playing a part. Altered taste acuity and hedonic craves for food in the post-RYGB patients. It has been seen that there has been 50% increased ability to detect sucrose post-RYGB, and there has been no change in the taste for sour or bitter foods. These findings have been validated by the functional MRI studies of RYGB patients who presented reduced activation of the mesolimbic reward areas, especially after high-calorie foods. Now coming to the major mechanisms for bariatric surgery, that is the changes in the gut hormones. Ingestion of food and nutrients results in alteration of gastrointestinal, endocrine and pancreatic secretions, enteroinsular axis. Gut hormone changes precede and are independent from weight loss, and these changes are sustained up to 10 years post-operatively. GLP-1, ghrelin, oxyntomodulin, PYY, CCK are the major hormones which play a role. Adaptation and reprogramming of the intestinal glucose metabolism post-bariatric surgery is under the control of these hormones. So first coming to the glucagon-like peptide 1, GLP 17, 37 and 36 are the active forms. It is secreted by the L cells of the ileum and colon due to presence of nutrients in the distal ileum, which is also part of the hindgut theory. So GLP-1 has various effects, including incretin effects, stimulation of beta cell growth, decreasing the apoptosis of beta cells, suppression of glucagon, decreased gastric emptying and intestinal motility, and also induction of satiety. So after sleeve gastrectomy, there is rapid gastric emptying, which results in faster delivery of nutrients into the distal bowel, which results in increased secretion of GLP-1, and after RYGB, nutrients directly enter the mid-jejunum from the small pouch via the gastrojejunostomy. I have put these two pictures just to correlate the gastrointestinal and the central nervous system pathways and how they are related. So this is the L cell which we can see, and on the basolateral surface it has various receptors for the hormones CCK, VIP, GRP, and including various receptors, importantly MC4R receptor. And on the luminal surface also there are various receptors, especially for the bile acids TGR5. So L cell secretes 4 hormones: GLP-1, polypeptide YY, oxyntomodulin and GLP-2. The presence of MC4R receptors on the L cell regulate the secretion of GLP-1 and polypeptide YY, and further in the central nervous system, binding of MC4R to MSH inhibits feeding. So this is the anorexigenic pathway which results in weight loss, and this is the orexigenic pathway which results in weight gain. And post-bariatric surgery, the feedback in this pathway is increased and the feedback in this pathway is decreased. Further interaction of neural and endocrine pathways. The GLP-1 receptors are found in hepatoportal region of liver and vagal sensory afferent neurons in the GA tract, and moreover in the nodose ganglion, which is just at the entrance of the cranial cavity. And these neurons project to the neurotractus solitarius of hypothalamus, arcuate and paraventricle nuclei, and GLP-1 may also directly act in the brain to regulate feeding behavior. This I already discussed, peptide tyrosine. It is expressed in the endocrine pancreas and reticular nucleus. It decreases gastric emptying, inhibits feeding and controls meal-related glycemia. After RYGB, polypeptide YY increases 20% in the fasting state and by 3.5-fold in the fed state. It also increases post-sleeve gastrectomy. And PYY gene knockout mice have poor weight loss as compared to the wild type. Oxyntomodulin is another hormone which is structurally similar to GLP-1 and has similar role as GLP-1, however less clinical significant as compared to GLP-1. Ghrelin is secreted by P and D1 cells of the fundus and the small intestine, mostly the duodenum. As the name suggests, growth hormone releasing peptide, it results in secretion of growth hormone, and it is an orexigenic hormone to the hypothalamus. It suppresses adiponectin. Adiponectin is an insulin sensitizing hormone. Its levels are decreased more after sleeve gastrectomy as compared to RYGB, because in sleeve gastrectomy there is resection of the fundus, which results in more decrease of the levels of ghrelin. However, in humans it plays a marginal role only in the weight loss. So what is the hindgut hypothesis, which I had touched upon? Caloric restriction is definitive but not the only factor for glycemic improvement. Rapid delivery of nutrients into the distal gut results in enhanced secretion of gut hormones such as GLP-1 and polypeptide YY. And this hypothesis has also been supported by the findings of ileal transposition, in which when the L-rich ileum is transpositioned in the proximal bowel, in those patients also we have seen that there is increase in GLP-1 response. There is also a foregut hypothesis. Bypass of the proximal small bowels, especially the duodenum, results in reduction of secretion of unknown gastrointestinal factors that decrease insulin secretion and promote insulin resistance. Duodenal exclusion could reduce the production of putative anti-incretins and increase of insulin secretion. This is also a mechanism for improvement of type 2 diabetes after RYGB. So these unknown gastrointestinal factors, gastric inhibitory peptide has been putatively one of those factors, but exact factors are still unknown. So in summary, these are the changes after both the procedures. Caloric restriction is there after both the procedures. Taste and smell changes, vagal nerve signaling I'll come to. Ghrelin is decreased more after sleeve gastrectomy. GLP-1 is increased more after RYGB, and it is increased after sleeve gastrectomy also. Similarly, PYY, oxyntomodulin. So coming to the adipokines, first is the leptin, which circulating leptin is secreted by white adipose tissue and gastric mucosa. It also crosses the blood-brain barrier and controls appetite and energy expenditure. In obese individuals, there is increased baseline concentration of leptin and levels decrease after weight loss. Reduction of leptin results in reduction of energy expenditure, and maintenance of weight loss by diet becomes challenging, and here comes the role of bariatric surgery, where there is reduction of leptin without any decrease in the energy expenditure. So coming to the energy expenditure, chronic caloric deprivation as observed after RYGB normally produces a decrease in resting energy expenditure. However, in studies it has seen that there is an increase in resting energy expenditure after RYGB, and this is a possible mechanism of weight loss. And studies on humans also have shown increases in resting energy expenditure after RYGB despite the use of VLCD. There is no definitive explanation for this phenomena. Hypothesis is that there is increase in small bowel mass, but that study was in rodents, so it cannot be extrapolated to humans. And in sleeve gastrectomy and gastric bandit, there is no change noted in resting metabolic energy requirements when we divide it by free fat mass. However, in sleeve gastrectomy, it has been seen that the resting metabolic energy requirement as a ratio of total body weight, that is increased. So in all, the energy expenditure is increased after any form of bariatric surgery. The limitation in these studies is that assessment is at different times after the food intake, so there is inconsistent reporting in these studies. So this was one of our studies which showed increase in GLP-1 and which were independent of weight loss. Adiponectin is an insulin sensitizing hormone. Its levels are found to increase after bariatric surgery, and similarly Omentin-1 also is an insulin sensitizing hormone, results in increase in HDL levels, and its levels are found to increase after bariatric surgery. Now coming to other mechanisms of weight loss, there is some role of vagal signaling. Vagal afferents are activated by presence of nutrients in the stomach and intestine. Preservation of vagal fibers during surgery results in greater and more sustained weight loss in animal models. The rapid entry of food from esophagus to alimentary limb via the small gastric pouch may trigger neural signals from the vagal afferents to nucleus tractus solitarius, parabranchial nucleus, and nucleus amygdala. And this has been postulated as a mechanism for long-term weight maintenance after RYGB. The studies have shown that there is no added benefit of adding a vagotomy in bariatric procedures. Moreover, there is a vagal remodeling, because in these procedures in RYGB the stomach is transitioned horizontally, which results in cutting off the vagal afferents, and in sleeve gastrectomy the stomach is cut more distally, so There's a difference in the vagal efferents which are cut post-surgery, both in RYGB and sleeve gastrectomy, and this altered signaling results in remodulation and neural signals which have increased satiety and decreased hunger post-surgery. Now, coming to the bile acids exert the mechanisms via 3 sites of action. First is the intestine. In intestine, there is activation of L cells via bile acid receptor TGR5 and FXR signaling. In liver, there is bile acids act via similar receptors and results in glycogen synthesis, inhibition of gluconeogenesis, and amelioration of insulin resistance. Further, they can cross the blood-brain barrier and act on FXR receptor in the hypothalamus and result in positive alterations of the feeding behavior and improve glucose tolerance. Levels are found to increase following RVGB and in animal models of sleeve gastrectomy. And in finally the intestinal microbiota, there are 2 prominent bacterial divisions, bacteroids and firmicutes. In obesity, there is a significantly higher level of firmicutes and lower level of bacteroids. And after bariatric surgery, the ratio has been found to be reversed. So, summarizing the mechanisms procedure-wise, in RYGB, it was initially designed for malabsorption, but now it is known that it is more of a restrictive procedure than being malabsorptive, and even serum albumin and fecal fat are rarely altered after RYGB. The key point is exclusion of duodenum and increased delivery of nutrients to the ileum. Other mechanisms which we have already discussed, GLP-1, polypeptide, YY, increased satiety, vagal stimulation, results in increased meal frequency, reduced meal size, altered preference for sweet food, and all these changes results in increased energy expenditure, changes in gut microbiota, and which results in weight loss. In gastric banding, there are 2 pathways. First is the vagal stimulation from the pouch, and second is the pouch pressure. These 2 pathways modulate the vagal signaling in the central nervous system, which results in reduced appetite, which is followed by reduced food intake, which results in weight loss. Glycemic control in banding is usually secondary to weight loss rather than any other weight loss independent mechanisms. In LSG, there is increased GLP-1 and polypeptide YY because of rapid gastric emptying and increased delivery of nutrients into the distal bowel. And also there are increased bile acids, which results in improved glucose homeostasis, and increased these incretin hormones results in improved satiety, reduced appetite, and reduced food intake. So which has a better weight loss, RYGB or LSG? There are 2 famous trials. SM-BOSS randomized clinical trial, which found that at 1, 3 and 5 years, the weight loss following sleeve versus bypass were 72 versus 76, and at 5 years 61 and 68%. And in the sleeve pass trial, recently 7-year results were reported, and the weight loss was 47% after LSG and 55% after RYGB. So there is a trend towards higher weight loss after RYGB, but the clinical significance of this is to be considered while choosing the procedure, while choosing any procedure for a patient. So finally, the weight loss seems only in part to be due to purely restrictive mechanisms. Hormonal changes stimulate anorexigenic pathways, increased insulin sensitivity due to caloric restriction, improved beta cell function due to enterohormones, and which results in improvement of glycemic status. Role of bile salts needs further elucidation. Thank you.
Thank you, Vitesh. Any questions from the audience? If there are none, then we can move to the next talk. Thank you.
So it's Professor Sudhir Kalhan, who is the chairman, Institute of Minimal Access Surgery at Gangaram Hospital, who's going to talk to us on bariatric to metabolic surgery.
Thank you so much. Professor Sandeep Agarwal told me to talk about the transition from bariatric to metabolic surgery. So I think it is very, very important that so it is, very important first that but we must kind of go through our experiences of bariatric surgery. So, my take on this would be, since it's a group of youngsters who are there in this hall, that whether it is bariatric or metabolic surgery, these two slides of caution for you, that weight loss is not a quick fix solution. Obesity is a lifestyle disorder that needs to change along with the surgery. The compliance of the patient is as important as the surgery itself. Weight regain is going to happen no matter whatever you do. So counsel the patient and relatives that the risk for surgery is higher than usual because of the comorbidity. So this is very, very important that we talk about bariatric and metabolic surgery. We must counsel the patient very well. Why? Because first, do no harm. Select your patient well, evaluate them thoroughly, counsel them very well, because bariatric or metabolic surgery can lead to long-term complications which can be life-threatening. So be very careful. Don't take them very lightly. Again, the Indian obese is different from the Caucasian obese. Why? Because we are having a metabolic syndrome at a lower BMI. Our total body fat is higher. The carbohydrate intake in our diet is higher. The fiber is low in our diet. We exercise very less. Alternate medicine use is high. So all these things make an Indian obese different from the Caucasian obese. And that is the reason that as early as February 2009, guidelines were, the Asia Pacific guidelines were introduced. And this consensus meet said that if you compare the Caucasian and the Asian Pacific population, then the recommendation of surgery were dropped by 2.5. That means that in the Asian population, you could do bariatric surgery for a patient who had 32.5 BMI with comorbidities. So this was the first significant thing which was done, which said that the Indian obese is different from his Caucasian counterpart. Now, what has happened in the last 2-3 decades? In India, the number of surgical procedures has gone up. In 2018, I was told that there was an 86% increase as compared to 2014. That means in 4 years, 82% increase in the number of bariatric procedures. And if you see these procedures, it has been gradual rise and it keeps on rising. And if you see the number of procedures, sleeve slowly, gradually high. OAGB suddenly taking a spurt in the last 4-5 years, and RYGB kind of remaining constant. So again, year-wise, if you see the procedures, the numbers are increasing. Now, whether it is bariatric or metabolic, how does surgery help? Surgery, broadly speaking, changes both the physics and the chemistry of the body. When we talk about physics, it restricts, sometimes it increases the gastric emptying, produces a little malabsorption, and chemistry means it changes the gut hormones. My previous speakers have been talking about the role of gut hormones, and broadly speaking, whether it is bariatric surgery or metabolic surgery, this is what is going to change, the physics and the chemistry of the body. Again, this is a very famous set point theory. That means every person has a set point. You and me will have a set point, and that depends on the baseline energy expenditure you do and the baseline energy intake. So that kind of tells you this is the basic, your set point. For example, if my set point is 28 BMI and I try and do dieting, I'll bring it down to 26. The moment I start eating, it'll come back to 28. So that is why people lose weight and again regain to that side. So unless I really overeat or take a lot of sweets, I will stick to my set point. And the only way of shifting this set point to the left side, that means to a lower BMI, is surgery. Because surgery will increase the basic energy intake, also baseline will be decreased, the energy expenditure will also be increased, and that will shift it to the left. So that is why the obesity surgery is changing the set point. Well, we all learned in our 2 decades or 2.5 decades of obesity surgery, bariatric surgery, was that the metabolic complications of obesity, diabetes, hypertension, all these things were getting resolved with bariatric surgery. So, all these then became targets for metabolic surgery. So, these comorbidity resolution, which my previous speakers have been talking in various studies, told us, can we use bariatric surgery or these procedures to just achieve metabolic endpoints. That means an anti-diabetic surgery or a surgery to resolve dyslipidemia. Well, then a lot of surgeries, a lot of trials came, and the important ones already have been discussed. The Stampede trial, which is the first trial which said that patients who have undergone a surgery for control of their glycemia did better than the medical arm. Again, on all aspects, whether it was HbA1c or BMI or overall, and that was the first study which significantly said that more diabetic patients achieve glycemic control following bariatric surgery. So that was the first initiation of metabolic surgery. Again, another study, Buchwald et al., Carlson, they did a study for following a patient for 15 years. And they found that the diabetic resolution was much better in the surgical arm as compared to the medical arm. So, what is metabolic syndrome? I think we have been discussing this. Now let's come to the effects of various peptides. I mean, I'll not repeat, already you have been told how the gut hormones are changing in the GI tract, in the pancreas, and how they are affecting the body. And these are the basic characteristics of enterohormones after bariatric surgery. If you see, GLP-1 goes up, GIP goes up, polypeptide YY goes up, ghrelin comes down, and these are the effect of the enterohormones after bariatric surgery. So now let's focus on metabolic surgery. Metabolic surgery changes various mechanisms of GI physiology and affect the metabolic regulation. And this is through gut hormones, through affecting the bile acids, changing the gut microbiota, and even the nutrient sensing. Again, we have talked about how specifically in diabetes, these multifactorial aspects help in bringing down immediate, within short term, the resolution of diabetes. So specifically now, metabolic surgery. So metabolic surgery by definition means operative manipulation of a normal organ or an organ system to achieve a biological result for health gain. Any health gain, whether it is diabetes or OSA, but where the primary target, now that's how it's different from bariatric, the primary target is not weight loss. Weight loss might occur, but the primary goal is not weight loss, the primary goal is resolution of the metabolic syndrome. So the term metabolic surgery has emerged from the recognition from our bariatric experience that mechanism of action of bariatric surgery beyond weight loss. That means not only weight loss, but beyond weight loss, certain chemical changings, certain hormonal changings are acting in the body, which are improving the metabolic component. But at the present time, do we have enough evidence, level 1 evidence? No. We still have supportive evidence. We still have our large clinical experiences from the bariatric surgery studies, and metabolic surgery per se, as metabolic surgery, we still have experimental data, and they still cannot be validated for, please can you just slow down? So again, I'm not going to talk about the foregut hypothesis. We already discussed the foregut and the hindgut hypothesis. I mean, so now the first change which happened, Ravinder, please. The first change was the Diabetic Surgery Summit 2, in which clearly they understood that BMI cannot be the controlling factor. They said that it's not necessary that only 40 or 35 BMI patients who did not respond too well to diabetic medical management should be considered for metabolic surgery. So that was the first thing, and that said that surgery could be considered as a tool to achieve better type 2 diabetes control even in patients with class 1 obesity. So I think that was a breakthrough. The Diabetic 2 Summit was a breakthrough which said, yes, surgery could be considered. And again, they have multiple studies, gastrointestinal effects, glycemia control, on lipid metabolism. My previous speakers have already controlled and told you how it controls cholesterol, LDL, triglyceride, improves the HDL. Again, how BPD is a better tool for controlling dyslipidemia, how it's controlling hypertension, how it's, really resolving the OSA and the PCOS. Now there is some gynae recommendations that the role of metabolic surgery in less obese females with PCOS is an area that needs further research. They said, yes, certain girls in the younger age group who have PCOS, have infertility, can we think of doing some surgery, predominantly as a metabolic surgery to resolve this? So these are, things which are coming. Again, cardiovascular and overall mortality, we have already discussed. So if you see the current available randomized controlled trials comparing metabolic surgery to other medical managements, it clearly shows that surgery in terms of type 2 remissions, HbA1c, excess weight loss, all these parameters is scoring over the medical management. Now a quick word on the gut microbiota. I mean, this has again come up in a very big way, especially in the experimental models, and that says that these are diseases of the gut, and the gut microbiota are actually controlling our overall milieu, the hormonal milieu, and some kind of dysbiosis is happening, which is leading to the weight gain and other problems. So, this is the famous study was very exciting, and in which they compared genetic obesity and dietary obesity, and they found that in both the age groups, both the groups, the vermiculites were in the people who were obese, especially the rats. They found that the vermiculites were high and the bacteroids were less, and whenever they did this surgery, the reversal was happening. So they concluded that the gut microbiota were controlling inflammatory signals, they were controlling adiposity, bile acids, GLP-1 and the energy expenditure. So they said gut microbiota is playing a very important role. So now there is this very famous experiment which had this thing, and what they did was that they took a rat, it did an RYGB, they took a sham rat, mice, and what they did was that the mice which had lost weight after RYGB, they started feeding this normal mice with the fecal matter of the mice, and this healthy mice started losing weight. So this is what happened, that even when this mice was overfed, once he was feeding on the gut microbiota of the RYGB mice, it was losing weight. So that led to the theory that yes, the gut microbiota are also playing a very, very important role. And this basically led to purely metabolic procedures come up, and one of the very important and very popular was ileal transposition. Now ileal transposition, if you talk about ileal transposition as purely metabolic, that just involved a transposition of a piece of ileum into the proximal jejunum, and that led to increase in GLP-1, polypeptide YY and bile acids and so many other things. And then later ileal transposition was combined with sleeve gastrectomy, and they said yes, we will have weight loss also, and then we have better resolution of metabolic. But then this is a difficult procedure, cannot be performed by everybody, and does have comorbidities. So this is basically a summary of the purely, I would say, the upcoming planned metabolic procedures. This includes diverted sleeve gastrectomy with ileal transposition. It has sleeve gastrectomy with ileal transposition. It also has duodenal jejunal bypasses, minimal gastric dissection. All these are all procedures now people which are doing only purely as a metabolic procedure, and the results are very encouraging, but we still don't have a grade A recommendation for using these procedures. Also, some of the endoscopic procedures can also be used for purely metabolic gains on resolving the metabolic problems. And the first recommendation which all of us can quote, or all of us can take a breather from, is the IFSO APC consensus statement of 2011, which clearly said that in the Asian candidates who have inadequately controlled type 2 diabetes and a BMI above 27.5 can be considered for purely metabolic surgery. And these are the procedures which I have already told you. These are the ones which can be used for. Again, the APMBS 2018 survey also strongly said that we should not be just blind to medical management, and patients who are not medically controlled, its time has come when you must think of a metabolic procedure to help them and for better control of the procedures. And at present, this is the recommendation from Southeast Asia, that 37.5 or 32.5 with comorbidities for bariatric surgery, and for metabolic surgery 27.5 BMI is the recommendation. But again, if you see, while bariatric surgery is covered in the insurance, metabolic surgery is still not covered with insurance. So again, a word of caution. We are very hopeful that in the IFSO 2021, which is coming in a few days, we might have a more consensus statement on metabolic surgery. We expect to touch that aspect. Until that time, I think let us be positive about metabolic surgery. And lastly, concluding with the slide that, metabolic, bariatric, all these things, surgeries, they require a big team, a team involving psychologists, physiologists, cardiologists, anesthetists, and it takes a lot of good team to actually be what I call as fat fighters. Together you have to go and address this multifactorial problem, and that is the only way we can take care of it. This is our team at Gangaram Hospital. Thank you so much. I think I was at time.
This excellent perspective on metabolic surgery. The house is open for questions.
Thank you, sir. Very differentiation between bariatric and metabolic, and it was quite justified and thought. But my thought is, when we are thinking only to do if a 27.5 BMI, we are doing a metabolic procedure, do you think we have to do any of the newer procedure of metabolic, or even procedure which are pertaining now as sleeve bypass? Because bypass, you've said it's just not a malabsorptive procedure, which I've been getting it. So what is the thought when a person has to do it on 27.5 and above? What procedure he should select when he's doing just for a metabolic reason?
See, you are right that can we do a sleeve at 27.5 or an RYGB at, but these procedures which we are talking about, the ileal transposition, these are procedures which they say are independent of weight loss. Now in sleeve or RYGB, we are achieving metabolic resolution through weight loss. So the newer procedures are saying that the weight loss might not be as much, the metabolic component is much more. So that is the evolution of metabolic procedures, where they say that it is going to be weight independent. The weight loss is not our primary goal. Our primary goal is the resolution of it. So I think still it's a very experimental phase. We are still not sure. The results are still not out. Lot of caution. There is no grade 1 recommendation. And still, most of us will stick with the gold standards. The RYGBs and the sleeves and the OAGBs.
Yeah, but I feel that whatever I'm gathering from the literature today, recent, if you're doing a metabolic procedure for anything, and the procedure has to be simple also for any young person to start, MGB is coming in a better way as compared to the other sleeve and bypass for metabolic.
See, again, if you we have our own opinions on MGB. First of all, I feel that MGB is a procedure which can be malabsorptive, and it has a very variable malabsorptive. There is no prediction on the amount of malabsorption an MGB is going to produce. And if you produce a malabsorption in a 27.5 BMI patient, it can create a lot of havoc. And you will not be able to defend yourself.
If I may, Ashish, I think Dr. Kalan is extremely right in saying that most of the novel procedures that he has mentioned are still in the ambit of a trial.
Absolutely.
They are not accepted to be used in your practice as standard practice procedures. So this is one thing you have to be very clear about. Currently, the metabolic procedures which are recommended, accepted, and legally right are the standard procedures such as sleeve gastrectomy, gastric bypass, BPD, duodenal switch. As far as OAGB or MGB is concerned, again, that is a procedure which is rapidly gaining popularity as a weight loss procedure, but it is primarily a malabsorptive procedure, and its acceptance as a metabolic procedure is yet not through. So that will also be considered as a trial procedure for metabolic surgery.
See, Vandana, that is why my second slide in the presentation today was primum non nocere, first do no harm. These bariatric and metabolic procedures can be very life devastating, and all of us sitting in this hall who have done bariatric surgery for the last 2-3 decades, we know that some of them have produced life-threatening, life-altering complications, and they should not be taken lightly.
So I have a question. So what is the status of ileal interposition, which is purely a metabolic procedure for load? Still a trial? It's not. But lot of surgeons in India.
No. You cannot do ileal transposition. You cannot do ileal transposition without taking a clearance from the ethics committee, and it is still in an experimental phase.
I think a brilliant lecture. Really loved your talk. I mean, covered everything very nicely and clarified what metabolic surgery is. And I would agree with Vandana and Dr. Kallan that all the those procedures which are meant for metabolic surgery are in actually evolution stage, let's put it that way. And the only procedures we're allowed to do is sleeve gastrectomy, OAGB and RYGB as metabolic procedures also. And I must tell you that even these procedures are very effective.
Yes.
You know, if you do a sleeve in a BMI of 30 with diabetes, and we have recently published 5-year results, are extremely effective in terms of metabolic control. Okay, so the point is the normal weight people, like, these procedures may not be effective because it requires some amount of excess weight for the metabolic effect to occur, besides the hormonal effect. So for a normal weight, we have to wait for those novel procedures to become standard. But as of now, only standard bariatric procedures can be used as metabolic procedures, period.
Yes, Sandeep, this hall is full of youngsters.
Yeah, that's what
They should not go back with a message that they can saying that this new company which has come, which is giving a lot of advertisement, get diabetes surgery done. The surgical, the one which is.
So that was my
So
contention.
bariatric surgery is simple, 3 procedures.
Yeah.
Okay.
So that was my.
Prestige Healthcare will come up with advertisements. Diabetes
So
surgery.
that was my contention,
don't do
that when we are talking about the procedures, and they saw the metabolic procedures coming, there was a row of all metabolic procedures, but still to date, only 3 procedure holds. That was I wanted to enlighten that these are the metabolic procedure, and people will think that 27.5, we have to do only these. We can't do a sleeve, we can't do a bypass, or we can't do an MGB. But for MGB with a limited experience, people had a lot of problems when they were going beyond 250, 300, and they were not seeing the junction. But it is a low limb length which is causing very good results now. They have shown a lot of series like that. So the limb length is very important in MGB, which has to be considered. Okay, so there's a change, and I invite Dr. Vanna, and we have been colleagues for like 25 years, and she is the director of minimal access bariatric endoscopic surgery at Max Saket, Delhi. Very accomplished surgeon, and most of the surgery they just do gastric bypass. So she will really enlighten us to some more values about ethics related to this and ethics in bariatric surgery. Vanna, please.
Thank you, Dr. Ashish, for that kind introduction, and thank you, Dr. Sandeep, for inviting me to this BARIME, and always so wonderful to meet with the young surgeons, young upcoming surgeons, and glad to see the large numbers which are present here to learn more about bariatric surgery. So the topic that I've been given can, in a way, well, it's a little dry, but at the same time it's extremely relevant, and is something that you will always carry with you. In fact, this last lecture that I heard, I could think of so many things in this. Even the last discussion that was there between which is the right procedure, which are the procedures which should be done. Again, what comes into play is the ethics. So what do you understand by ethics? Ethics as such is a moral code of conduct. It defines how you are to behave. So it comes from the Greek word ethik, and ethik means what your disposition is, what your character is, what sort of customs and habits that you normally display. So it comes from that, and ethics per se in our normal lives helps us to deal with difficult situations and how well we can handle them. And a person with the right ethics and good moral values will be able to face any difficult situation and can only rise in life. So it adds the value dimension to our behavior and decision making. So why is ethics important in medicine? In medicines we deal with human lives, and I think it's one of the arms or branches of science where nothing can be more relevant than the practice of good ethics. So it deals with the moral issues. It deals with the physician-patient relationship, maintaining the dignity, the self-respect, the confidentiality, the honesty in the relationship. It deals with the relationship between colleagues, to respect and uphold the dignity of your colleague. And of course, it also helps this physician to recognize what are the difficult situations and helps in them dealing with it. So there are 5 principles of ethics in medicine. And to simplify it and help you remember it, remember A, B, C, D, E. Where A stands for autonomy, B for beneficence, C for confidentiality, D, do no harm, and E for justice or equity. And how will you define it? Autonomy is when you inform the patient adequately, when you carry the patient with you in managing the patient is as much in knowledge of the disease which is being treated and is able to take informed autonomous decisions. That is good ethical practice. Beneficence, again, always act in the best interest of the patient. It may not be the right thing also, right means legally right thing to do. But if you keep the patient's best interest in mind, it will also serve your self-interest. Confidentiality, don't be casual. Don't casually mention about either the behavior of or any irrelevant information about your patient or information about your colleague. So confidentiality applies in both aspects. Do no harm. I think this has already been discussed. First and foremost, do no harm. Always keep the benefit of the patient above everything else. And justice. What do you mean by justice? I think AIIMS is just. There is a fair and equal distribution of resources. AIIMS will not differentiate whether the person is coming, which strata of society the patient is coming from. Unfortunately, the same does not hold true because medicine today is also being practiced in commercial institutions where you have to shell out a certain cost. So honestly, it cannot, but still in those institutions also there are philanthropic arms where there is an attempt to provide medical services to all strata of society. So yes, keeping institutions like this premier institutions at par, which this is, but also other government-run institutions at par in delivering medical healthcare services is good ethical practice. The other second thing about equity and justice, which is important, is to have a fairly equitable share of burden as well as the benefits of any novel procedures. So it should not be that any novel drug, new drug which has come into the market or which is being tried, is tried as a trial on those who cannot afford anything better before it is open to others. That trial should be clear, announced, advertised, so that each and every strata or person from every strata of society contributes in the burden of the trial and then enjoys the benefits of whatever the outcomes are. So ethics in medicine, I think Hippocratic Oath, we are all aware of. It is what we take, all of us have taken at the time of our convocation. And it came into being from the 5th century BC. Subsequently, medicine, the practice has changed. Also, you can say advantages or the malpractices which probably flourished, especially seen during the world wars. I think we are all aware of the brutal and horrific experiments which were carried out in the concentration camps. So to protect humans from such acts came the other codes of conduct, such as the Nuremberg Code and the Declaration of Geneva, which came in 1948, immediately post the war period. Then was the Universal Declaration of Human Rights, which provided certain rights which I think a lot of us in democratic world will enjoy well. And then finally for us, in the Indian Medical Council regulation came around 2002. Now coming to ethics in bariatric surgery. Remember, I think if you look back through all the lectures you've attended so far, there must have been questions which have arisen in your mind as to what is right, what is not. Every question which is discussed on the floor is again, which is the right procedure, what is to be done, who is the right patient. So obesity per se is just a few decades old, as it recognized as a disease. So obesity was actually considered a sin for the longest time. I think if you read the Bible, obesity or sloth is considered a sin. All right? Recognizing it as a lifestyle disease, just like diabetes has come very recently. So even the fact that it is a disease of epidemic proportions was probably declared by WHO just about 2 decades back. So the NICE guidelines telling us who are the patients to be selected also have come just in 91, 2 decades back. So before that, who was deciding? And how was it being decided? Again, it was your medical ethics which made you decide, okay, this is the patient I can benefit. So I must operate on this patient. And there were surgeons in that period, in 1954 when it started, who fought the medical community. A lot of them were bad-mouthed, a lot of them were, boycotted for this. But it was their own belief that what they were doing was in the best interest of the patient, so it survived. The first society was the National Obesity Society, more for conservative or the medical management, which came up in 1950, but by 1961 the American Society of Bariatrics formed, and then the Surgical Society came out on its own at the same time. The Obesity and Metabolic Surgical Society was formed in 2002. We kind of caught on later. Again, that is something you are familiar with, because ours is a developing country, and because majority of malnutrition out here is undernutrition, the obesity gets diluted. So in a patient population of 1.3 billion, if 5% are obese, we don't see them. But that 5% in sheer numbers is much more than the total obese population in America. But because in America 1/3 of the population is obese, it shows. So the awareness came earlier. Here the awareness has come later, but it has come anyway. So ethical guidelines in OSID, they provide a broad framework for the practicing bariatric surgeon, and it helps us in determining what should and should not be done as compared to what can and cannot be done. That means it differentiates ethics from the legal know-how. It is covered under 14 headings. Okay, this can be very, very, let's skip all that. So all these are the ones basically, again, how you conduct with the patients, with your colleagues, with the insurance companies, with the companies who are providing you with the products, professional companies, how do you maintain your data, how do you conduct your novel procedures, how are you managing complications, your own vis-a-vis complications of another surgeon. It covers all those things one by one. It is available, you can go read it up and do everything. But briefly I'll tell you that, remember, all actions by the bariatric team should be in the best interest of the patient. Always choose the right or the appropriate patient. Okay, resist temptation in the beginning. Over a period of time, you will be able to take those risks when you are confident that yes, you will be able to benefit the patient. But initially, follow the guidelines, what are there, choose the appropriate patient, choose the appropriate procedure. Just because you know one procedure doesn't mean that it should be applied to all patients. If a patient comes to know where you feel that yes, another procedure maybe you are not performing may do the patient well, it is safer to refer the patient. Remember, if you refer a patient to a colleague who's doing that procedure and the patient's outcome is better, next time he'll send another patient to you and not to that surgeon, because you have kept his or her interest in mind and the outcome has been good and he will trust your decision. All right, so informing the patient and patient counseling is extremely important. Was there a lecture on counseling? So patient counseling is so important. Remember, these patients, this is something you will realize over a period of time, that patient will only hear and register what they want to. That is why these days even, video counseling and all is going on to capture what you have told the patient, because they will just not remember. They will only register what they want. Okay, so counseling extremely important for the patient. Patient is able to take an informed decision. In this, just an example I'll tell you, patient we operated was a smoker, was told to stop smoking, did not smoke. 3 years later, came back with a perforated ulcer, again was explained the possibility, was managed, told that next time it happens, you're going to die, has got readmitted with a perf. So again, it's so important to counsel and tell the patient, and because you have documented, you are safe. Otherwise, they will turn around on you. And again, be sure of your competency level. Do what is best in your hands and manage and provide good services. Never malign a colleague. It will come back to you. If there is a complication, handle it. Make the patient understand that this possibility is always there. It can happen even with you, because tomorrow it can happen with you. There are complications, accepted complications, percentage of those complications which are documented in literature. You stand together and you treat the patient, it will all work out well. You badmouth anyone, it is all going to come back to you. So never malign a colleague. Handle the complication, talk to the colleague, tell them this is how I've managed, it will work out in the best interest of everyone. Maintain your records well, they will also help you, all right? And always, novel procedure, again, this has already been discussed, should always be in the ambit of a trial. Never falsify information, because that written record that you have, again, will put you in jeopardy. So, these are just some unethical behaviors. I don't think I have the time to do all these. I think that is more or less something that I have. Just one thing I'd like to say is special situations. There are certain special situations. One is children. So children, again, one of the primary roles of ethical practice is an informed or autonomous decision, which probably this group of patients can never take. So it becomes a big ethical question mark. So this is, and that is why I would like to, point out that probably every lecture must have talked about a multidisciplinary team. Now the point of a multidisciplinary team is just this, that when in doubt of whether the patient you are managing is the right patient or not, that is where the multidisciplinary team comes in. Because if there is a doubt in any one, it can be sorted out, worked out, and come to a proper best decision for the patient, which is ethical. So to conclude, I think the most important human endeavor is the striving for morality in our actions, our inner balance, and even our very existence depends upon it. And only in morality in our actions can we give beauty and dignity to this life. And remember, moral courage is sometimes higher and a rarer virtue than physical courage. Thank you so much.
Because I know you for the last 25 years, but I tell you, is such a presentation which really makes me so proud of what we routinely practice. And I feel so thankful to my teacher, Dr. Chaube, where I spent my 6 years with him 20 years back. And what he has taught us, the ethicality part, and it is such a wonderful feeling to hear it from Vanna, who has been associated with him for last almost 30 years. But it is very true. Just take it in your mind and heart. I don't know. So just take it in your mind and heart. I'm telling you what she has said. Real works in practice. If you do it, you will have no regrets. Thank you so much, Vandana.
Thank you.
Ma'am, I have one question. Ma'am, I have one question. Ma'am. Like, ma'am, as we know, there are different procedures with their pros and cons in the bariatric surgery. If given a choice, a surgeon can choose according to the guidelines and all these things. But many times the patients, they read a lot in the net and they come with a particular procedure like, I want to go for sleeve gastrectomy. And on the endoscopy, there is reflux, there is de-esophagitis or hiatus hernia. But he has read in the discussed with some other patients that there is malodorous flatus, which is very disturbing, increased motion, frequency of motion, patient do come. And they say, do the sleeve. What do you do then?
Again, this is where the first principle A, autonomy. So your intention should be to inform the patient. The patient has to know the pros and cons of it is not for you to take the decision. So the patient has come with a grade 2-3 esophagitis, has a hiatus hernia, has GERD, has come reading about sleeve gastrectomy, wants a sleeve gastrectomy. Your duty is to inform that doing a sleeve gastrectomy, these are the pros and cons. And doing this procedure, these are the pros and cons, so that the patient is on the same page. And the explanation and information should be provided in patient's language so they understand. And then the decision should be autonomous.
No, that is right, ma'am.
Yeah.
But the patient does not agree to this.
So you have to do a sleeve.
Should you go for sleeve knowing that it is not a right procedure for this patient?
Again, it is not your decision.
No, then why we should
Your decision or your ethical conduct.
Why we should not say no to the patient?
Then you are acting like God.
Dr. Phoebe, he told me one thing, we are not salesmen, we are surgeons. If the procedure is not right for that patient, if he is demanding that patient, you should have guts to say no to the patient. I will not do this procedure.
Hemang, medicine is such an imperfect science. Even sleeve improves GERD. I will not be so dogmatic. Unless it's absolutely grossly wrong. Patient of 28 BMI says, I want MGB, you can say, I won't do it. But a patient, between choice of two procedures, a patient says, I would agree with Vanna, absolutely, 100%. Patient says, end of counseling.
So the patient, yes.
I had a patient from London, 34 BMI, whatever, she wanted sleeve, bypass. We said, you don't require it.
You can modify the sleeve, you can do a hiatus repair, you can do a fundo with the sleeve, you can modify it. But you can still give him a sleeve, no? There's no issue.
Something grossly wrong.
Yeah.
See,
modify a sleeve and give him. You can repair the hiatus.
This patient who is a smoker underwent a bypass. He was counseled. It is documented. He was told that smoking may cause marginal ulcers. He can perforate. He didn't stop. He came with a perforation. Again, everything was told. He's come with a reperforation. So can you say that, no, I will not do?
If the patient says, you do it on me, I am taking the risk for perforation due to smoking.
That's exactly.
I will continue to smoke.
That is.
Do the surgery. So what should be done then?
No, if he says that he will continue to smoke, you refuse the surgery. That is. But this is not that patient is okay.
You cannot refuse the surgery. You can only guide the patient. Yes, over dinner. These are. But to keep your conscience clear, just make sure that you have informed the patient that sleeve has a higher risk of reflux, that the patient will require regular follow-up, but you are nobody to decide that, okay, for you I will only do bypass and for you I will only do sleeve. So that decision is autonomous and has to be taken by a well-informed patient.
Actually, I think we are also on the other side, and Dr. Sandeep will agree with me that whatever we explain to the patient, our patients are not very well read. And in the end, they say, Doctor Sahab, aapko jo theek lagta hai, aap wo kar do.
That's right.
So that is another spectrum which we see more commonly than a patient coming after reading and saying us that this is what we want to do. So maybe that is also not fulfilling the A criteria here.
So I think if you don't want to do sleeve in a certain patient, you can refuse. You can well refuse, and that is not illegal for you. But the patient will go to someone else and get the surgery done.
Let's have the last talk, please. Come on, we are absolutely wasting the part. You want to have the last talk, please?
Yes, for the last talk, we'll have Dr. Suvashish Bhattacharya, who's a plastic surgeon at All India Institute of Medical Sciences, and he'll talk about post-bariatric body contouring, post-weight loss body contouring.
I am Suvashish Das. So thank you for having me. So after the talk by all the fat fighters, so a fat sculpture or fat manager, you can say. So I don't fight with fat, but I manipulate them or sculpt them so that a better body can be seen. So what is body contouring is? So we do surgeries after post weight loss so that the body image or body contour restored to a normal rather than absolutely brilliant, or it's to a better view. So this is the plastic statistics of 2014 after post weight loss surgery. Now it is a demand that the post bariatric body contouring surgery is increasing day by day. So you can see from the infograph that the number of the percentage of body contouring surgery are going on. So what are the problem in a post weight loss patient? The problem is it is having a deflated appearance because the fat is gone, the overhanging skin is loose, and the skin doesn't retract. So in the upper trunk there is redundant flank and skin rolls are there, as well as in lower trunk there is pubic and groin rolls, and there is a overhanging pannus. So these are the extra skin they call stria and cellulite. So the problem begins like back stress, emotional distress, the patient cannot clothe properly. They also have body image. Like the sir has said with previous speakers, the body, the bariatric surgery brings physical and chemical change. But I want to emphasize that there is also a psychiatric change or psychological change. The patient doesn't perceive its body, the body image doesn't change usually in these patients. So there is uncomfortableness, there is skin breaks, ulcers, and they can reach the area, they can clean themselves. And they also have difficulty in work and mobility. So what body contouring surgery can bring is, it can change the self-esteem. What we perceive ourselves, what we perceive ourselves, our self-esteem, our body image, it can change. It can change your working, mobility, the patient can easily clothe, and also activity. But it is not without any complications. So like every surgery, some complications or cons are there. Infection, hematoma, these are all common things. So how we approach a patient of body contouring surgery? So before a patient, when the patient comes for this, I want to have a plastic surgery after the weight loss. So we ask the weight, whether the weight is stable or not. So you all know better than me that the post bariatric surgery, it takes time to get a stable weight. So usually 18 to 24 months we delay the surgery so that he can have a good or stable weight and he or she is not regaining weight again. these patients also have medical problems, though, so we include a cardiologist or pulmonologist. So ideally BMI 30 or less is a good way good, but lesser than that 25 is good for me to operate on. So here I want to emphasize that in every surgery we ask for consent, but in plastic surgery we are little paranoid about consent because the fear of litigations. So the patient will not ask you about the surgery. The most common question they will ask, will there be a scar? Kuch daag rahega? They ask. So problem is, no wound can heal without a scar. So you have to tell there will be a visible scar, but what we can do for you, we can minimize the scar, we can put the scar in such a way that it will be less visible. And you will not a perfect body. You will not become a model, you cannot become a Victoria's Secret model or something, but you will have an improved body shape. So, and another problematic thing is the scar will migrate over time. When the patient regain weight, there will be the scar migration, and the scar can break also. And in this patient, there will be a requirement of resurgery or touch-ups, nicks. So with all those things as well as the complication risk, you have to explain very well that what is the things are going on in the few days. So when you are counseling the patient, you have to tell what are the realistic goals, what you will achieve from the surgery, and it is not that drastic transformation will occur overnight magic. So it will be a staged procedure. You have to undergo staged procedure. Multiple surgeries might be required according to the need of the body habitus. And you have to tell what are the recovery time, what are the do and don'ts, like ma'am has said, she has suggested someone to do not smoke. So smoking, not cessation of smoking is very important also in these cases. So P for plastic surgery and P for photography. I cannot emphasize more. So there should be photography for documentation. There are different standard views for each surgeries. For breast lift, you have to take different standard views. For our lower body lift, you have to different standard views. For thigh lift, you have to take different standard views. So it should be with ring flash for facial photography, and 1 meter distance, we take a neutral background or green background without any jewelries. And you have to tell the patient that you have this asymmetry, you have this scar, this adhesive area beforehand, so that this should be documented in the consent itself. Because patient will say, Doctor Sahab, ye kya kar diya aapne? So you have to tell them beforehand this exists before. So this will remain after the surgery also. And I want to emphasize here that most of the patient of body contouring surgery, they fight inside in their mind. They want to regain that self-image of a beautiful body, but the problem lies here. Their expectation and the reality doesn't match, and that is the major cause of litigation. So when the litigation occurs, you have to, if somebody is not psychologically stable, in the court of law, somebody will ask whether the litigation is due to psychiatric problem or any psychological problem. So beforehand, you have to be very clear on that things. And the 4 most important principle that any body contouring surgery should be, it should be a staged procedure. You cannot combine all of the surgeries in a single package. So because I'll explain later why it shouldn't be done. There should be cessation of smoking 1 to 2 months before. The microvascular changes that occurs, it will necrose the flap. The flap will be gone and you will land in a trouble. There should be pre-operative nutritional planning, because you all know these patients have different nutritional requirement. They have vitamin B12, B6 and folic acid different deficiency, and no extreme makeover. You cannot do something that magic. There will be magic, but should be staged magic. So there comes the Pittsburgh evaluation scale. It's for the sake of fancy name. So this scale, what it does, there are different anatomical areas, 10 anatomical areas, and each anatomical area there have a grade. So grade 0 is no deformity, grade 2 mild deformity, grade 3 moderate deformity, and grade 3 severe deformity. So on the basis of, you can point out, figure out, and in the pre-operative evaluation chart, you evaluate this area need to be done. So this will give a whole idea what things to be approached, how to approach, and you discuss with the patient what bothering you most. So what are the options, different options we have? Surgical, yes. Non-surgical, yes, somewhat we have non-surgical also. So so when I talk about plastic surgery, people talk about liposuction, is it? So liposuction is not very useful in this patient because these patients already have a deflated skin. The fat is not the problem here. The redundant skin is the problem here. So liposuction may not be effective. So excisional procedure are effective. So we cut and stitch, but it is not that easy like a tailor. So there are different options, like for arm, we do arm lift, for lower body lift, thigh lift, and tummy tuck. That is very, everybody is know about it. Similarly, there are for upper face, neck lift, face lift, breast lift, and we can also do combined lifts as well. So sorry, I couldn't have clinical picture because the past 2 years, the COVID, we couldn't follow up patients, so I couldn't bring the clinical pictures today. So in general, the body contouring, I have already explained. Patient need to be stabilized, they need to be motivated, non-smokers, and realistic goals. So what should one expect when the body contouring consultation starts? So we discuss what is the surgical goal here. The surgical goal is to primarily create a good body shape, so that patient will have a better psychological feeling or better feeling of self-body image. So like every surgery, medication, vitamins, and all medical history and previous surgical history we explain and discuss. And photograph, these are all we have covered. So what we ask regarding fitness and what surgery to do. So regarding what surgery to do, we'll cover next. And sometimes the patient, young patient, they ask for whether I want to get pregnant. So what is the indication of getting a body contouring surgery or plastic surgery? So those are tricky areas. So you have to tell the patient that if there is a midline scar or something like that, some procedure may not happen. So usual order, what surgery we do first? So lower body lifts, that is excessive skin, redundant skin around the belt area, that is belt lipectomy also called. So lower body lifts are done first. So after the lower body lifts, we cover the upper body lifts along with breast. So the axillary rolls, breast rolls, these are also included here. And lastly, thigh plasty. There are various combinations are here. The Brazilians do differently, Europeans do differently. But the important thing is you have to evaluate your patient clinically and see what the patient require. Indian patient, it is a whole different ball game. We don't, frankly speaking, the patient don't have, like other European country, they want to go out in the beach. So in Indian patient, that is a different scenario. Now safety measures, anesthesia concern. Like all bariatric patient, anesthesia concern is there. You have to position the patient properly so that nerve injury or ulcer injury shouldn't occur. For infection, these patients are prone to infection because of skin, previous skin breakage and all things. And most importantly, DVT, prophylaxis should be given. So these are the body contouring risk. So in conclusion, body contouring surgery gives a long lasting and good body image. Though there are recurrences, you need to touch up surgery, re-surgery can need in some patients, but overall it gives a satisfaction and improves the quality of life. Thank you.
Dr. Subhashish. Any questions on this talk?
I think it's an excellent talk and kept it very short and sweet, and for us, the basic principles. But let me say this, that majority of the patients do not require or do not want it. I think less than, between 5 to 10% patient would actually ask for it, and less than 5% would get it done. Because a lot of patients with good exercise can have a reasonably good skin turgor, and that's what I've experienced.
Massive weight loss patient, they usually, in Indian patient, mostly the most important is panas, the overhanging panas that prevent from walking comfortably. That's why in our patient, mostly panas and thigh plus.
Thank you.
Thank you, sir. This concludes our sessions for today. Thank you, esteemed dignitaries, faculty and delegates for your gracious presence. We now will be inviting you for dinner at the AIM Sports Complex.
Before you leave, you want to say something?
Yeah, we request to join us tomorrow at 8 a.m. Here only, at the same venue.
Yeah, just 30 seconds. This slide is about an London Bariatric Surgery Symposium. It's an online symposium on basically, this is basic, and if you want to now get interested in more advanced discussions, this is an online symposium. For BARIME delegates and faculty, it's free to join. They have a fee, but for us, they have, allowed us to be a part of it. So if you are interested, leave your email in the group or with Rachna, and we'll get you involved and send you the. So each email will be given a separate link. So nobody can join just like that because it's a paid course. So this is a really good with world-class faculty. You would name who's who in bariatric surgery will be there. So if any of you are interested, faculty, delegates, from BARIME, we have a free registration. Thank you. So now, all of us proceed for the dinner directly. So walking directly to the pool. Just come along with our people so they don't get lost. Okay, and tomorrow please try to make it in time. Don't have too much alcohol so that you don't get up. Okay. Good, very good. Sorry, I've been barging into your forehead repeatedly. Please take a bouquet there.
ऊपर से चेक करना है सो वो ऑप्शन में जा
Okay, thanks. We'll take the bouquet.
We'll take them.
Give one to her, give one to me. Good people here. Morning till evening, you are there. So thank you so much.
मैं दे दूँ फोटो खींचूँगी इन दोनों को दे दो एक फोटो खींच लो फोटो देना रोकना
हेलो अनुज ओटी अनुज
कौन से बीसी मत करो
अरे वो चला रखा उसने रिकॉर्डिंग चला रखी
हट हो गया चल
हेलो हेलो